Start. Okay.
The speakers.
So I can work proper. Is the camera is not here?
Yeah.
We can start.
Coming.
Okay. Yeah. All right. Yeah.
হ্যাঁ দেখো টাইমও আছে সবও আছে আপনি মুভ করবেন হচ্ছে
Check 1, 2. এটা আর একটু বাড়াই দিও হ্যাঁ
Congratulations again. Thank you very
Look.
much.
Thank you.
Check. Look.
Assalamu alaikum. Welcome to scientific session 2. It is the session of cervical degeneratives. Dr. Zakaria bin Jamjuri bin Zakaria Mahmood and Dr. Kazi Shamusa will chair the sessions.
Assalamualaikum warahmatullahi wabarakatuh. I think we are behind time. So I would like to invite Professor Mat Shalam, our president, so to deliver his talk on decision making in cervical disc prolapse.
Good morning, ladies and gentlemen. First of all, thanks to all participants, especially local and foreign faculties for attending our program. And your presence will glorify and it will be a successful congress. So my talk is on the decision making in cervical disc prolapse. So the history of the disc in the cervical disc in 1838 first was the herniated disc was identified by K. Subsequently, about 100 years after, then it was reported by two gentlemen, one is Mr. Bard and Mitchell, in 1934. So disc is composed of your avascular fibrocartilaginous structure and centrally nucleus pulposus, and the peripherally is annulus fibrosus, all of you know. So mostly the contents is the water and also type 1 and type 2 collagen fibers and proteoglycans. And the function of these intervertebral disc, all of you know, basically the shock absorbing activity, and also it absorbs that tensile and the compression force, and also the rotational forces that is absorbed by this intervertebral disc. So the disc herniation mostly in the man and also maybe in the female. But one of the important issues is the trauma, the cause, and also the cigarette smoking is one of the potentiating factors that leads to develop the disc herniation in cervical spine. Any disc can be herniated, but mostly in the lower cervical 5, 6, and 6, 7. And the clinical feature, all of you know, the neck pain along with the radiation in the arm or the forearm, or the motor weakness or clumsiness of the hands. Sometimes it is a mimic with the other symptoms like the cardiac problem or the vertebral artery compression. There are some special tests clinically to diagnose. It means the Sparlingia maneuver, the antilarmitis test, and the compression test, and also sometimes with the distraction test. These are the tests we can get some science to diagnose it clinically. And finally, it confirmed by radiology, X-ray, CT, MRI, and sometimes we do the myelogram. There is some classification about the location or hardness or softness of the disc. There are the 4 classification that was described by Odom. I am not going to details. So how to treat this disc, the herniation in the cervical spine? Mostly the non-operative treatment. You'll be happy to know 95% patient that needs only conservative approach, the rest, and the analgesics, exercise, and physical activity. So we can treat a maximum patient by non-operative procedure. So when you'll go for the surgical decision? So there's a lot of factors because the expectation of the patient and the outcome all the time not the equal. That's why we need to assess the patient thoroughly before going for surgical intervention. Even that when we are going to do surgery, when the non-surgical approach or management is failed, not improved, and then neurological deficit and is patient having with the cervical myelopathy, we plan for surgery. Most common surgeries in spine, cervical spine in the disc is the cervical foraminotomy, and anteriorly we do discectomy and fusion. But the selection criteria not always the static, the straightforward, because when patient associated with other pathology like degeneration, not all the time is straight-cut decision. When the soft disc and the lateral compressing the nerve, we can do posterior approach, but when the soft or hard, the disc in the central or medial, the middle side, definitely needs to approach anteriorly and fusion is needed. And bone graft or spacer helps to maintain the foraminal height and the disc height, and also it enhances to biological union. If the facilities have the minimal MIS, yes, it is a very accepted procedure, but all the time we cannot do. And also anterior cervical, the 3 procedures is mostly done, but nowadays the Smith and Robinson technique, maximum we adopted this technique, and we are habituated. And if we want to have the motion segment is a preservation, if arthroplasty is possible, we can do arthroplasty, but it is not very popular in our country. But cervical disc is sometimes a problem with a lot of degenerative changes. When the cord or roots are compressed, then the strategy of cervical spine, the surgical approach varies. So anterior surgery, when less than 3 level kyphosis, then we go for straight with the anterior surgery. But when more than 3 levels and say state or the lordotic curvature, then we do posterior surgery. But when patient having both anterior and posterior combined, then we need to global the decompression and stabilization. Anteriorly, mostly we do ACDF, SCCF. Posteriorly, we do decompression and instrumented fusion, and combinedly we do the anterior and posterior approach sometimes. So for an example, this is the Odom type 4, cervical 4, 5, 35 years old man. You can see the X-ray and MRI not improved, then we do just anterior surgery, ACDF, typical taking the bone graft from iliac test, and stabilization done, and you can see the before and after the X-ray. So when patient having with the more than 3 levels, and anterior surgery not advocated, then posterior surgery is done. This is the posterior instrumented fusion after doing laminectomy. But when the both anterior and posterior combined, we go for anterior and posterior global, the fusion. This is both anterior stabilization done by standalone case and posterior instrumented die by laminectomy and particular screw. Lateral massive screw. So 63 years old man having with the cervical disc along with the canal stenosis at the level of 3 and 4. Patient was not improved by conservative approach. We did surgery. Mostly the anterior surgery we did. So this is a standalone case. So in degenerative case, it's one of the good implants to stabilize and decompress. Sometimes the patient having with the adjacent segment degeneration. So this gentleman was operated, ACDF done in 2 levels, and 15 years back, he was fine. But subsequently this patient came with the symptoms, pain and the clumsiness of the hand. I did it 15 years back, and a few years after I removed the implants, you can see the good fusion and good stabilization and maintenance of the cervical lordotic curvature. But if you see the MRI, you see the above and below adjacent segment degeneration and compression of the cord. So how to do? The anterior or posterior already 2 level is fused. So we did anterior again the standalone cases in the 2 levels, and then we stabilized it. Subsequently, if you see this patient, initially when this patient video, so this is the before surgery, and this is the immediate post-op. Can you help anybody? Next. Okay. So you can compare the before and immediate after post-op and few weeks after surgery having with the, so 4 levels, all we did the anteriorly. So anterior surgery is possible sometimes, But say having the other patient, 70 years old man, JO score is a 12, kyphotic curve is straight, going to, developed the loss of the lordotic curvature. We did all 3 levels anterior surgery with standalone cases. And postoperative you have seen. So it is another case compression from both 4 levels involved in the anterior and we did, posterior. Then more than 4 levels we did the posterior surgery, the laminectomy and instrumented fusion. And the below level, the 6th level, we did the pedicular score. The other was the lateral muscle too. And if you compare this patient having with the good neurological function again, but no losing of any stability or neurological deficit. And this other patient having with the 6 years old severe DCM with a JOA score was a 12 and compression both from back and the in front and back having with the bulbar involvement. And this is a patient having with the quadriparesis. We did the global the decompression and stabilization. And this is a postoperative X-ray. And this is another patient had the 2 levels ACDF done, but he was fine. Subsequently, this patient came with a history of fall 3 days back, and he developed the pain and the weakness. Patient couldn't walk. This is immediately, before doing another surgery. And this patient, if you see that this is so we did the surgery the posteriorly, and subsequently, if you see, this is a patient that regained the neurology. Hey, back karo to back karo jai, back slide to the. So just video on video is not. So I like to conclude the session that before going to surgery in a cervical spine, thorough the selection of the patient is most important because and the counseling with the patient, because every center doesn't have the same facilities and the patient expectation is very high. So all the time in all centers it is not possible. So prior to going for surgical intervention, prior to doing any procedure, who is the procedure to and what is the expectation of the patient and how far we will be able to give the patient, we need to compromise or coincide. Thank you for your kind attention. Thank you very much.
Any questions? I think we have the questions after the session is after the last talk. So next I invite Dr. Faizul Hassan to give his talk on surgery in cervical spondylotic myelopathy. What, when and when not. May I request Dr. Shalam to please
go back. Good morning again. It's me again, Mr. Hassan from Royal Orthopedic Hospital. Can I go to the first slide, please? Okay, so this topic is cervical myelopathy on this occasion, which is, again, is quite a common topic for any spine surgeon. And we all know the definition and the incidence, which is more common, especially in the older male people. We know all the common signs of cervical myelopathy. Those are the very common signs, but there is a weird and wonderful signs of cervical myelopathy, and we'll come into that later on. So incidence, there is no reliable data on incidence, but the most important thing is the progression of the disease. We all know there is a varied progression of cervical myelopathy. Some of them are quite steep, some of them in a step ladder fashion, and some of the patient may remain stable for quite a bit of longer period. The question is when to operate on this patient. So here are some MRI scans all done in our hospital, and you can see various pathology and multi-level cord compression, and will come into those patients. So my question to the audience or to any spine surgeon, if you see a patient with significant cord compression but not much of myelopathic symptoms, what we call a pre-myelopathic patient, will we operate on those patients? Should we leave it alone, or we should intervene? It is quite a common, hotly debated issues among the spine surgeons. There's various papers published regarding that matter. In Cato in 2012, only 5% patient who have a proven MRI cord compression, and then Wilson in 2013 is that almost 23rd of the patient, they progress in their system in their symptoms in 4 years' time. And there is also is a bog standard, but a well-known paper that majority of the patient with mild symptoms, despite having a significant cord compression, can be treated with conservative management. But there was a systematic review by the clinical spine surgery, but their finding is quite interesting, that the surgical intervention should be considered to avoid any neurological deficit. So they have suggested for surgical intervention, despite not much of symptoms, but evidence of cord compression on the imaging modality. The question is, the answer we in fact all know, the thorough history and examination, most important thing. Look for any subtle myelopathic signs and inform the patient regarding the natural history of the myelopathy, and there is a chance of progression. And it is most important thing is shared decision making. If the patient doesn't have any significant signs of myelopathy but evidence of cord compression, you have to disclose the symptoms and the progression to the patient, and you have to make a decision together. So now how to operate? Again, we can go from the anteriorly, we can go from posteriorly, or occasionally we need to combine both anterior and posteriorly. So here are the few patients operated in our hospital, ACDF with a cage and corpectomy of various kind of corpectomy cage. ACDF, again, is the bog standard procedure, and there's various data has showed there's no advantage of putting a plate. Either you can use a standalone cage or a cage with a screw fixation. The outcome is almost very similar between those two groups. Standalone cage has got a better clinical outcome and a less adjacent segment disease. But if you use a plate, the subsidence rate is raised, but the restoration of cervical lordosis is definitely better if you put an anterior plate on. And OPLL, it is one of the most hotly debated topic regarding surgery in the OPLL. In UK, we don't see that much of OPLL than what been described in the literature in Japan or in the Asia Pacific region. There is a big study by the Chinese group regarding outcome of the both anterior and posterior surgery in OPLL, and we all know about the K line. So what they have suggested that if the canal occupancy ratio is more than 50%, and if the K line is negative, they have suggested anterior surgery. But if the occupancy is less than 50% and the K line is positive, you can go either anterior or posterior. Here are the few examples of OPLL operated in our center. Personally, I would like to go from anteriorly, and I prefer anterior surgery. And all of them had anterior surgery, and one of the patients also required posterior decompression fusion in a later stage. Again, another debated topic, if you go posterior decompression, whether the patient will require instrumented fixation or not. There is a topic that because of the OPLL, the patient is already fused anteriorly. So there is an argument there is no point of doing a posterior fusion in a patient with an OPLL. If you do surgery OPLL without any fusion, only laminectomy, the short-term outcome is similar to between the fusion and the non-fusion term, but the slightly worse long-term outcome in the laminectomy people, because there is a tendency of kyphosis, especially the focal kyphosis in those patient group. But again, you have to remember that one, the radiological correlation doesn't transfer into the clinical presentation. Even patient may have some focal deformity, but the patient may not present with features of cord compression or any myelopathic features. So in this patient, we've got a long segment of OPLL and we have done posterior decompression with instrumented fusion. One of the most, again, an emerging modality of neurophysiology in the treatment of or the diagnosis of cervical myelopathy. The various paper has suggested that 3 groups of cervical myelopathy patient. One who has got a florid cord compression but no symptoms. One who has got cord compression and symptoms. The other group who doesn't have any cord compression but the features of cervical myelopathic feature. In those scenarios, various neurophysiological tests has been implemented, especially MAP and SSAP, to distinguish between the other neurological disorder which may mimic cervical myelopathy. It's still an open topic and there's many areas to debate. What are the best treatment modalities of cervical myelopathy patient? But the most important thing is patient selection. The patient should be aware what they're signing up to, and in my belief, if the patient is non-symptomatic, despite cord compression and signal changes, we should leave the patient alone and observe and follow them. If there's any signs of deterioration, we can intervene in the earliest convenience time. Thank you.
Dr. Fazil Hassan, please take a certificate of appreciation on behalf of BSS.
Now the session is open for question and answers.
Hello.
Any questions?
My question to Dr. Faizul is, hi Dr. Faizul, this is Dr. Basu from Kolkata. So my question to you is, do you find neuromonitoring helpful in cases of cervical myelopathy? And how often do you use them? And is it mandatory in your practice to use neuromonitoring for these cases?
Thank you for your question. I don't personally use neuromonitoring for cervical myelopathy patients, even for anterior posterior surgery. But one of my colleagues, he routinely uses even for ACTF, he uses monitoring. So I think that is an extreme one, and that should be a middle ground. But personally, I don't use neuromonitoring for myelopathy patients.
So like what benefit does he get from using it?
Personally, I don't think there is any significant benefit for using neuromonitoring. That's why I don't use that one. But one of my colleagues, he used the right. MAP and SSAP. And if there's any drop of those signals, he becomes cautious, what he explained. But right. To my view, that the cord needs decompression and you have to go ahead and decompress the cord. No point of stopping at the middle of the operation if you lost monitoring during the right. surgery.
So you have to complete the procedure anyway.
Yes.
Hello. Dr. Fazil, hello, listen to me.
Hello,
I
sir.
have one question to you that you have shown in a non-symptomatic spinal cord compression or asymptomatic spinal cord compression in cervical myelopathy. If you declared as a cervical myelopathy without any symptoms or without any motor deficit or sensory deficit, can it be happen that myelopathy without any symptoms, or can it be called it asymptomatic? This one question. But another one is, if it is asymptomatic cord compression without myelopathy, in which situation you go for the surgical intervention and when you ignore this surgical intervention?
Again, the clinical features of myelopathy is so varied. So, we know that they don't present with any motor deficit. They might have some hyperreflexia and other signs. But again, you might have some subtle signs of myelopathy and having cord compression. But if that compression or the symptoms is affecting his daily life and activity, he might have some numbness in the hand, but he's coping with his symptoms and he's maintaining his normal life, he's working and everything. So what's the point of intervening at that patient? If the symptom progress and which is affecting his daily life or activities, or there's a progression of symptoms, then is the best time to intervene.
But there is on international data that if you find such like a patient, that you may do the dynamic X-ray and MRI as well. And if there is impinging further to the cord, or even there is impinging from the back or even front, then it's another indication for the surgical intervention.
I agree with that one, but that is the group of patient in the third category who has got signs of myelopathy but no significant cord compression. In those patients, definitely we go for dynamic X-ray and occasional dynamic MRI scan to see, though a lying or a supine MRI is not showing any compression, any instability and causing the cord compression. But again, if that is negative, then leave those patients alone or find other neurological cause of his symptoms.
Okay, thank you for your answer. But I have a question from Secretary General to President of Bangladesh Spine Society.
I think we're
sir,
running short of time.
You have shown that one of your cases, the compression from the back, and we did the laminectomy, wide laminectomy, and do the lateral mass fusion and fixation, as well as C7 pedicle screw, perhaps I have seen. But the lordosis not maintained in cervical spine with this fixation device. So without any maintenance or without any circumferential cord compression in whole over, is it sufficient to be laminectomy and lateral mass fusion and fixation for that cases?
I got your point. Thank you. Thing is that the existing lordosis that was, and before that, before planning for posterior laminectomy and instrumented fusion, we did your dynamic X-ray. So as in dynamic views shown that no instability, and that's why we didn't plan for anterior decompression or anterior stabilization. Posteriorly, we stabilized, and even after surgery, the good maintenance as before it was, so it was not due to losing of the lordotic curvature. I want to supplement one thing is that we need to study or read the MRI, and we need to read the patient. We'll treat the patient, not the MRI. Sometimes there is many patients, those are practicing, I think they will agree. In the MRI findings, sometimes coming without patient, if you see the MRI, you will see patient definitely will need surgery, immediate decompression, or patient will develop some neurological deficit. Whereas patient is okay. And it's reverse. Patient is having with, the neurological deficit or, the other signs, symptoms that needs to clinically to decompress and stabilization. But MRI showing not that much, the compression or the abdominal stenosis. That's why if the myelopathic sense, even that, yes, it is one of the important issues that it can progress. But if patient is good and no instability, to me not all the time requires the surgical decompression. But if you see that you having with the decompression, patient is progressing his symptoms, but in that case, I think the surgery is okay. Thank you.
Thank you, Professor Shalam. Since we are running short of time, sir, please, may I invite Muhammad Rizaul Kareem to present his case now.
Professor Kamran, there is one question from Professor Kamrul Hassan. He is a senior spine surgeon in our country.
We can have it.
My question to both the speakers. One speaker use implants is big case, standalone big case, and another speaker use titanium case, standalone titanium case. My questions to both of you: which implants is suitable for interbody fusion in regards to pseudoarthrosis or subsidence?
As long as you use the cages appropriately, it doesn't matter what type of cage you're using. But personally, in our center, we like big cages. And personally, I also like big cages. But various centers in UK, they use titanium implants. I don't think it doesn't matter as long as you do the job appropriately.
To me, the no implant is safe for the patient. So whatever is the titanium or case, you cannot have any guarantee that it will not, react. So yes, definitely the peak case is more preferable, but if they're having with the facilities, but to me, if the one level, two level, subsidence is there, but is a one or two level, if the possible, why not the start up? Still, though there is some chance to reduce the disk space, but to me, it enhances to biological union. Thank you.
I think, yes, we close the session now. Thank you very much. Next case by Dr. Rezul Karim, please.
Can I start? Honorable Mr. Chairman and Moderator, I am grateful to my teacher, Professor M. D. Shalom sir. From him I learned the spine surgery. So I will be talk on a case-based discussion about the patient suffering from cervical myelopathy with neurological deficit. The 45 years old male patient, his dollar came with weakness both upper and lower limb, neck pain and rigidity, and also trunk pain, clumsiness both lower limb and weakness in the walking. But he can walk with support, alone or support with other. On examination, sensory was intake, motor 4/5 from C5 to below, but distal part of the hand function was near 3/5. Hoffman sign was strongly positive. Knee, ankle jerk, and all the jerk, bicep jerk, tricep jerk are exaggerated. Ankle cronus present, but patient has bowel and bladder control. This is his X-ray. Looking only degenerative sense, there is no gross K line is normal, but if you view there is slight deviation from left to right. So I did the MRI. The pre-op MRI showing there is huge compression at the C5, C6 level, and also moderate compression C6, C7 level. This is only cervical disc prolapse or any other or OPLL. What is the solution? It is only huge disc prolapse. Myelopathy is due to for disc prolapse or OPLL. What is the solution? So I did the CT. CT is shown there is segmental OPLL. So the OPLL. The patient is suffering from neurological deficit, weakness, all spasticity, gait disturbance. So it was a case of segmental OPLL at C6, C7 and part of the back of the C6 and with myelopathy. What to do? If patient, though patient is a neurological deficit, so I think no way to manage conservatively. It was a progressive. The neurological deficit was progressive. So I go for surgical management. And question is anterior or posterior? Anterior ACDF or ACCF? Posterior laminotomy or lateral mass fixation or laminoplasty or fixation, plate fixation. What I did, there is some evidence about anterior surgery. Pfizer already shown. Anterior surgery is associated with the superior outcome when OPLL occupies 50% to 60% of the canal, already mentioned by Faisal, despite increased technical difficulty and higher complication rate. Another article, they also show the anterior decompression and also posterior. There is a debate. But I did another article for anterior surgery, another article for posterior surgery. Posterior laminoplasty alone is safe and effective for treating severe cervical posterior longitudinal ligament, that is OPLL. All parameter was normal. So I did anterior surgery, SCCF C6 and fusion C5 to C7. A devastating outcome follow first POD. Patient wake up with complete paraplegia. Post-op MRI. Post-op MRI, there is a significant decompression of the cord. The CSF column is DAPR, both anterior and posterior. This is the post-op MRI. Looks like a decompression cord, but clinically it was bad, very bad indeed. Immediate after, I consult with another spine surgeon. He examined the patient. There is complete loss of sensory and motor. He explained it may be a spinal shock. So wait. But after 7 days, no improvement at all. So again, we made a medical board. They also gave the opinion. The canal is adequately decompressed. Conservative should be contemplated. The expert opinion they given. It is not a symbolic picture, not that patient. So after 6 months, some sensory is regained. Some sensory function, both upper and lower limb, regained. But not motor. Spastic paraparesis, MRC 2/5 upper limb, MRC lower limb 0/5. Bowel bladder uncontrolled. After 8 months, we did another MRI and CT. In MRI, looks there is some compression both anterior and posterior. No CSF column, both posterior and anterior. So another medical board has made, and my teacher was the leader of this medical board. What should done? Patient wants do again surgery. If surgery was done, I will recover from this weakness. So again we decide to do again redo surgery by posterior laminectomy and lateral mass fixation. But at 45 days of post-op, sensory as before, spasticity, right upper limb is slightly spasticity is reduced. No motor improvement, MRC gate as before. And what could be done? When could be done? How could be done?
Yes, from the panel.
Dr. Raj, again, the question comes from a colleague in Kolkata that whether a neuromonitoring will help you to warn that there is some ongoing damage to the spinal cord. So one of the things which I said I don't believe or don't use can be considered. The other thing is whether do you use high-speed drill to decompress during the corpectomy. If you don't use a high-speed drill during corpectomy, there is a good chance that you may compress the cord while you're trying to do the corpectomy. So the cord might have been damaged. Even though the reperfusion injury might be there, despite you doing the surgery meticulously, when the sudden decompression of the cord, because you can see there is some cord edema into the level, so that may the cause. So there's no right or wrong answer. But I think anterior surgery was the right thing to do.
I have some experience like this type of OPLL cases. The young man with he was able to walk, but he has the symptoms, all these things. The 3 level. I did the decompression internally and SCDF we done. Finally, the patient came out with this paraplegia. I was so worried about these things. That time we don't have this neuromonitoring as well. But we are scared, but we consoled the patient that may happen, maybe it would be all right. The patient was in the wheelchair bound. He went back to the house. After 15 days come for the further stitch removing. So he was also the paraplegic. But after a couple of months, the patient came with walking. It may happen due to the patient handling during surgery. The myelopathy patient, when you are doing positioning, you have to be very careful that during and after anesthesia, the positioning may harm the patient as well. At the same time, when you are doing the high-speed drill, as Dr. Faisal is mentioned, and other intervention when we are doing, cord may have the trauma, and that trauma may causes the permanent damage or the transient damage. So it depends on what type of trauma it happens.
Yeah, I mean, I am of the same opinion that if we use neuromonitoring, especially in these cases, so once you put in the leads and you position the patient, especially the hyperextension should be avoided. And the second thing is you have to use a microscope and a high-speed drill. Otherwise, you can't safely decompress, not with a Carrison punch, especially in operating cases.
Supplementing, because in our perspective, we don't have microscope. Many centers, very few centers use the microscope. So microscope and diamond tip high-speed bar. And of course, this sort of when 40-50% is occupied by, the ossified bone, in that case, you better go for neuromonitoring, and high-speed bar should be used, diamond tip high-speed bar. Otherwise, every chance to damage. Because when we are just naked eye, we are going to see it, and when using, say, osteotome or, say, the upcut, may not be up to the small size or big size, compressing the cord, and already it is compressed. Having with that, you are going to damage second time compression. So heating is the second time and damaging root and cord. So every chance to develop the neurological.
Yeah,
I have used the dental bar, I have no high-speed bar, dental bar,
otherwise
but
every chance to damage.
no neuromonitoring.
There are only two things. One is that never ever use osteotome in C-spine surgery. And second thing is, I believe that for C-spine surgery, it's highly recommended to use a microscope. Yes, Professor.
Guru, you want to supplement something?
Sorry that's happened to you. It's happened to me, and maybe one of the most unforgiving things about our specialty is how you can be punished when you do a good job. And this is an example of that. I wondered with the case I did whether positioning was an issue, whether I maybe had him hyperextended a little on the table and that was enough to do it. And yes, using a high-speed burr and not getting in under it. But I started thinking then, and whether there may have been benefit in my case of perhaps doing a posterior decompression first, such that it gave more space. I agree you had to go in the front, but obviously something's happened as you're going in the front that's making that stenosis critical, and maybe providing some more space first at the back might give a little margin of error. I don't know. It's a difficult case.
That's an interesting
Dr. Kamran, hello. Yes, I'd like to add on things, even with the high-speed bar and microscope. But if the focal OPLL is adherent with the dura, many surgeons has a temptation to try to remove this OPLL. This attempt may causes further injury to the cord. That should be avoided. In that situation, you just remove the body and part of the body and make flattening of that OPLL over the dura. It is safer for the surgeon to not to damage the cord.
Thank you. May I request?
I have a
Hello, sir.
question to the.
Yes.
Another thing I want to mention here. First case is operated here. Whatever it is, there is a stabilization and cord compression. But second operation, I think is without necessary. Is it mandatory to do second surgery? Because patient is in complete paraplegia. And there is also changes in the cord. Why there is a second surgery? Morar upor khorar ga. I don't know.
May I request?
So can I ask one question, sir? Can I ask one question?
Yeah,
Yes,
but last question, please. Not after
The
that.
burning.
Last question.
Thank you. I am Professor Hawk. The burning issue of the case of Dr. Reja. What was the cause of that post-operative complication? This is the main issue. Some of our colleagues thinking of cord injury during surgery. I don't think so. As the patient had a severe compression of the spinal cord, after the decompression, the cord might have a reactionary hematoma on that cord area, which is the cause of secondary cord damage. And the Faizul and the Kamrul has already said there is edema of the cord. And this is not the traumatic injury during operation. This is due to reactionary hematoma within the cord, which has caused permanent damage to the cord and ultimately paraplegia. So you have to wait how much cord edema will help you to regain the problem of the patient. This is very unfortunate.
Thank you. May I request Dr. Karim to please accept a moment on behalf of BSS.
Assalamu alaikum. Very good morning. I am Dr. Muhammad Yusuf Ali. Welcome to everybody, our scientific session 3. This session is craniocervical junction. I would like to request Professor Muhammad Anwarul Islam as a chairperson, please come to the dais. And I would like to request Dr. Abrar from India come to dais as a chairperson. Professor Anwar. The presenter in this session, first presenter Dr. Jawad Salim, Pakistan. His topic is AAD, AI, what to look and what to look for, when look for.
It is recorded version of Dr. Jawad.
Assalamu alaikum. Good morning, everyone. My name is Dr. Muhammad Jawasnim. I'm working as Assistant Professor Orthopedic Spine Surgery at Doctor's Hospital and Medical Center. My today's talk is atlantoaxial instability and what to look and when to look. I will discuss briefly about the anatomy of the C1, which is the superior view, which is showing the superior articular surface of the mass of the occipital condyle, tubercle, transverse process, and this is the inferior view, which is showing the inferior articular surface of the lateral mass and transverse process and the tubercles. This is the anatomy of the C2 anterior view, which is showing the dense superior articular facet of the atlas, and here's the posterior superior view, which is showing the dense and the posterior articular facets of the transverse ligament of the atlas. And these are the shown ligaments, which is important to note: the transverse ligament of the atlas, the apical ligament of the dense, and the alar ligaments, which are the stabilizer of the atlantoaxial joints. The most common cause for the instability is the rheumatoid arthritis, cases of the trauma, Gracil syndrome, genetic or the metabolic syndromes, and like the Down syndrome, spondyloepiphyseal dysplasia, Morquio, chondrodysplasia, and the metropic dysplasias. On the physical examinations, you should thoroughly go through the neurological examination. The patient presents with the sensory loss, motor loss, and you leave with the upper motor neuron signs. On examination, the patient presents with the Cock-Robin deformity or the torticollis, and some of them present with the occipital pain, myelopathy, vertigo, brainstem signs. And on examination, there is a tenderness over the spinous process of the axis on palpation, and the Sudeck sign, which is the displacement of the spine of the axis in the direction of the head tilt. Diagnostic consideration: anterior atlantodental interval more than 3 mm in adults and more than 5 mm in children is the diagnostic for the instability. The plane radiograph: look at the plane radiograph showing the open mouth view with the showing the dens should be in the center, and the lateral mass of C1 over the C2 should be equal. Lateral cervical spine, you can get the neutral flexion and extension and measure the atlantodental interval on both these sides. And the combined spread of the lateral mass of the C1 and C2 should not exceed 6.9 mm. Greater than 6.9 mm, it shows the rupture of the transverse ligament. Atlantoaxial distance greater than the 4.5 mm on lateral radiograph is indicative of the atlantoaxial instability. The posterior ADI is from the posterior border of the dens of the anterior border of the posterior tubercle. This index may be more important because it may directly assess the space available to the spinal cord. On the CT scan, you can assess the stability of the atlantoaxial joint, measuring the amount of the displacement, and the rotational CT, you can get the right, left, and the neutral. And on the MRI, you can see the stability of the atlantoaxial joint as well as the associated soft tissue changes, which is not visible on the conventional radiograph. Well, there is the Fielding and Hawken classification for this with the type 1 is simple rotatory displacement with intact transverse ligament, and the type 2 is anterior displacement of C1 on the C2 of 3 to 5 mm with one lateral mass serving as the pivot, and type 3 is anterior displacement exceeding the 5 mm, and type 4 is the posterior displacement of the C1 on the C2. Fielding and Hawken classification, this is again showing type 1, 2, 3, and 4. In type 1, the interval is less than 3 mm, type 2 is 3.1 to 5, and 3 is more than the 5. And this is the radiological classification evaluation for type 1, 2, 3, and 4, again showing the same thing. And this is the classification of the transverse lateral ligament injuries. In the type 1 injuries, there is a disruption on the ligament substance in the mid portion, and if it's in its periosteal insertion, it's 1B. And then in the type 2A injuries are disruption of the tubercle for the insertion of the transverse ligament from the C1 lateral mass involving a comminuted C1 lateral mass, and 2B is the avulsion of the tubercle from an intact lateral mass. Natural history for his ligament injury. Type 1, all 12 the instability 100%, and then type 2A it is 26%, and type 2B is 100% well the instability. And the management for regarding the Gracil syndrome is you can give the antibiotic, extraction, immobilization, and the soft collar, type 2 Philadelphia collar, and then type 3 and 4 you need to get the hollow vest. And the traction you can give in children 7 to 8 pounds, increase up to 15 pounds. In adults is 15 pound increase up to 20 pounds. And this treatment regarding the classification is Hawkins classification. Type 1 is stable subluxation, treat conservatively in collar. Type 2 is unstable, treat with physician's discretion. And the type 3 and the 4 both are unstable and require the surgical stabilization. Atlantoaxial rotatory subluxation, if it's 1 week or the less, use the soft collar. More than 1 week traction or hollow or the fusion. C1, C2 dislocations, mostly fatal, similar to occipital C1 dislocations. Odontite fractures, most common injury in the children, spine less than 11 years, usually fracture through the sternocleidosis, usually anterior displays intact anterior periostral sleeve. And in kids, you can give the reduction with extension with 50% of the opposition of the bone required. Hello or the Nirva cast, young children 6 weeks older, 8 weeks. And in flexion extension films at the you get the extension films at the 8 weeks, and in adults anterior odontite screw fixation of the C1 C2 fixations. This is the odontite fracture, and this is the AP and the lateral view on the flexion and extension you can see. And the osteodontodium, most likely odontite fracture non-union, and neurological compromise to sudden death. Check flexion extension films, and if it's more than 5 mm translation, surgery persistent neck complaint of the instability, and the prophylactic if there is the persistent neck pain. Anterior atlantoaxial subluxation, etiology, flexion injury. Disruption of the transverse atlantal ATI will be increased by 5 mm. Attachment points of the transverse atlantal may be weakened in rheumatoid arthritis or the trauma, and incompetent of the odontite process. Odontite fracture, congenital hyperplasia. Neck pain with no specific character, radiological evaluation again I've shown you. And what's the rule of spans? If total overhang lateral mass displacement of both C1 on the C2 is more than 7 mm, ADI more than 3 mm in adults, and in children is more than 5 mm. Is transverse atlantic ligament injury. CT scan is showing the bony avulsion. MRI directly assess the integrity, loss of the continuity, high signal. Surgical options for C1 C2 fusion, transarticular screws along with the posterior elements, or you can put the screw rod construct along with the C1 lateral mass and the C2 pedicle or the C2 spinous process of the posterior sublaminar wiring as described by Brooks and Calais. And my next partner will discuss in detail regarding the fusion techniques and details of the fusion. This is our team, and thank you again, Bangladesh Spine Society, for inviting me for this talk. Thank you.
For your nice presentation. Now I request Dr. Gurudeep Das from India. Gurudeep. And your topic is on C1 C2 fixation, harms versus transarticular techniques.
Respected Chairperson, sir, senior faculty and delegates, warm good morning to everyone and greetings from India. I have been asked to speak. Okay. And at the outset, I'd like to thank the organizers for the invitation and the warm hospitality. I have been asked to speak on the C1, C2 fixation options. And the objectives today are to discuss about the technique of transarticular C1, 2 fixation, the harms technique of C1, C2 fixation, and then evaluate the pros and cons of each technique, and then decide which one probably is better suited for your own case. So there are various surgical options available for C1, C2 fusion. And if you look at the evolution of these techniques, initially for a long time the wiring techniques were very popular. They were good, but often you needed external mobilization with a hollow vest. Later on, with the development of the C1, C2 transarticular screw and the Harms technique, there has been a revolution, and most of us now preferably use these two techniques. So coming to the transarticular screw technique, it was developed by Dr. Magrill in 1987, where you needed to put a screw on each side, and this screw passes from the C2 pass across the C1, C2 facet joint into the C1 lateral mass. So this needed a very precise trajectory, because if the joint is not reduced, this screw will be misplaced. So the starting point was somewhere around 3 to 4 millimeter cranial to the C2 facet joint, and you have to aim for the bottom 25 to 50% of the antetubercle of C1. As I mentioned earlier, it has to pass through the facet joint, and because of the steep angle needed, often you needed to flex the head of the patient like in a military tuck position. And you have to make sure that the guide wire does not cross the antetubercle of C1, otherwise you can injure the retropharyngeal structures. The typical screw length is somewhere around 34 to 40 millimeter, and this is a very robust fixation. But we have to be aware of the course of vertebral artery whenever we are planning a transarticular screw. The transarticular screw passes medial and superior to the normal course of the vertebral artery, but the aberrations in the course of vertebral artery are very well known, especially a high riding vertebral artery. And if you see, if the vertebral artery is more medial or more superior, then your screws can come in the path of the vertebral artery. Like in this case, you can see the track of the cave of the vertebral artery in a normal patient and those with a high riding vertebral artery. So if your normal screw you are putting, it will not go and injure the vertebral artery. But if there is a high riding vertebral artery, it comes directly in the path of your transarticular screw. So you have to be careful. Otherwise, this transarticular screw provides excellent biomechanical stability, and it has minimal screw pull-out rates and with very less cost. But the problems are it has a very exacting trajectory, and if you are not accurate, you are prone to injure the vertebral artery. And the other thing is that you have to get the C1, C2 facet joint reduced before you plan this screw. The second technique is the Harms technique, or popularly known as the Goel-Harms technique. It was first described by Dr. Atul Goel and Dr. Vijay Lahiri from KM Hospital, India. They described the plate and screw technique. Later on in 2001, Professor Julian Harms from Germany, he described the polyaxial screw and rod technique. The plate and screw technique needed extensive dissection of the C1, C2 facet joint, and you have to cut the C2 nerve to be able to put this. Whereas with the Harms modification, you could escape dissecting over there and you can preserve the C2 ganglion. So probably this modification has become more popular and is better known. This involves putting a lateral mass screw at C1 and putting fixation in C2, which can be either a pedicle screw or a power screw or a laminar screw. So the lateral mass screw of C1 you can put directly on the posterior arc of C1. However, you must be aware of the presence of a ponticulus posticus, where there is a ridge of bone over the vertebral artery and you can injure it. Or you can choose a safer option of putting it just caudal to the C1 arc directly into the lateral mass of C1, and you direct it slightly more medially around 10 to 15 degrees, and you again reach for the antetubercle of atlas. The C2 fixation options include a pedicle screws, where you start in the medial and the superior quadrant of C2 and direct it around 20 to 30 degrees medially and 30 to 40 degrees cranially, and this again is safe. But occasionally, in the presence of a high riding vertebral artery, this may not also be feasible. There you can choose to put a power screw. The power screw is a shorter part of transarticular screw with a less steep angulation, and this is a typical screw length is around 14 to 20 millimeter. So you can compare the trajectories of the pedicle screw and the power screw. Another safer option is putting a laminar screw, but you have to plan your screws like you plan for your CC screws in your neck femur fracture. So one screw has to be cranial, the other screw has to be caudal, so as to accommodate both the screws. The typical screw length is again around 30 to 36 millimeter, and this provides equivalent pull-out strength to a C2 pedicle screw. So the benefits of this technique include probably a little simpler surgical technique as compared to the transarticular screw, and with a reduced risk of vertebral artery injuries. And you can put it in patients who have irreducible atlantoaxial dislocation as well. Now the problems are, it is costlier because here you are putting 4 screws instead of the 2 screws in transarticular technique, and you have to do some amount of dissection in the C1, C2 area to be able to put the C1 lateral mass screw. And occasionally you may have to sacrifice the C2 nerve root to be able to put the C1 lateral mass screw. So the question comes, which of these two techniques is better? And let's see what's there in the literature. One of the earliest studies published in 2011 was a biomechanical study which compared all these techniques in cadavers, and they found that the transarticular screw with modified galleys provides the best possible stability, and it is superior to the Goel-Harms technique of C1, C2 fusion. Another clinical study, which was a retrospective review of patients, found that both these techniques provide equivalent fusion rates, but the Magril's technique had higher rate of complication both intra-op and post-op, and by complications we mean over here vertebral artery injuries, which was around 13% with the Magril technique and only 4% with the Harms technique. Then another retrospective review compared these techniques, and here specifically they looked at patients who had a high riding vertebral artery. 76 patients in this group had high riding vertebral artery and 51 patients had narrow pedicle. And in this series, they found that whenever there is high riding vertebral artery, it is wiser to put C2 pedicle screws because it is much safer. And they suggested that whenever you have a patient with a high riding artery, please prefer a C2 pedicle screw technique. Another retrospective review again confirmed this, and they said less radiation exposure with your Harms technique. So to summarize all these findings, the Harms technique scores whenever there is a risk of vertebral artery injury in terms of complication and with radiological outcomes, whereas the Magril technique scores better in terms of cost involved. And this is reflected in the trends in literature. Ever since the Goel-Harms technique has come, probably people are preferring the Goel-Harms technique as compared to the Magril technique. So the take-home message from my presentation would be that both transarticular screw and the Harms technique are viable options for C1, C2 fusion. Transarticular screw provides better or superior biomechanical stability, but in the presence of an aberrant course of vertebral artery, probably the Harms technique is better. At present, the Goel-Harms technique is more widely used of the C1, C2 fusion techniques, and as a surgeon, we must be aware of the limitations of each technique and then make informed decision regarding the best option. Thank you.
Thank you very much. Next talk is by Dr. Arif Khan. I think it is a recorded talk. Dr. Gurdeep, please. Topic is anterior odontoids techniques.
Professor Arif, are you here with us?
I'm here, sir. Hello, everyone. Assalamu alaikum and good morning. I'll be talking about thoracolumbar spine injuries. And since this is a very common topic, there's a lot of discussion that always go about the management of these injuries. And there are a lot of points where we as a community agree on.
Junaid, this is not his topic now. His topic is on anterior odontoid screw fixation and techniques. Before preparing the presentation, there may be the question and answer session. Have you any question to Dr. Gurudeep or Dr. Jawad Salim? Hello, Jawad Salim is here with us. Dr. Jawad, are you with us? No.
I have a question for
Gurudeep.
Thank you for your nice presentation. Regarding the C1, C2 fixation cases,
Do you routinely perform the angiogram in every case?
So whenever you are planning, so it is mandatory that.
Hey, mic turn, okay, mic turn. Yes.
Sorry. So whenever you are planning any surgery in the craniocervical junction, whether it is occipitocervical fusion or C1, C2 fixation, it is mandatory that we are actually aware of the course. So we do CT angiogram routinely and with 3D reconstruction so that we can plan our C2 fixation options, especially around the C2 fixation options.
And regarding the positioning of the cases, do you prefer the flexion position or the neutral?
No, that depends what we are doing. Like if we are doing a occipitocervical fusion, I would like it to be as neutral as possible. If I am doing a transarticular screw, I need my head to be flexed as much as possible because that involves a very steep trajectory. Whereas if I am doing a Goel-Ham's technique of C1, C2 fixation, I keep the neck in neutral position.
Hello, Gurudev.
Bismillahirrahmanirrahim.
In
Hello
case
everyone,
of
my
traumatic
name is
cervical
Professor
spine
Arif
injury,
Khan, and
Arif, can you start?
before I start my talk, I would like to express my extreme gratitude to all my friends who invited me, particularly Professor Shah Alam, Professor Shahidul Islam, Junaid, Anwar, and all others. I was so excited to be with you during this conference, but because of reasons that were beyond our control, I have to talk to you online. The topic that I have been given is odontitis screw fixation is more of a technique, sort of no disclosures. So just to give you a short overview of the odontite fractures, these form about 5 to 15% of cervical spine injuries. They were first described by Lambert in 1894. And for many years, the classical treatment was C1, C2 arthrodesis. For all these fractures, Bowler in 1982 performed the first anterior screw fixation. As you know, the C1, C2 immobilization will stop 50% of cervical spine rotation, so it's very disabling. And therefore, the odontite screw fixation has become very popular and in patients with the right indications. This also obviates the need for a posterior approach, which is much more damaging to the muscles. As far as classification is concerned, the most commonly used classification is by Anderson and D. Alonso, and he divided these fractures into 3 different types. Type 1 is at the tip of the odontite. Type 2 is fracture at the base of the odontite process, and type 3 involves the body of the axis. And 2 fractures are further classified into 3 different types. Type A is undisplaced fracture. Type B are displaced fractures. They can be transverse or oblique, starting anterosuperior and going posterior-inferior, while type C fractures are comminuted or oblique, starting antero-inferior and going posterior-superior. Type 1 and type 3 fractures are usually treated conservatively and have very good results with conservative treatment. Type 2 fractures are notorious for developing non-union, which can be as high as 30 to 40%. There are certain risk factors associated with developing non-unions, and these can be age more than 50 years, displacement of more than 6 millimeter, fracture comminution, fracture gap of more than 1 millimeter, angulation of more than 10 degrees, delay in treatment of more than 4 days, posterior redisplacement of more than 2 millimeter, and smoking. The odontite screw fixation is quite popular because of its certain advantages, and the most important advantage is that it provides direct osteosynthesis without immobilizing the C1 tissue segment. And as you know, C1, C2 segment provides most of the rotatory movements of the cervical spine, which are very important in cervical spine. However, in order to achieve the best results, it has to be used in in its own indications, right indications. And these indications are displaced type 2B fractures. Type 2B means transverse fracture, are the one that starts antero superior and ends posterior inferior. In polytrauma patients and in patients where they cannot tolerate the hollow rest. Then there are certain contraindications to anterior screw fixation for the odontite, and these include fractures which cannot be reduced or which can only be reduced in flexion position, because then achieving the correct trajectory would not be possible. Similarly, barrel chest, and again, achieving the correct trajectory becomes very difficult. Then in chronic injuries, because reduction will be very difficult, and then reverse oblique fractures, and this is very important to identify, because in the reverse oblique fracture, once we achieve compression, this pulls the proximal fragment anteriorly while pushing the distal fragment posteriorly. This not only reduces the contact area between the two fragments, but also reduces the space available for the spinal cord and can put pressure on the spinal cord. The imaging that are needed before we go for osteosynthesis of the odontite process are the plain X-rays, which include open mouth view, lateral view of the cervical spine, and in certain cases we can do flexion extension radiographs to see for instability of the cervical spine. Instability in this area can be diagnosed when the ADI is more than 10 millimeter or the space available for a spinal cord is less than 13 millimeter. This can be diagnosed based on plain X-rays. However, CT is much more accurate for diagnosis instability in this region. Before starting the procedure, it's very important to properly position the patient. This procedure is done in supine position with the head usually immobilized with the help of a Mayfield frame. And for the beginners, it's better to have two image intensifiers so that we can have simultaneous AP and lateral views at the same time. Now, the placement of these image intensifiers is also very tricky, and this has to be done by the surgeon himself and should not be left to the assistant. Lateral view can be easily achieved, but achieving the correct AP view is not easy. You will have to open the mouth and put a radiolucent substance between the upper and lower jaw to keep it open, and then rotate the image intensifier in different directions to achieve a good anterior view of the odontite process. Now, sometimes, because of the position of the reduced fracture or because of the shape of the chest, it is difficult to use a straight, normal, regular drill, and therefore it can be very advantageous to have a flexible drill available to you. Before taking a start, you need to achieve this trajectory in your AP image intensifier. You need to open the mouth, put some radiolucent material into it so that it stays open, and rotate the image in different directions to achieve this anterior view of the odontite process. Once you get it, you fix your image intensifier in that location. Once the desired images are achieved in AP and lateral view, the image intensifiers both are locked in that position, and the site is exposed at the level of C5-6. Now, going through the left side or the right side is personal choice. But once you go to the vertebral body anteriorly, then you can make very easily the dissection. You can take it up as high as C2 level. I don't usually use the proper jig for odontite screw fixation. Rather, I just use a simple Holman retractor and put this anteriorly over the body of the C2, and this displaces all the soft tissues and it gives me a visual of the C2 level where I can go in and put my K-wire in first. That entry into the C2 body is very important, and this is about 2 millimeter posterior on the inferior ill plate of the C2. The most common mistake that people commit is to start along the anterior cortex, and KYs can be easily passed, even drill can be made easily, but once we put the screw in and start compressing it, this might shatter the anterior cortex, and then stabilization may not be possible, or rather the whole procedure would end up in failure. Once the correct entry point is achieved, like here, the KY is passed, and then its trajectory is checked both in the AP and in the lateral view, and it is gradually progressed, and again under continuous monitoring in the image intensified in both AP and lateral views. The KY is passed up to the tip of the odontite process, and is left there, and the cannulated tab is passed over it. All this trajectory is then tabbed with the tab, and then you measure it and pass the screw over the wire. And this is a short video of the procedure. This is the K1 has been positioned. This is now passed, and the position is checked simultaneously in both the AP and the lateral X-rays. K-wire is going up. Now this is crossing the flexor side. This is how is the operative side picture. So the K-wires have gone all the way up to the tip of the odontite process. This is measured, tab, and then the screw is passed. Compression is achieved. This is how it looks anteriorly. This is the picture at the end of the procedure. Some people might like to use 2 screws. However, I use single 4 millimeter cannulated screws, and that gives me good purchase and fixation. That's all from my side. Thank you very much for your patient listening.
Next, I will invite Dr. Muhammad Harun Al-Rashid. He is going to talk about their institutional experience about the Goels technique for atlantoaxial dislocation and fixation. Dr. Rashid.
Hello. Good morning, everyone. Respected chairperson, honorable guest. I'm Dr. Muhammad Harun Rashid, working in Mohammed Singh Medical College. I would like to give thanks to give me the opportunity to present of what we are doing in our department. So today I will talk on AA, the atlantoaxial dislocation, the surgical outcome following Goels technique is our experience. So, atlantoaxial dislocation mostly is a congenital anomaly, but it can happen following trauma. There's some inflammatory diseases is there that can affect the joint, and definitely infection is one of the causes that can affect this joint. Surgical treatment near these symptomatic patients to prevent the progressive neurological deficit and to protect against the potential respiratory failure and sometimes death. And there is some the options is there to deal with these kind of cases. The first one, the Brooks and Gales type, followed by the Goels techniques, the lateral mesh and C2 pedicle, and then already we have heard about the transarticular C1 C2 fixation. So today I will focus only on the Goels technique. We did a respective study from 2021 January to June 2023, so 1.5 years retrospective study. that we included all AD patients with different pathology, and we did CT angiogram before surgery in every patient, and we did perioperative reduction and fixation by the Goels technique. We recorded the clinical, radiological, and surgical outcome just after discharge, 1 month and 3 months following surgery. This is one of the cases that we have done in our department. This is a case of AD. You know, in extension there is a Atlantic axial index is increased here, and we did the CT scan. What we have seen, the dense of the odontoid process entered into the foramen magnum, and if you see, there is a extensive compression from the anterior side up to the medulla, and this is the post-op image of the patient. So here the basilar examination AD we did by the Goels technique. Here's the Professor Goel. Actually, he first described for dealing with these very difficult cases, and he published this article in 1994. And here, till then, is 1,118 times have been cited this article for these rare cases. There are some steps for this technique. First of all, the opening of the C1, C2 joint. And after opening the joint, we must remove the cartilage for bony fusion. And after that, we go for fixation. So what we do actually, we place the patient in prone position, keeping the head 45 degrees up. And there is a traction, almost 1/6 of the body weight, and there is the counter traction of the body weight. We make the face floating over the horseshoe. And also, it improves the venous drainage. You see, here's the C1, C2 joint, and the main way to identify the C1, C2 joint is to the C2 ganglion. So we have to first open the C1, C2 ganglia. Either we can remove it, or we can change the position. Then we can place the bone graft over there. Before that, we must have a very clear anatomical ideas about the C1, C2 joint. The first thing is the opening of the joint. The main thing in the opening of the joint is the venous problems that we usually, it makes the operation very difficult in the initial stage. So I make a video for the juniors how to open this one. What are the venous problems here? This is the C1, this is the cranial part, this is the caudal, this is the left and this is the right part. So we are opening, this is the C2 posterior arch. There is the 3 venous channels here. This is the vertebral artery is here. So perivertebral venous plexus is here. And vertebral artery venous, this is the vertebral artery is here. So around the vertebral artery, there is a vertebral artery venous plexus, and there is a vertebral venous plexus. Another venous channels is there. There's the marginal cavernous sinuses. And so when you do dissection at the C1, C2 joint, we must be careful that we are not directly entered over the capsule, rather we must keep in the superior still plane. So we are here dissecting the muscle in a very low by coagulation mode. So only during the exposure, this is the C2, this is the C1, this is the C2 nerve ganglion. Only the venous channels that communicates the vertebral venous plexus and vertebral venous plexus we should count for. This is the place for the vertebral artery venous plexus. We shouldn't open this. We must keep in between the vertebral artery venous plexus and vertebral venous plexus. This is the vertebral artery venous plexus, and this is the C2 ganglion. So during the exposure, only a few of the bleeding, this is the venous plexus that actually communicating. So only a few bleeding can, a few millimeter blood can be lost during this, this cautery. During the dissection. So we can remove the C2 ganglion, because most of the time patients have presented with the muscle power 3, muscle power 2 like this. So we should about the minor hypoesthesia that can happen following the C2 nerve root. There will be mild suboccipital hypoesthesia will be there. So this is the joint already open in the on the left side. This is the other side. This is the right side. This is C2 C1 posterior tubercle, and this is the posterior alternatial membrane. I want to show the vena channels that you shouldn't go for, because if you certainly, these are the vena channels that are gradually opening. So you must, this is the vena channels, these are the vena channels. So during residency, we have seen a lot of problem when roping. I think this video will help the juniors how to open this one. These are the vena channels that you shouldn't open. And these are the vena channels for the vertebral venous plexus. These are the vertebral artery venous plexus. And this is the C2 nerve root. So we are just removing the soft tissue over there. This is the posterior lateral mass. Sorry, this is the lateral mass of the C1 on the right side. If it's possible, you can preserve this C2, but in this case, we resected it because this case was, I will show you, this is case of lateral rotation of the C1 over the C2. So for the adequate exposure and not to prevent the vertebral artery, I transected it. So this is the C1, C2 joint on the right side. Already prepared for the lateral mass for the fusion, for the screw. This is the left-sided C1, C2 joint.
There is running short of time. Please conclude.
Okay. So, okay. So for screw placement, we must be careful about the high riding vertebral artery. There is the arcuate foramen is there, so we shouldn't. We should take account of this. And there are some other arterial abnormalities that's there. That is the persistent first intersegmental artery. There's the duplication of the vertebral artery, the pica originating from the between the C1 and C2. Already you have this, the angles 15-degree medial and 15-degree superior for C1, and for C2 it is 15-degree medial and 30-degree upwards. I will not go details on this. I will talk. This is one of the case for ossodentodium with AAD, and if just you see how much descended this tip of the odontoid process. So it's a quite good approach for reduction of these cases. This is the post-traumatic cases. There's a C1 posterior transluxation over the C2. You see the vertebral artery on the right side. Okay, this is the post-op case. So these are the results: male dominance, only presented with a weakness.
Please conclude your speech, please.
Okay.
Last slide.
So thank you. What I can say, this Goel technique is a very effective technique for the stabilization of the atlantaxial joint. But before that, you must have very clear anatomical knowledge of this joint. Thank you very much.
Thank you. Now I'll request Dr. K.M. Islam is going to talk on basilar invagination, treatment of the cases of basilar invagination. How do we perform their experience?
Assalamu alaikum. Very good morning, dear learned audience. It's a great honor to present our work in front of the learned audience like you. I will go a little faster because we are lacking behind the time, and I will skip some slides. And okay, this is the anatomy that has been described by my previous speakers. I will skip through this. And basic anatomy of the craniovertebral junction has been already been described by my previous speakers. So I am not going detail. I will go to the case-based discussion directly so that we can save the time. And this is the basic armamentarium that we need to do to perform the surgery successfully for basilar invagination. And first of all, we need to do a extracervical spine, both AP, lateral, and dynamic view, MRI of cervical spine. And the most important imaging that we need is CT scan of cervical spine with 3D reconstruction. It gives us a pre-operative idea how we will operate the case and what do we land, what are the anomalies present in the case. And another important imaging is CT angiogram of neck. It helps us to have an idea before surgery about the course of vertebral artery, which is very important to do the surgery successfully, and also Doppler and definitely operating microscope with high-speed drill. This is the first case, 40 years male. He presented with progressive weakness of all four limbs for last 4 months and urinary urgency for last 1 month, and his muscle power was on right side MRC grade -4 and on left it was 4. And this is the X-ray. You can see the crowding of the craniocervical junction. This is dynamic view. It is basically irreducible variety of BI. This is the MRI. You can appreciate the narrowing of the foramen magnum and protrusion of the odontoid into the foramen magnum, which is causing huge compression on CV junction, and there is also a mild signal change. And this is CT CV junction showing that settling of the odontoid into the foramen magnum, causing gross reduction of foramen magnum, and you can appreciate the there is a deficiency of posterior arch of Sion and assimilation of anterior arch with clivus. And this image is very important for instrumentation. You can appreciate the tilting of the CV junction towards the right and fusion of the atlas with the occiput. And what did you do? Our approach was C1-C2 joint destruction, joint jamming by titanium spacer, and stabilization by occipitocervical kill plate connected via rods to C2 pedicle screws. And our surgical strategy was, in this case, there was overriding of axis over the atlas and fusion of the atlas with the base of the occiput, and it was difficult to land on the C1-C2 joint. So what did you do? We cut the C2 ganglion bilaterally and ausculted the vertebral artery with the help of Doppler, and it was anomalous on the right side and it was mobilized. And finally, C2 pseudoarthrosis was identified. It was drilled out and we landed on the C1-C2 joint and a spacer was placed. This was the position. We placed the position in prone and neutral position. And this is the video after drilling of the pseudoarthrosis. After cutting the C2 ganglia, we landed on the C1-C2 space. And on the left side, drilling was continued, high-speed drill under microscope, and we landed on the true C1-C2 joint. And after that, a spacer was placed to achieve the destruction. And our technique is a DCR technique. What we did that we first did destruction, then compression, and finally reduction to pull out the dents down. And this is a very brief video. I will skip. And this is the operative view. And as you know, for occipitocervical fusion, this is the basics of occipitocervical fusion. I'm skipping. And this is the final picture after the surgery. And reduction could be achieved. And this is a postoperative MRI after 3 months. You can appreciate the foramen magnum has been decompressed. This is 2 video before discharge and 3 months after follow-up of the patients. Subjective improvements His spasticity has been decreased. Muscle power is same before surgery, but in follow-up, his subjective improvement of muscle power just after 3 months of the follow-up. This is another case, 32 years female, neck pain, weakness of all 4 limbs, and sensory level below C2. You can see the settling of C2 dens in foramen magnum with gross compression of CV junction and tilting of the axis on the right side. And this was a case of basically Klippel syndrome. You can see the block vertebra and hemivertebra and deficiency of Sion arch and fusion of axis atlas with occiput. This is a perioperative picture, and in this case we did foramen magnum decompression because we suspected that we could not achieve the adequate reduction of dens below the foramen magnum, so we did foramen magnum decompression. And this is the postoperative CT scan showing that we could achieve the foramen magnum decompression, and this is the condition of the patient in just 3 months follow-up. Spasticity has been decreased and she has subjective improvement of muscle power, and she is feeling better than before. These are the common complications we can encounter. Most important is we should have special attention to vertebral artery so that we should not injure.
Please
that.
conclude. Please conclude.
And thank you very much for your patience hearing.
Thank you, Dr. K.M. Islam, for your nice presentation. Now, only 1 or 2 questions is allowed for the presenter. Is there any question? No questions. I have a question to Atikul Islam. Hello, Atik. In case of basilar invagination, whether are you going routinely to do the foramina magnum decompression, or sometimes you go for the odontoidectomy?
Most of the cases, we try to put down the dens below the foramen magnum, and in all cases, we suspect perioperatively that we could not achieve that. In that case, we did foramen magnum decompression. In none of the cases of our series, we did transoral odontoidectomy. We all did posterior decompression and posterior fixation.
Any one of your cases, whether you go for C0, C1, C2, or only C1, C2?
Most of the cases, we did C1, C2 fixation. In one cases, we did craniocervical fixation.
Thank you. Dr. Arif Khan.
Question to you.
Yes.
Sometime, in spite of your screw fixation, there is a non-union, and patient is having persistent discomfort. How you are going to manage that case?
You see, the bailout procedure for interior screw fixation is the C1, C2 stabilization. So not all cases can be done through the anterior screw fixation, and not all cases will be successful. So whenever there is a problem, we have to do posterior C1, C2 stabilization.
Thank you, Professor Arif, for your nice presentation.
I have one question.
Okay, the session is over. Now I would like to request the moderator of the next session, Dr. M.D. Shahidul Islam Akun. And chairperson is Dr. Syed Shahidul Islam and Dr. Klaus from Germany. Klaus, please come.
Bismillah ar-Rahman ar-Rahim. We are taking of time
So we need to hurry, and we are waiting for lunch session. This is a big session here. There are many topics, and our presenter is Arif Khan from Pakistan, Jamzuri bin Zakaria from Malaysia, Kamran Farooq from India, Abrar Ahmed from India, Dr. M.D. Noor Alam from Bangladesh, Zutan Chandra Churik, Bangladesh, Muhammad Mahamudul Hassan. This is the first session here, then subsequent sessions. I request Met Klaus to start the session and also Syed Shoaib Islam sir.
So I should start. I would like to request all the presenters to come to the dais and sit on your chair. Please, all presenters come to the dais. So Arif is here with us. So
Yes.
first session, yes, Arif is there. His topic is thoracolumbar spine trauma, consensus and controversies. Dr. Arif Khan from Pakistan is the head of the Department of Orthopedics and Spine Surgery, Khyber Girls Medical College, Pakistan. And he is the Secretary General of APOA, as well as the past President of Pakistan Orthopedic Association. Let's welcome Dr. Arif Khan from Pakistan.
Hello everyone, Assalamu alaikum and good morning. I'll be talking about thoracolumbar spine injuries. And since this is a very common topic, there's a lot of discussion that always go about the management of these injuries. And there are a lot of points where we as a community agree on with each other, while there are others where we do not agree with each other. So today we will be discussing these points of consensus as well as the controversies. I have no disclosures, and I will start my presentation with this case of ours. She's a 38-year-old lady who presented with a history of road traffic accident 12 hours ago. She was having severe back pain in thoracolumbar region, no other injuries, and she was neurologically intact. And these are the x-rays. Now we will discuss this case under different headings, including imaging, classification, they should be treated conservatively or operatively, what should be the time of surgery, which approach should be used, and what should be the technique, and should this be just stabilized or should this be fused as well. Now this is the x-rays of our patient, and this shows a fracture of T12. Now what next? Is it sufficient for our decision, and should we make decision based on it, or should we do other x-rays, should we do CT scan or the MRI? Now before we make any decision, we should realize that there is literature that suggests that in up to 1.6 to 17% of the cases there is a non-contiguous spine injury, meaning if there's one spine injury in a patient, in up to 17% of the cases, there can be another injury to the spine as well. Now, most of these injuries are stable, but up to 3 to 4% of them are unstable. And if they are missed, they would have serious consequences for the patients. Now, one very important study that I came across regarding the role of CT scan and MRI in decision-making process. This study was by Raja Sekran, Alexander Vaccaro, and many others. And their conclusion was that our modern classification systems are based on CT scan, not just on X-rays. And therefore, CT scan is mandatory for diagnosing as well as for screening the whole spine. However, this study did not support the need for routine MRI in these patients as far as their management was concerned. There is one particular fracture, that is type B2 injuries, where the MRI has a better imaging value than the CT scan. In the rest of the cases, CT scan would give most of the information that are required. Now, this is the X-ray that I have taken from the same study, from the same paper, and based on the X-rays and CT scan, this fracture was classified as type A3. But when MRI was done, they found that there was injury to posterior ligamentous complex, and therefore classification was changed to B2. Now, this is one particular injury that is type B2, where MRI is very helpful. In the rest of the cases, CT scan can give us adequate information. Now, as far as classification is concerned, the most commonly classification used nowadays is by the AO spine, which use two parameters, mechanical and neurological. Mechanically, there are three type of injuries: type A, compression; type B, distraction; type C, translation. And every type has further subtypes. Then, based on neurology, they are from N0 to N4, which is complete cord injury, and then NX when the injury cannot be properly documented or diagnosed. Then there are two modifiers, M1 and M2. M1 when the injury to PLC cannot be properly diagnosed, and M2 when there are certain comorbidities which can impact the decision-making process. Now, this is our patient, and here you can see that there was a fracture of T12. It was a burst fracture, and if you can see, there is increased gapping between the spinous process, indicating that this is a type B2 injury. And this is the CT scan confirming the same thing, compression injury, and there is type B2 injury. What about the use of steroids? And this was more popularized by the recommendations from the third NASIS study. And according to that study, heavy dose steroids should be used if the patient presents within 3 hours for 24 hours. If they present for between 3 to 8 hours, then they should be continued for 48 hours. Beyond 8 hours, then they do not recommend it. However, the heavy dose of steroids are associated with serious morbidities, and most of the people do not believe on the recommendation of these studies. The next question is, should this be treated conservatively or operatively? Now, for a simple compression fracture with intact posterior ligamentous complex injury, it can be treated non-surgically. However, if the posterior ligamentous complex is injured, which can be diagnosed if the kyphosis is more than 30 degrees, loss of anterior body height of more than 50%, gapping interspinous process, gapping facet joints, are MRI evidence of posterior ligamentous complex injury. In this case, the posterior column should be reconstructed. And the posterior column can be reconstructed only through the posterior approach. Now, there is thoracolumbar injury classification and severity score, the TLIC system, which is based on three independent predictors: morphology, integrity of the PLC, and the neurological status. And they give score to each of these points, and if the score is less than 3, they recommend conservative treatment. If more than 4, they recommend surgical treatment. If the score is 4, then it depends on the surgeon choice. Now, the next important question is when to operate. And again, there are a wide variety of studies that can give very different recommendations. In this one very interesting meta-analysis that I came across, published in 2019, and according to this, in patients with complete cervical cord injury, there is more improvement after early surgery. However, after incomplete spinal cord injury, the improvement after early or delayed surgery is the same. Now, this was very interesting because this was contrary to the belief of most of the people. Now, there's another meta-analysis, and their conclusion was that early surgical decompression was associated with favorable neurological recovery. However, there was a lack of high-quality evidence, and there was a need for further studies and further examination. That means they were not very sure whether it is needed, early surgery is better or late surgery is better. And then there's another study which does not observe any significant beneficial effect of surgical decompression within 24 hours in patients with thoracic and thoracolumbar spinal cord injuries. So we have a very wide range. However, most of the people would believe that this patient should be operated as soon as the patient condition permits. When the patient is hemodynamically stabilized, whether it's day or night, he should be stabilized. Then, which approach should be used for surgery? Posterior, anterior, or combined anterior and posterior? And there are a lot of studies, each suggesting either posterior, either anterior, or combine of them. But the bottom line is, if the posterior ligamentous complex is injured, this has to be reconstructed. It has to be restored. And this can only be restored through the posterior approach. Then what about the anterior column deficiency? So if the anterior column is severely deficient and we just stabilize it through the posterior implants, all the load will go through the posterior implants and they will either pull out or they will break. And therefore, in these cases where the anterior column is seriously deficient, it should be reconstructed as well. The next is, should they be stabilized using short segment or long segment fixation? Short segment means one segment up and down without involvement of the fracture vertebra. Long segment means two or more level up and down. And now both these fixation methods have their own advantages and disadvantages. This is one of our case of fracture of the L2, and this was stabilized with short segment fixation. Long segment has its own advantages and disadvantages. Now, to come to the conclusion, most of the people believe that type C injuries should be stabilized with long segment fixation. Asia A injuries should be stabilized with long segment fixation. Older age people, osteoporotic fracture, they should be stabilized with long segment fixation. In younger age, type A, type B2, type B3, they can be stabilized with short segment fixation. What about fusion? Now, again, there's a lot of controversies here. Some people would think that it's not needed at all. There are others who...
Of time, so please conclude, Arif Khan. Thank you. Thank you so much. Our next presenter, Dr. Yes, please. You call
Yes.
the second presenter.
Hello everybody, my name is Klaus Schnacke from Germany. It's a pleasure to be here. And the next speaker I would like to call is Dr. Zamzuri bin Zakaria Mohammed from Malaysia. We'll talk about current treatment for A3 and A4 thoracolumbar fractures without neurological deficit. How should we treat? Please.
Okay, thank you very much, Mr. Chairman. So I will talk with something which is very familiar with everybody, which is thoracolumbar trauma. So we are very near to our lunchtime. I will be very fast. So hopefully we can go for our lunch earliest. So I will talk on this topic. It's a controversial topics. So my name is Dr. Zamzuri. I'm from Malaysia. So I practice from the coast of Malaysia. So 2 hours from Kuala Lumpur. So I will talk on the A3, A4 thoracolumbar fractures without neurological deficit and how do we treat. So this is the applied anatomy where we should see the thoracic and the lumbar vertebra. You already know there is a transition between thoracolumbar, thoracic and lumbar. There's a thoracolumbar junction where the area is very common for surgery, common for fracture because of translation between mobile to rigid segment or rigid to mobile segment, lordosis to kyphosis and orientation of the facet. That's why the area from T10 to L2 is very common to fracture. So the type of fractures is very common. It's either called burst fracture, compression fracture, fracture dislocation, and fraction distraction type of fracture. So what I'm going to touch today is mainly on the A3 and A4. So what is A3? A3 means incomplete burst fracture with involvement of posterior wall only, but only with one end plate is involved. So this is how it looks. This is A3 fracture. So this is A4 fracture. It's a complete burst fracture characterized by involvement of the posterior walls and both end plates. So this is how it looks like on the picture. So there is A3 and A4 fracture. Both are burst fracture. One is involvement of the one end plates, posterior wall, another one with both end plates and both the posterior wall as well. So what is the best treatment for this? What is the ideal treatment? Is it operative or conservative? So we don't know either which one is the best. Okay, so if you look at the advantages and disadvantages, operative treatment give immediate stability, earlier intervention, sooner return to work, and non-operative give less cost, no complications, surgery, any implant-related complication, and infection. So if let's say, look at the key points, so far, there's no general consensus exists between A3, A4 thoracolumbar fracture without radiological visit. So there's no consensus yet. Number two, many contrasting opinions have been proposed, currently recommending both operative and non-operative modalities. So I served the journal, so this is the journal Management of Burst Fracture Thoracolumbar published in 2016. So indication, they say that generally surgical treatment indicated in A3, generally, okay. So there is another paper, so it's published in 2019, conservative versus operative treatment of stable thoracolumbar fractures in neurologically intact patients, where they found that the study concluded that surgical treatment for stable thoracolumbar fractures in neurologically patients provide better radiographic outcomes, but in terms of clinical outcomes such as ODSI, VAS, and quality of life is not statistically significant. So I just show my cases. This patient is 40 years old, got involved in the motor vehicle accidents, and then got fracture, C4 fracture of the T4. So this is involvement of 2 end plates. So this is the CT scan. So I decided to treat this patient operatively. So this is how it looks, check X-ray post the surgery. So this is case number 2. There's a number, there's a 1 patient also. So this is around 40 years old. So he get involvement in motor vehicle accident and sustained T7 fracture. This is type 3 fracture. So I treat this patient conservatively, A3, T7 burst fracture. So what I can conclude from this slide, I think the best treatment for this patient, I think, is operatively, where you can have a good X-rays and then you can mobilize patient earlier and the patient can go back to the normal earlier compared to you treat operation conservatively. But conservative treatment still play a role as a treatment of option is indicated. So thank you very much.
Thank you. Thank you, sir. Jamzuri Muhammad Zakaria. Our next presenter is Kamran Farooq, and his topic is Management Strategy for Neglected Thoracolumbar Trauma.
At the outset, I would like to thank the Bangladesh Spine Society for giving this invitation to me. So, which one is it? Can you help me, please? It's not scrolling forward. This one, okay. Yeah. Okay. So basically, I mean, what we have seen is, why? So I am still in the previous timing, is it? Yeah. What happens is that most of the spine injuries which are missed are either we are not doing enough studies, or the studies are not interpreted well, or there's insufficient studies. We published a study. We did a study. We published in Asian Spine Journal, and what we found was it was a retrospective study. What we found that and what we had used in those cases was actually all the approaches. We did anterior approach in 9 patients, posterior approaches. Most of them were posterior approaches, and a combined in 5. What we found was that most of the cases which came to us neglected, but either there was inadequate or inappropriate treatment at primary health center, means they were not really spine centers. And the patients went to the spine surgeon pretty late, in almost 40%. So those were the main reasons. And in some cases, there were patients who had a missed injury. However, now there's a new paper which says that even for patients who are detected late, better if you operate them. So what the objectives being obviously to give a relieve the neural compression, provide a stable column, try to reduce the deformity, at least prevent any further progression, and get a as balanced spine as possible. What we have employed different strategies is, one thing is for sure, that you have to get a very complete discoligamentous release. Without that, you will not be able to get either decompression or reduction or a good balance. And different strategies like corpectomies, partial or complete, multi-level, Pontes or intradiscal PSO, and obviously we always have to instrument them and augment them with interbody fusion. And some cases, so this was actually a case in our hospital. She was admitted in general surgery and then discharged and came to us after 6 months. And you can see that it's a classical ligamentous chance B2 type fractures that I was talking about earlier. And these are the imaging for that patient. So it can be seen that it's basically almost a complete ligamentous flexion distraction type of injury. So what we did, we mobilized it very well and fixed it long segment with interbody fusion. It didn't really need any bony work in that much of bony work in that. It was, and this is a long-term follow-up. Another case, this was a burst fracture, didn't have any neurological deficit, but did have a lot of back pain. So they came to us. And in this case, it was simple. We did a partial corpectomy with posterior instrumentation fusion. This was a case, she had pre-op Asia C score, came to us after 5th months. I think they didn't treat them surgically when they came to us. This is the fracture. It collapses, typical type, more than 50% and more, vertebral body is damaged and more than 30%, 30 degrees of kyphosis. Maybe should have been fixed initially with surgery, but they did treat it conservatively. So for this case, what we did, we thought that since Asia C at conus level, we went anterior and did anterior surgery. Although the kyphosis correction is not that good, but yeah, I mean, the patient is much better neurologically now and going on. Again, another fracture dislocation. This is a classic fracture dislocation flexion distraction injury with compression of the vertebral body, burst progressing on to a fracture dislocation, nearly toppling off. And this is what we did. At the first go, we did a posterior thorough decompression, did a kyphosis correction, flipped the patient over, and then we did an anterior surgery, complete corpectomy with a expandable cage. And this is a long-term follow-up. This was a case, traumatic listhesis L5S1, admitted in surgical ward, and they referred to us after 6 weeks. It's more like the kind of listhesis we have, except that it is traumatic. So in this case, you can see that it's almost a grade 3 sort of a traumatic listhesis. So this was fairly straightforward, no big deal in this. It's just that we had to take the ileum into consideration and fix S1 as well as N2 levels above with interbody fusion. This was a very interesting case actually. Traumatic spondyloptosis of D8-9 with no neurological deficit. That's really hard to imagine. A patient was in surgical unit and they had, for hemothorax, referred to it after 6 weeks. So this is, when they came to us, it was almost 6 weeks. This D8-9 patient, spine is almost toppled over and importantly, no neurological deficit. So we thought, what should we do in this? If you see the CT scan, you can see that the spine is actually cut into 2 halves. With 1 half really off. So in the first go, we thought, okay, what we'll do a posterior instrumentation, flip the patient over, maybe do a corpectomy, and then put a cage in between the two. So in the first stage, we did a posterior instrumentation. This is what we got. So the patient did have a good chest, so I didn't want to go anteriorly at that go, and I thought I'll wait for some time. And but the patient, was doing well. So then in retrospect, I thought, why do we have to really go anterior and support it? So we carried on with this. So this is what I was talking about. Sometimes just in situ fusion with a thorough posterior decompression works. And this is a long-term follow-up of that patient. And the patient was actually doing quite well.
You have 2 minutes only, yes, sir, please.
Yeah, I know that. And again, another fracture. This was a translational injury at L4-5. Patient had, I think, grade 4 power in the lower limbs. Came to us after almost 6 months. You can see on the X-rays. And CT scan doesn't look really that bad. But X-rays look on flexion distraction, they look a bit more scary. So I was thinking that maybe we can do an in situ fusion with a posterior decompression. But when we went in and put in these screws, and I distracted it, the disc opened. I mean, this was the initial X-rays, and then when distracted, the discs actually opened quite a bit. So I thought, well, that's nice, and maybe we can instrument the one which is dysthetic, and that's what we did, and we were able to instrument even the vertebra, that is 5433, and we put in a complete discectomy with interbody graft, and it fused nicely. Go on. Yeah, and this is a long-term follow-up with this patient. Most of the cases which happen are actually basically because of neglect. Again, a fracture dislocation, 1 year old also, I think, came to us from one of our states. Patient came to us walking. The spine is basically translated. So again, then we had to do almost something like a near complete corpectomy we did of the listed of the vertebra below and put in an interbody graft. And this patient is doing well. Again, patient managed conservatively for 1.5 years and referred to our center. Classic case of a kyphotic deformity because you didn't treat the initial unstable vertebral burst fracture. For this, we did an intradiscal sort of a PSO. This is a pre-op X-rays, and we did a
please conclude, sir. Yeah. Please conclude.
So, and corrected and again, classic case of kyphotic deformity following burst fracture. So to conclude, we say that neglected trauma is really not that uncommon in India, and main reason being that they came either late to us or inadequate treatment was given, and you really have to tailor-make the surgical strategies to each case. Thank you very much.
Thank you. Thank you, Dr. Kamran Farooq, for your brilliant presentation of neglected TL trauma. I would like to invite our another friend from India, Dr. Abrar Ahmed. He is the president of West Bengal Spine Society, India. He will talk on prevention of complications in ankylosing spondylitis.
Good afternoon. I'm going to start with a case. This is a 70-year-old lady, a diagnosed case of ankylosing spondylitis. She had a fall injury from the chair at home, admitted with severe back pain with power of 4/5 in the legs with no bladder or bowel sensations, sensory loss. This was a 3-column fracture at L2, L3 level. And what we did, we stabilized this patient. We did a minimally invasive fixation with cement augmentation in this patient. And patient was significantly free of pain and regained full power and was planned to shift to the ward. And from the ICU on the 4th day, except for the patient was having mild pain in the back and the neck. And on second post-operative day in the ICU, patient developed quadriplegia and neurogenic shock. And when we investigated, we found that she had a C6, C7 complete dislocation with complete contusion of the cord. Urgent surgery was done. It was a posterior fixation, cervicodorsal fixation was done. And after 3 days of the surgery, patient died. So it's very common in these patients to miss secondary injuries. And the lifetime incidence of the fracture in Eng-Spont patient is 5 to 15%, and injury to the posterior osteoligamentous complex is hallmark of these injuries. And around 65% of these patients have some sort of neurological deficit, and majority of these patients, they do not recover from the neurological deficit. The mortality rate is around 35% in various cities, and incidence of late onset neurological deficit is around 15%. So why there's so common fracture in these patients? Basically, these fractures are just like the fracture of shaft of the femur, and because of osteoporosis and altered disc mobility, ossification of ligaments, facet joint fusion, and progressive kyphosis, there is change in the biomechanics of the spine, leading to high incidence of injuries with the minimum trauma. Along with that, they have got impaired balance and coordination, problem with the proprioception and vestibular dysfunction. So it is very important once the patient they come to the emergency room, you always ensure that the patient will remain on the same bed except at the time of radiological investigation. Only then you will shift the patient from the bed, that too under the supervision of a senior person. You will never shift the patient from bed to trolley and trolley to the bed. that is going to cause secondary injury. Second thing is very important to maintain the preoperative alignment. Like this patient has come with the injury to the cervical spine, and it is very important, do not put any traction to these patients and or flatten the bed, but to keep the patient in the same position in which the patient was in the preoperative period. Second thing is that whenever you are doing the radiology, always supervise that thing. There should be always a senior person which should be present there, and if you see, our senior colleague is present there, and he will supervise all these CT and the MRI investigations. Sometimes the patient is so much deformed that it is very difficult to put the patient in the gantry. In those patients, you do not do the MRI, just do the CT scan, and do not forcibly do the MRI in these patients. And the majority of these cases, the X-rays, they just do not reveal 40 or 60% chances of showing without no injury in these patients. It's very common to have missed injuries. As I showed in the first patient, it's very important to have thin slice sagittal reconstruction, like in this patient, in which I showed in the first instance. There was an injury which we missed in the cervical spine, which was not visible in the recon images. And so you have to be very careful. Always assume if there is a lumbar fracture that there is a secondary spine injury, and do a thorough investigation in these patients. Second thing is very important, once you are doing once the patient is in the operation theatre, always do this, do not use the conventional form of intubation, do not allow the anesthetic to do that sort of intubation. Do them either with the fiber optic system or video laryngoscope. And you should always remain standing at the head of the table. You see that sometimes the anesthetic want to sit on the table. I am standing there always at the head. I will not allow the anesthetist to sit on the table, because we have seen one or two of patients, they have stayed on the table and they have aggravated the neurological deficit in this patient. So do not allow them. Second thing is that whenever you are positioning the patient, if there is a thoracic injury or the thoracolumbar trauma, always keep the cervical collar on, and patient should be positioned on the cervical prone in that with the cervical collar on, and never remove the cervical collar during the surgery. Another very important thing is that sometimes once you make the patient prone, the fracture opens up. So it is very difficult to position this patient on the table. So never use this sort of bolster. Always use the parallel bolster in these patients. Second thing we found very useful in these patients is when sometimes as I told you, this fracture that opens up on the prone position, so it's very important. This is our own method. We tie 2 or 3 pillows on the abdomen, so that once we are making the patient prone, the preoperative alignment of the fracture is maintained, and then this fracture do not open up. So this is the positioning and the preoperative alignment, and it is very important to do adequate fixation. It means these patients are osteoporotic. They may look sclerotic on the MRI. You have to go at least 3 levels up and 3 levels down, and try to do as minimal possible fixation as possible. So this is a 55-year-old male patient. The example of this patient had both cervical as well. There's an injury there. Plus, if you see, there's an injury higher up also in the recon images. So we did both the fixation in the thoracic as well lumbar spine in the same this thing. After 1 year, the patient had a fall injury. And
2 minutes more, sir.
Yes. And you see there's a fracture of the rod. And why this has happened, if you see, first thing is that we have used a soft rod in this patient. So always use a very stiff cobalt chromium rod. Second thing, we have not done any fixation. We have left this screw. We have not done the fixation on the right side, and that ultimately has led to the pseudoarthrosis and the breakage of this. So this was what was done, and we did the revision. We removed the rod on one side, put another rod on the second side. We put a connector there. So it is very important in these patients to do a community education, emphasize that these injuries are not normal injuries. In case of injury, do not use the conventional methods of mobilization. Education and training of the ambulance drivers, primary health care workers, emergency care technician, radiologist and emergency physicians. That is very important in these patients. Otherwise, they can do disaster in the emergency room. There is another example. You can see there's a comminuted fracture of cervical spine. You don't know what to do with this patient. So we have done the cervical posterior fixation, occipital cervical fixation in this patient, and we have used the cervical pedicle screw lower down. So it's very important nowadays. What we have started in these patients is personalized ankylosing spondylitis card that we give to the patient, and there's a number of a very senior person there. In case of any injury, they can call that patient on the important mobile number, or they can do a video calling of these patients, and then we can guide them how to manage how to immobilize the patient, how to transport the patient to the hospital to prevent the injury. Thank you very much.
Thank you. Now we're calling Dr. Mohammed Alam to talk about outcome of short segment pedicle screw fixation incorporating fracture vertebra in thoracolumbar spine injury and the observation in NITOR.
Okay. Next.
Oh, okay. Okay, then we move on to Dr. Huton Chandra Banik. Efficiency, safety and reliability of single posterior approach for unstable thoracolumbar burst fractures treated with anterior reconstruction and posterior instrumentation.
Respected chairperson, moderator, delegates from home and abroad, and their participant. Very good known. Backslide, please, backslide. Welcome to BSSCON 2023 and in my lovely Bangladesh. These are the recent development of our country, all of you know. I will talk on efficacy, safety and reliability of the single posterior approach for unstable thoracolumbar burst fracture treated with anterior reconstruction and posterior instrumentation. Unstable burst fracture means the burst fracture with neurological deficit where 3 columns are injured, kyphosis occurred more than 20 degrees, decreased the anterior height of the body over 50%, and the canal was compromised more than 50%. Thoracolumbar burst fracture is the commonest fracture that encountered most frequently in clinical practice, but there is still a controversy regarding the best treatment modalities. Fracture morphology, neurological status, and the surgeon preference play a major role in deciding the appropriate approaches. Combined anterior and posterior instrumentation provide the most stable repair, but use of both approaches on a trauma patient may increase the morbidity. Anterior reconstruction of the spine through only a approaches can provide an effective outcome. Total number of spine injury patients, 210 million per year. Among them, the thoracolumbar spine injury involved 90% and the burst subtype accounts 10 to 20% of these injuries. Male to female ratio are 3:1. Goal of this study is vertebral column stability restoration, kyphotic deformity correction, neural canal decompression, and early mobilization of the patients. Still, there is a controversy regarding the management of unstable thoracolumbar burst fracture, or the treatment is conservative or operative. The approaches is anterior or posterior, or the combined approach or the single approach, and the short segment and long segment fixation. Here I will show some radiological images. Burst fracture L1 treated nicely with the short segment fixation and immediate posteriorly regain of the vertebral body height, but in later on, then again loss of vertebral body height. Another radiology, burst fracture L2 treated with short segment fixation increased the vertebral body height, but in later on, rekyphosis developed. Another radiograph shows the burst fracture L1 treated nicely with the short segment fixation and increased the vertebral body height postoperatively, but in later on, breakage of the screws. Another bust fracture, L1, CT scan and postoperative X-ray nicely gain the vertebral body height, but in later on follow-up, the pulling out of the screws. In that case, fracture treated with the short circuit configuration in corporation with the fracture vertebra also, but later on what happened? Somewhere in the rod broken, screw broken, and sometimes the screw pull out. Here, despite the anterior reconstruction, we uses cement reconstruction to reconstruct the anterior column of the vertebra, but in later on the follow-up X-ray breakage of the rod. So how will you overcome this scenario? All of you know there is a new classification system, helix, where the
2 minutes more.
spine
2 minutes.
study groups. I'm not going in details of the helix classification, but one thing is when the score is less than 3, the treatment option is non-operative, 4 points the surgeon decision, and 1 point is more than 5, then surgery. Another classification system, McMahon's load sharing classification system, here the score is 3 to 9. When the score is more than 6, then anterior reconstruction is preferable, and score is less than 6, then posterior surgery. Number of patients of my study is 8, age 16 to 60 years, inclusion criteria unstable back fracture with neurological deficit. When the TLIC scores more than equal 5 and macro score more than 6, functional neurological status is evaluated by the ASIA score and BAS score, and radiological evaluation by the kyphotic score. Here I will show some case illustration. The BAS fracture L1, the CT scan and X-ray MRI. Here we decide the long segment stabilization with anterior reconstruction with case and bone graft. Another BAS fracture L3, CT scan and MRI. Here we decide short segment fixation with anterior reconstruction by the case and bone graft. Another case, BAS fracture L3, treated with the short segment fixation with anterior reconstruction with case and bone graft. Another case, BAS fracture L3, treated with the short segment fixation with expandable case. So the result is a mean improvement by the ASIA score 1.67, mean preoperative kyphotic angle that is increased from 25 to 5 degrees, and visual BAS score improved from 6.1 to 1.7, mean duration of surgery 210 minutes, and blood loss 440. Here one article shows 3-column reconstruction through single posterior approaches for the treatment of unstable thoracolumbar fracture. The technique was TRSP approaches is safe, effective, and offers some advantage over the conventional method. Another article, single stage posterior corpectomy in expandable case, placement for treatment of thoracolumbar BAS fracture. Here also some effective advantage. So I conclude this presentation. A single posterior approach is safe, effective, and reliable surgical approaches for reconstruction of all columns of spine. It reduces the post-operative time, blood loss, and morbidity associated with the combined approaches. Thank you all. And finally, I am grateful to my spine mentor, Professor M.D. Shah Alam, and another guide, Professor Dr. Jahidur Rahman, Associate Professor Shohid Akon sir, and Dr. Junaid sir, and also grateful these two institutes, Dhaka Medical College and Hospital, and only one APSS affiliated spine center, Bangladesh Spine and Orthopedic Surgeon. Thank you everyone. Thank you for patient hearing.
Thank you. Thank you. Jutun Chandra Bunik, our last presenter of this session here. Dr. M.D. Mahmudul Hassan. Its topics is challenges of surgical treatment of thoracolumbar BAS fracture in district level hospital. My experience. Mahmudul Hassan.
Honorable Chair and distinguished faculties from home and abroad and their colleagues. Assalamu alaikum and very good noon. This is Dr. M.D. Mahmudul Hassan, Assistant Professor Spine Surgery, Shatkhira Medical College, is going to present challenges of surgical treatment of thoracolumbar BAS fracture in district level hospital. When I was first posted from or transferred from NITO to Shatkhira Medical College, my condition just like Columbus, who first landed in ancient disorganized America. But I have dream to convert the disorganized situation into organized one like White House. But I faces lot of challenges, lot of obstacles when I started working there in spine surgery. The social obstacles, the obstacles from the patient party, patients, electronic printing media administrators, and from the hospital equipments, logistics, and other staffs also. And these are the challenges I faces to convince the people, the patient, to do surgery by me. They think this type of surgery is not possible at district level hospital. And I got a lot of patients, but most of the patients choose their, we know Satkira is just beside the West Bengal, and they choose the surgeons of West Bengal. Abra sir is here. And we convinced few people, patient to go in Dhaka, but the poor patient can't afford Dhaka or West Bengal, and we did the surgery there. And there is, in government hospital, there is no facilities to do the spine surgery, but I had the dream to start a separate spine unit there. And I did only 13 cases in 1.5 year in my private center. Approximately 90% of all spinal fractures occur in the thoracic and lumbar spine. Bust fractures are comprised as 14% of all spinal injuries. And these are the common causes of thoracolumbar bust fractures. Fall from tree, fall from height, road traffic accident, and sports injuries, and fall in the bathroom. And I use Asia impairment scale and TLX scoring system for my cases. And in TLX score more than 4 is definitely undergo surgery. And if 3 or less, we can treat it conservatively. And 4, handle conservatively or surgically. And my first patient, TLX score was 7. And this is the patient, Asia score was B. And this is the MRI and X-ray. And I did the surgery. And in this case, I faces the practical problem in the operation theater. Before this case, I individually not repaired the durometer. I seen from my professor, Professor Shalom sir, and I did in my first case. And this is the patient, follow-up. And this patient in follow-up period, several times asked the patient party, when my patient will walk. And now the patient is normal activity. And this patient can do his day-to-day works, what he did in his previous life. And second patient, TLX score was 7. And this is the patient, and Asia grade was...
You have only 2 minutes.
Asia grade was C. And this is the paraoperative pictures. And this patient also can do his normal work. He was an electrician. And he fell from doing his work. And this patient, TLX score was 8. This is a auto rickshaw puller. And Asia score was also B. And this is the MRI and this is X-rays. And this is the paraoperative pictures. And we did long segment fixation in this case. And now he can do his previous work, rickshaw puller. And this is the institute from where I born. And I am very much grateful to all my teachers of NITOR, especially Professor Gonimullah sir, Professor Shahidul Islam sir, Professor Jahangir Alam sir, and Professor Qazi Shamimuzzaman sir. And this is the institute from where I grew up. This is the medical college where I am posting, and this is the place where I am doing my private practice. And this is the man from whom I learned all my spine surgeries. He is the father of spine surgery, I personally believe, in Bangladesh. Surgical treatment gives better correction of kyphotic deformity and greater stability and perform direct or indirect decompression of neural elements. I want to give emphasis that decompression of the neural elements dictate the final outcome of the motor and sensory function of the patient. And surgical treatment decrease the immobilization and early return to works. Thank you. Thank you so much for patience hearing.
Thank you. Thank you, Dr. Mahmood Hassan Polash, for your brilliant presentation. So we conclude to end of this session. We will allow one question for each speaker.
Sir, before that.
Yes, yes. So before that, Secretary General wants to say something.
Thank you, sir, for giving me the opportunity. Dear audience, this year we have make some changes by our EC that you have already seen the placard, and every person should be seated in their own seat. Don't cross to from another seat to other seat on things. And we have lunch symposium like international forum, and in a lunch symposium our session will be on osteoporosis and fragility fracture. So we will take our lunch at the same time the symposium will going on. So you should be seated in your own seat, and already arrangement of the seat is going on, and everything, food and everything is coming within 10-20 minutes. So don't be crossed from your seat to other seat. Please be seated. Okay, thank you, sir.
So there is question from you ask question, please. Give your identity. Dr. Fazul Haq in front of you. Give him mic, one mic, please, for asking questions. There is mic in front. There is mic in front.
Thank you. It's Faisal Hassan from Birmingham. My question to Dr. Bonig, who is working in my beloved medical college. All the failure you have shown is a short segment fixation failure in the thoracolumbar fracture. And your answer is going anteriorly. Have you thought about going a long segment fixation, then reduce the failure rather than going anteriorly?
In addition to this, I want to add one. Yes, in addition to this, why you have not included fracture vertebrae in your fixation, including short segment fixation, including fracture vertebrae? It gives stability, and where you cannot go anteriorly.
Next session, sir, please.
Thank you, sir. For Dr. Shohid sir, actually short segment fixation incorporation of fracture vertebra, specifically there is some criteria. When the pedicle is intact, then we decide the short segment fixation incorporated with the fracture vertebra. It is a better stability than short segment fixation alone. So then we consider short segment fixation with incorporation of the fracture vertebra. I think it is stable. Sir, long segment fixation for the thoracolumbar burst fracture definitely better than the short segment fixation alone. Actually, in that case, only 8 cases we analyze where the short segment cases are failed with us. Then we consider the short segment fixation with anterior reconstruction or long segment fixation with anterior reconstruction. Specifically, when the TLE score is more than 6-7 or the Macron score is more than 6-7. Then we consider the anterior reconstruction with case or the expandable case.
Your fixation, if it's a T12 fracture, T11 fracture, and your last screw is T12,
we will have
it is bound to fail.
Excuse me.
Yeah, so
hello.
Go for long segment.
Excuse me.
Rather than anterior.
We will have a discussion about this debate in a second, so maybe postpone it. Huh?
There is a debate in later on.
Regarding this, actually you've shown these all 6-7 cases.
Mic sound please. Mic sound please.
Short segment cases. Do you know why these cases is failure? So I am giving answer. the failure, because you put it the screw half of the vertebra. Almost all the cases I have seen very carefully, it was in the half of the vertebra, nearly more than half. And the screw size was also 5.5 or 4.5 like that, but it should needed the 6.5. So my explanation is that if you put the screw, all the 360, I mean this from the posterior to medial to anterior column,
Silence, please.
the cortex.
Silent, please.
And
Silent,
at
please.
the same time, the proper size, proper diameter screw, and all the flexor vertebra, when the pedicle is intact, I think failure is very unlikely, in my experience.
So, যারা খাওয়া দাওয়া করতেছেন প্লিজ আপনারা একটু শব্দ করবেন না প্লিজ ডোন্ট মেক এনি সাউন্ড প্লিজ বাইরের লোকজন আছে আপনারা একটু বোঝেন না একদম চুপচাপ উইদাউট এনি শব্দ ছাড়া আপনি করবেন প্লিজ
যার যার সিটে বসতে এত শব্দ কেন খাওয়া তো শুরু হয়নি এখনো
Any question is allowed, Professor Shahidul Islam?
Yes, one question.
So one question for Abrar, Professor Abrar Ahmed. So thing is that in your, I mean the ankylosing spondylitis, usually it requires the global fixation. What is your experience in your practice? All the time you reconstruct both anterior and posterior?
Usually what happens, majority of these injuries, they happen in the cervical spine. And the issue with the cervical spine is that if you do a short segment fixation and go from the front, majority of the time that fixation is going to fail. But the difficulty is that in some patients, your neck is in, in the flex position or kyphotic position. It's just not possible to go from the front. Second thing is that sometimes the neck is very short. So it's very difficult to approach the spine from the front. We have got a protocol. If there's a complete neurological deficit, just go from the back side. You're not going to achieve anything. Spinal shock is over, there's a complete quadriplegia, do a long segment fixation posteriorly. Second thing, if there's no neurological deficit, then also go from the back side and fix it. But if there's a partial neurological deficit, try to go from the front, decompress from the front, put a cage and a plate there, and then flip the patient back and do the fixation from the back side. Otherwise, there is a very high incidence of implant failure because the osteoporosis plus lot of stresses at the cervicodorsal junctions.
Thank you very much. So we have the honor to have, 1 minute, we have the honor to have among with us as your co-chairperson, Mr. Klaus Snake, and he's the chair of this spine sections of German Orthopedic Society. So he will ask some question to some speaker, please.
Well, thanks. I have a question to all of you because mostly all of you cited the TLIX classification. And TLIX classification is something we in our environment have not used and do not use. And to my knowledge, it's changed a little bit worldwide because the issue with the TLIX is if it comes to the most controversial fractures, the burst type, you get only 2 points. And that would mean that a burst type fracture without neurological deficit doesn't need surgery, which is an option, but which doesn't reflect the international meaning because worldwide, and that's why we implemented in the aerospine classification the difference between A3 and A4, which is actually what I did. That's my part of this classification is to discriminate between A3 and A4 because we think there's a watershed. And worldwide, the majority of surgeons perform surgery for A4, but not necessarily for A3. So I think there's a weak point of the TLIX classification. So my question is what do you do with a patient who has only 2 points, but has severe comminution, 30 degrees of kyphosis? Do you follow TLIX and treat him conservatively? Or what do you do? Whoever wants to answer.
So actually, as I understand, you're talking about burst fractures without neurological deficit. So actually, the safest thing is to get an MRI done and look at the PLC. If what we have seen from our experience is that if it's highly comminuted And if you don't treat it surgically, in long term it goes into kyphosis. So to preempt that, have a look at the MRI. If there's a injury to the PLC, what we do is we go MIS and just fix that fracture. That's what we do. Because what we have seen that even if the patient doesn't have neurological deficit, obviously if the patient has a deficit, all the spine surgeons would operate. So the question comes about a burst fracture which doesn't have a deficit. So I mean that's the protocol we follow. I mean if the patient, I gave a thesis to one of my residents on MIS, short segment fixation for burst fractures. And the failures we got were just like Dr. Saab here had shown, that short segment fixation, if it's highly committed, they do fail, unless you put a screw into the or do a anterior column reconstruction. So I would always get a MRI done, and on top of that, if I feel that the vertebral body is more than 50% collapse or there's significant kyphosis, I would still go in for surgery.
Thank you. Probably last question from Dr. Fadul.
Can I answer that question from
Honorable Chairman, sir?
Yeah, I think, if my opinion, if let's say you're talking about A3 fracture, so this one comes from either I divide my mechanical instability or neurological instability or combined. So if you look at the mechanical instability, if let's say you look at the X-ray and CT scan, but if the patient had progressive neurological deficit with substantial canal compromise, that's now I will give an indication for surgery. If not, I will not do the surgery for them.
Sir, can I ask a question, sir?
Fadlul Haq, sir, please. Fadlul Haq. Probably it will be the last question. Dr. Reza, sir.
Have you faced any patients of neglected cases? There is a severe kyphosis as well as there is a fusion over there back. And if there is any fusion of part of the bone but the kyphosis, then what you want to do?
Sorry, repeat your question. I didn't understand.
Neglected cases, but they have fusion.
Yeah, of course. Yes.
Yeah. So in that particular situation,
that's what I said in the presentation, that you have to mobilize them. Either it's a disc or ligaments or even bony fusion. So we osteotomize them. I mean, you have to do a complete release. Otherwise, it's not possible to get the alignment back.
And then you correct it. Yeah.
The only one case like that thoracic spondyloptosis which I showed, original plan was to resect the body anteriorly also. But since the kyphosis was maintained, patient didn't have any deficit, I didn't want to go for such a major surgery, and that patient in situ fusion, that's why I did.
Yes. Oh, Reza sir, please.
So, Reza, very short question, Reza.
Short question. Thank you, Kamran sir, for your nice presentation. One new case shown, there is spondyloptosis at the D10, D9 level, it's the cord level.
Yeah.
There is no space for cord, but spondyloptosis patient has no neurological deficit. What is your comment about
I mean, that's what I said, that it's a very interesting case. The reason being that at almost 3 or 4 levels, the patient had a consecutive pedicle fractures. So just like in spondylolisthesis, systemic type of spondylolisthesis, we have pseudo widening of the canal. So even in that case, the patient, the vertebral body shifted anteriorly, but all the posterior elements were lying back. There was a pedicle fractures at multiple levels. So that is the reason why that patient didn't have a neurological deficit. Otherwise, obviously, I mean, if the vertebral body is intact, that patient is bound to have a deficit. So fortuitously for that patient, it didn't have any deficit because of pedicle fractures at multiple levels posteriorly.
Dr. Arif Khan, are you with us? Hello? Dr. Arif Khan from Pakistan, the Secretary General of Asia Pacific Orthopedic Association. Hello? Sorry, we lost him. He was a brilliant presentations. Unfortunately, we are unable to show all the presentations due to some technical problem. Mr. Klaus, you conclude the session.
Well, we've heard interesting lectures. Thanks you very much. So different issues, different problems, post-traumatic, hidden fractures, etc. Difference between A3 and 4. And,
এখন তো ডিবেট আছে আপনারাই তো চেয়ারপারসন
let's move.
Okay.
And I would like to thank all the contributors for their efforts here and, well, enjoy lunch. Thank you.
No. Thank you.
Later
Thank
on.
you so much. Thank you, my chairpersons and all presenters here. We chairperson and moderator in here, but our speakers take your seat. You have many more questions, many more debates. So this is time for debate. Some of us of short segment, some of us long segment. There are two presenters here. First presenter, Dr. Aksadal Mamun Masur Anon, he is in favor of short segment. And next presenter, Ozedem Dastagir, he will in favor of long segment. So first presenter, Aksadal Masur Anon.
Anon.
Short segment is the option, optimum. Okay, go on.
হোটেলের লোক যারা আছেন তারা যে প্রত্যেকটা টেবিল থেকে আমাদের লাঞ্চ কুপনগুলো কালেক্ট করেন। হোটেলের যারা দায়িত্বশীল আছেন প্রত্যেকটা টেবিল থেকে ফরেনার্স বাদ দিয়ে আমাদের সবার কাছ থেকে কুপন কালেক্ট করেন।
So again, welcome to a bit different flavor of presentation and very good afternoon to everyone. Though there is no debate actually about the management of thoracolumbar burst fracture after previous presentations, but still debate is continuing. So welcome to debate on short segment fixation versus long segment fixation in case of management of thoracolumbar burst fracture. So this is a case of lumbar 2 burst fracture and it is managed by short segment posterior fixation with cross links and the same level fixation. So my chairperson, faculties and my colleagues, today is my issue is on management of thoracolumbar burst fracture. Short segment is optimum. So debate is theoretical, but we both are spine surgeons and friends forever with Dr. Dostogi. So thoracolumbar injury is the commonest injury of the axial skeleton, accounts for around 90% of all spinal fractures. 65% of thoracolumbar fractures occur due to motor vehicle injuries and fall from height, with remainder contributed by sports injury and violence. So unstable fracture defined as failure of any two-column injury including middle column. Conservative treatment is usually the method of choice. Effective correction of deformity, neurological recovery, early mobilization and return to work are the fundamentals of the surgical management. So mechanism of injury, traction injury, direct injury and indirect injury, we all know about that. So now come to the classification. Classification actually starts from 1930 to 1940, but nowadays after 2000, the latest and acceptable classifications, especially the AO classification and TLIX classification has come. So this is the AO classification, type A, type B, type C, and we already told about that by the previous presenters. And this is the picture of the AO classifications. So another classification is Dennis classification, minor, major, and burst fracture, jackknife injuries, chance type, and fracture dislocation. So this is the TLIX classification, which is very important, and according to TLIX classification, according to scoring, we can manage the thoracolumbar burst fracture. So indication for surgical intervention, aim of surgical treatment is to improve neurological deficits, to reduce the deformed spine and to prevent kyphotic deformity. And indication for surgical intervention, incomplete neurological deficits, kyphotic angle more than 25 to 50 degree, and more than 50% of loss of vertebral body height and more than 40 to 50% of canal narrowing. So according to TLIX, if score is equal to 4 points, either management should be non-surgical or surgical. And if the score is more than 4 points, then management should be surgical. So there are so many articles on behalf of short segment fixation of thoracolumbar burst fracture. So these are the articles And all those articles, the current status of short segment fixation in thoracolumbar spine injury is documented. Posterior short same segment transpedicular screw fixation of the single level fracture provided satisfactory surgical and functional outcome. So Bolesta et al. Documented that a short segment construct with pedicle screws at the fracture site showed equivalent biomechanical stability compared with a conventional long segment construct in any of the loading conditions. Kana et al. Found that reduction of unstable thoracolumbar injuries can be achieved and maintained with the use of short segment pedicle screw fixation, including the flexor vertebra, and resulted in significant improvement of preoperative kyphotic angle and wedge angle with significant improvement of anterior posterior vertebral height. Thank you. So the advantages of using pedicle screws to treat flexor vertebra include the following. It provides a good 3-point fixation. It reduces the parallelogram effect to increase the stability. It avoids stressing the normal intervertebral disc, and it dispenses the stress of the pedicle screw connection. So a review of published studies showed that an immediate correction of kyphosis angle ranging from 6 to 21 degree is achieved after short segment instrumentation. So this is another important classification for Sanders classification of traumatic intervertebral disc lesion. So for my opposition younger brother, short segment posterior fixation for thoracolumbar burst fracture has been widely used because of its minimally invasive technique and efficacy in reducing kyphotic deformity while preserving the motion segment. Postoperative segmental kyphotic angle and anterior vertebral body height ratio are significantly higher in patients with preoperative Sanders traumatic intervertebral disc lesion grade 3 than grade 0 to 2. So short segment posterior fixation is for selective patients. Risk factors for loss of correction after short segment posterior fixation for thoracolumbar burst fracture are severe disc and end plate destruction at the time of injury and older age. So attention my brothers, short segment posterior fixation is a popular method for spine surgeons, always minimally invasive, less time consuming, cost effective, short hospital staying, and always in selective cases. So my dear opponent, younger brother, I know you will talk many things on behalf of your issue, but that doesn't matter. If we follow the principle, then short segment posterior fixation would be the optimum option. After your presentation, I won't have any scope to talk something on behalf of me, but I would like to boldly tell about short segment fixation in selective cases, and that is optimum. So thank you very much for your
Thank you, dear Anand, for your brilliant presentation. The next speaker, Dr. Ojedem Dastogi from Bangladesh. He will talk on long segment is the best.
Thank you, my dear brother, Dr. Anand Bhai. He is very much confident about his procedure, that is short segment is less time consuming, cost effective, and less hospital stay. But my dear brother, he forget about the failure of the short segment, that is long-term follow-up in a literature, there is long-term follow-up results of short segment. There is a screw pull-out, rekyphosis, and failure, implant failure. And in a literature, there is the early failure of short segment pedicle instrumentation. There shows that vertebral wedge angle is more or curve angle ratio is more, then screw pull-out, failure and rekyphosis will be more. And if you go through the AO classification, that is thoracolumbar burst fracture, that is A3 and A4. According to the loss of failure of the short segment, McCormack devised a scoring system that helps us to risk of failure of short segment construct. That is degree of kyphosis and degree of vertebral body combination and the apposition of vertebral fragment. And according to this classification, if the score is more than 7 or more, then we can go for long segment or anterior reconstruction. So our goal of treatment to protect the neural element, to prevent the correct the segmental collapse or deformity, to prevent the spinal stability and pain, and permit early embolization and restore the normal spine mechanics. So in another literature shows that short segment posterior fixation alone can lead to 9 to 54% incidence of implant failure, rekyphosis in a long-term follow-up, and 50% of patients with implant failure had moderate to severe pain. In another journal, there is a reports on the use of short posterior fixation for bus fracture describe high rates of failure in fixation and kyphotic collapse. And if we go through another journal, there is a short segment pedicle instrumentation had a high rate of failure, and in their report, the early failure of the short segment pedicle fixation noted 3 kinds of hardware failure, that is progressive kyphosis and kyphosis secondary to osseous collapse and segmental kyphosis after a corded screw in the lumbar construct group. And if we go to there are many more journals, that is use of 4 pairs of screw that lengthen the arm of the lever arm of the construct and probably not only the enhance the stability but also effective in reduction of the kyphotic deformity. So thoracic short segment fixation provides significant less stability and then long segment fixation. In long segment fixation is the best option because it is better stability than short segment, and it realizes the integrity of the posterior ligamentous complex and can resist rotational and shear forces that causes instability. And it is a lower rate of implant failure and loss of correction than short segment. And it is in severe vertebral collapse or retropulsion of the bony fragment into the spinal canal. Long segment fixation, there is a more easily decompressing the fracture fragment and correction of the kyphosis. It is a better reduction applying distraction and ligamentous by using longer rod and follow the natural contour of the spine. So it is better neurological outcome. So in conclusion, you can see that long or short fixation is not a matter of debate, but it's a matter of necessity. When pedicle is intact or fracture vertebra, no kyphotic deformity, then we can go short segment. But in case of F4 or there is a thoracic segment or thoracolumbar segment, we must go for long segment. I think in real life, Mr. Anand is very much fond of long type of fixation, and I think you will agree with me that is long segment fixation is the best for thoracolumbar spine trauma. Thank you very much.
Thank you, Dr. Dastogir, for your presentation also. So now with the chairperson comments, I am also agree with you. There will be no debate between short segment fixation and long segment fixations. You will do according to necessity, according to indication and contraindication. You mentioned that according to load sharing classification, more than 7 score demands for long segment fixation. But Professor Rajashekaran and her colleagues published a paper and he proved that long segment, instead of long segment fixation, short segment fixation with incorporation of the fracture vertebra gives same stability as long segment fixations. And there are many publications from Chabra and Rajashekaran and colleagues and all over the world. They given there is a short segment fixation is one of the choice, including fracture vertebra, where indicated and where contraindicated. There is other indications for long segment fixations. And my co-chair is a very senior and as well as renowned spine surgeons all over the world. Personally, I prefer AOC's classification and scoring system given by Alex Becker in 2016. He incorporated AO fracture and scoring system like TLIX. He also gave the TLIX in 2005. So I hand over my mic to my co-chairpersons to comment on it.
Thank you, Shaidul. With regard to the question whether to put it short or long, I think it depends on several issues. First, the location of the type of the fracture. So what kind of classification, A3, F4, or do we have a PLC injury? Second is the location, the lower lumbar spine. Most likely there's no need for a long construct, but the higher you get, thoracolumbar, etc., then a longer construct might be useful because the lever arm is different, the load sharing is different. Third is bone quality. Bone quality is of course important, but if you have weak bone, probably you need more screws to fix it. Then we have heard from you already, apposition of the fracture fragments and comminution. Very important, because the higher the comminution, the more destroyed the vertebral body is, the more support you need. And finally and lastly, the kyphotic situation. So all this has to be taken in account. That means that an A4 fracture can be an A4 fracture or an other A4 fracture. So we always have to check the X-rays, see the CT scans, ideally have a standing upright X-ray to see how kyphotic the situation is, and then decide whether to put it long or short. I personally think that we should keep it short as often as possible in order to avoid to fix segments which could theoretically move, and in order to decrease the amount of soft tissue disruption we perform, but in some cases it's not possible. In our environment, we always stay short, but we put anterior support. So in Germany, we typically just do short segment fixation with monoaxial screws percutaneously, and then go from anterior and replace the vertebral body if it's really severely comminuted. So that's a different approach. So the question is always, if you don't go anteriorly, then you have to decide whether to stay short or you have to do it long. And that's what I said are the reasons why you have to judge it. And I think both of you are right. Yeah? And, but we have to look in detail what kind of fracture we have, what kind of patient we have. Thank you.
Thank you. Thank you, both of our younger brother. You done a lot here. Thanks you both all. Our next case-based discussion topics is cervicodorsal junction trauma, and presenter is Office Secretary of Bangladesh Spine Society, Purvash Chandra Saha. Please come to the dais.
Everybody is hungry, right?
Thank you.
So be cool. I will be rather short. Before going to the case discussion, I must thank to Mr. Dr. Ankur Rando, who is a senior consultant of spine surgery in Indian Spinal Injury Center. He is my ex-colleague while doing my fellowship, and actually he shared this case. An ankylosing spine is an altered spine. Probably there is no disagreement regarding this statement. Because there is some altered biomechanics through a chronic inflammatory process, so the spine becomes brittle, deformed, minimally compliant, as well as there is some crucial transformation from a highly efficient bony articulation to a long bone-like rigid lever. And ultimately it becomes highly susceptible to fracture, leading to neurological devastation, as we know. So it is fragile because there is simultaneous ectopic bone formation as well as osteopenia. And there is typical non-physiologic kyphotic deformation as well as impaired gaze, which poses the patient to higher risk of fall, leading to fracture. And my case is on CT junction fracture in an ankylosed spine. CT junction is unique in terms of location. It is located in between the C6 to T2 because unique location, unique biomechanics, as well as unique imaging appearance. And very often, the fracture site is missed in plain radiograph. So, the timely and accurate management depends on the high index of suspicion, use of appropriate imaging techniques, as well as attention to adequate imaging. And there is some recommendation regarding the management algorithm. I am not going in detail. Let us go to the case. A 43-year-old male who was a diagnosed case of ankylosing spondylitis had a trauma 3 months back on a road traffic accident, diagnosed as a case of fracture at the level of the C7-T1 and as well as D9-10 with HFB neurology. Actually, he operated somewhere else 3 months back. And that it is the immediate post-operative photograph fixed only anteriorly at the level of the C7-T1. But the level, at the level of D9 and 10, it was managed conservatively. And he presented after 3 months to the late second center. And with a history of new neck pain, dysphagia, gradually increasing weakness of the both lower limbs, and examination, there was localized tenderness over the C7 and T1. The muscle tone was increased, Muscle power in the upper limbs was almost normal except at the level of TC8 and T1. But in the lower limbs, it was 0/5. Sensory was diminished below the level of D4 and bladder was involved. Plantar response was extensor and there was present perianal sensation, but the voluntary anal contraction was absent. This is the first MRI after surgery. So you can, this is very much obvious, that is complete disruption of the fixation site. And this is the closer view, you see. And this is the first CT, the total disruption of the upper column from the lower column here with implant failure. So, the dear learned audience, I just want to invite some opinion regarding the previous management. So, may I ask our Honorable President of Bangladesh Spine Society regarding the previous management and what is your plan for the next?
Usually in ankylosing spondylitis, a fracture, it requires a global reconstruction. So only the 2 screws is not sufficient because the already paralyzed patient. The same thing also in the the mid-thoracic probably, if I'm not wrong. So if the first the reconstruction and stabilization, if is strong enough, then less chance to develop your the failure case. And patient doesn't have any neurology, right? Already paralyzed?
Yes, Asia B.
Asia B. Still then the patient needs your that stabilization. Because how many days old? I don't know. If it's
at that time the injury was 3 months old.
3 months old. Even that if the MRI and other it is seen that the compression over the spinal cord.
Yeah, there was huge compression, sir, as you see.
Definitely it needs a decompression, wide decompression, and it should be stabilized globally, both anterior and combined. Posterior, that's my opinion.
So there was no debate about the conservative management. There is no scope of conservative, I think.
And I think to me the posterior approach stabilization is first, then you'll go for anterior.
Yes, sir.
May I ask one question to Dr. Saha? May I ask one question?
Yes, please.
Yeah. Sorry, this is a very nice presentation, but I want to inquire about the case in which you did C7D1 SADF. In that case, did the Smith-Robinson approach was sufficient, or you have to do an extensile approach?
Yeah, actually, it was managed somewhere else.
Okay.
Probably they did not address the situation properly. So the scenario became like this. So we want to go forward with this patient. And so as we're seeking your opinion. So Sir said we should go for global fixation.
In your dorsal level, there is, I think it is Anderson's lesion. In that situation, it should have to be fixed in a longer construct.
Yes.
And definitely wide decompression.
We shall see that later, sir.
Yes.
Sir, please.
Thank you. I was just going to make a small point. You described that as implant failure.
Yeah.
That's not implant failure. The implant was fine. It was surgical failure.
Yes.
It was a bad decision,
Yes,
and that implant was never going to work. So we need not to blame our implants when it's our fault.
Thank you, sir. So let us, yes, sir, please.
Hello, I'm Dr. Hong from Thailand. I have some experience in this case. This case, at first they will feed, in this case, this is double fracture, right? That some associated disease like DISH. This is the like as a long bone. That at first operation you will fix with short construct. It's not enough. I prefer you use the posterior construct with the long construct because this patient is related with DISH, diffuse idiopathic sclerotic hyperorthosis in this patient, DISH.
Yes. Thank you, sir. So let us see what happened next. So there is no point of conservative treatment. Anterior alone? Anyone, sir? Posterior alone? Both. Okay, let's proceed. This happened actually. There was a long construct there is removal of the anterior implant as well as long posterior fibrosis on C2 to D3. And 3 weeks later, the injury over the thoracolumbar fracture was fixed with a long construct. You see, at least 6 level was involved. So God was great. Immediately after the surgery, there was a sign of neurological recovery. Toes were moving, patient started active rehabilitation, the further increment of the motor power, and the gradually recovery of the bowel and bladder. So we are happy. But that is not the end of the story. 2 months later, somehow the God was annoyed with this. Okay, anyway, patient complains of increasing leg pain on the left side, feeling of weakness of the foot. He was giving history some clicking sound during his rehab in the lumbar region. X-ray was done. At the L2 and L3 level, there is some disruption. And in the lateral view, it is more evident, I think. So, fracture at the L2-3 level. So, what to do next? Kamrul sir, please. Yeah. You want to extend the instrumentation, right? Dr. Faizul, please. But he complained with some associated claudication weakness. But actually, unfortunately, I didn't get the MRI. It was done. But may we proceed to what happened next? So there was extension of the instrumentation, right?
Dear presenter, please proceed. Your next slide, please.
So there is extension of the instrumentation from L1 to L2 to L4. So I think everybody is happy with this, right? So that is not the end of the story. Two years later, patient complains of aching low back pain, clicking sound on changing posture, claudication, gradual weakness of the both lower limbs. And here is something changed at the level of the L2-3. There is some lucent area developed probably due to. What is your opinion? What might be that, sir? Dr. Peter. Okay, let us see. So it is more evident. Loosening of the screw side. There is a halo. And on CT is more. There is some vacuum phenomena. That means pseudoarthrosis had happened. This is the neurological status. Below L2, there is significant loss of motor power. So, what to next?
Go rapidly, please.
Sir?
Continue.
Running short of time.
And interbody fusion was done on anterior approach. LEF was done. Along with extension of instrumentation after the S1 level. This is the 10 months follow-up. So sign of consolidation. There's the 4-year follow-up. It did not fail actually. So this is the end of the story.
But I think this is not the judicious decision. It was not the judicious decision.
So can you put your opinion, sir?
Definitely. As there is loosening of the screw, and it was the posterior construct only. In that situation, you should not go from the front side because there might have some infections or microinfections around the screws.
So how would you want to approach the pseudoarthrosis?
Yes, simply you can remove the screw from the L1 or L2, whatever maybe, and you do the facetectomy from the posterior side, unilateral facetectomy, and even make fusion from the posterior side. With this case, from the anterior side, it was not judicious, I think.
Okay, thank you, sir. And so, the take-home message is, adequacy of imaging is a key in managing fracture cases in case of an Eng-Spondy patients. Positioning is critical. What Dr. Abarsa has mentioned regarding this patient, positioning the patient is very, very crucial. It may cause lots of secondary injuries. And thank you very much for patience hearing.
Thank you, dear Prabhash.
Let us have the lunch.
We come to the end of this session now. I will conclude the sessions. Dear Deputy, you invite the next Shahid Akon. You invite the next chairperson and co-premier.
Okay.
Okay, Dr. Anwar.
Thank you so much.
Dr. Saiful Islam.
Thank you all of my presenter, especially our Prabhash. You are a good case, but shortest of time.
Yes.
Thank you. Thank you so much.
Now, our lunch symposium. Lunch symposium. আমি হোটেলের বয়দেরকে বলছি এবার খাবার পরিবেশন করেন। খাবার নিয়ে আসেন, টেবিলে টেবিলে পরিবেশন করেন। আপনাদের সবার নাম লেখা আছে স্যার, দেখেন 1 এবং 2 নাম্বার টেবিলে। Okay, fine. But I'd like to request Dr. Saiful Islam, please come to the dais.
Yes.
Dr. Saiful,
Yes.
please come. And your chairperson is Dr. Chinmoy Nath and Dr. Ghulam Sarwar, please come to the dais.
Okay.
We will provide your food at the dais. Okay, no problem. We will provide.
Thank you, Anwar sir. Respected teachers, distinguished guests, learned participants, Assalamu alaikum and very good noon. You are all welcome to this first ever lunch symposium session, which is osteoporosis and fragility fracture. This is the new session in the Bangladesh Spine Society conference. I thank Bangladesh Spine Society for newer session. You are all welcome to this session. You enjoy the session and take your lunch. I am requesting today's chairperson, Dr. Chinmoy Nath and Dr. Mohammad Ghulam Sarwar to conduct the session. Thank you very much.
Good afternoon, everybody. I think everyone feels hungry. This is lunch time, but it's a very important topic to be discussed in the lunch symposium, that is osteoporosis and fragility fracture. And our first speaker is, please give time and please be quiet. Our first speaker is none other than Dr. Klaus from Germany. He is chairman of the German Spine Society. He will speak on classification and treatment of osteoporotic thoracolumbar fractures. Dr. Klaus, please.
Ladies and gentlemen, dear chairperson, dear colleagues, thanks for having me. I would like to express my deep gratitude to be invited to your conference here. It's my first time in Bangladesh. I would definitely say thanks to Shah Alam as well as Shahidul Islam. Thank you for having me. My talk will be about classification and treatment about osteoporotic thoracolumbar fractures. I'm an orthopedic as well as trauma as well as general surgeon. I'm sharing the EOSPI knowledge from trauma, and one of our goals was to develop further classifications with regard to osteoporosis, and therefore we'll move on. Before I start with the talk, I would just give you an overview where I am from. The town where I'm working is Erlangen. Erlangen is in Bavaria in southern Germany, close to the city of Nuremberg. Nuremberg is a small city in comparison to Dhaka. It has just 500,000 inhabitants. 110,000 live in Erlangen. This whole area has roughly 2 million people. My department, we perform roughly 1,000 spine surgeries per year from occiput to the pelvis, mostly degenerative deformities as well as traumas and some infection tumors as well. We are relatively equipped with latest technology like robotics, navigation, O-arm endoscopy. Tomorrow I will give a short presentation about robotics, and I will present a case of a severe deformity as well. And since we are the most experienced center in robotics, with regard to robotics in Europe, we've become the reference center for the Mazor technique in Europe.
আমি আমাদের বাংলাদেশে পার্টিসিপেন্ট যারা তাদেরকে অনুরোধ করছি আপনারা কথা একটু কম বলেন देयर इज अ প্রেজেন্টেশন আমরা প্রথম এই যে লাঞ্চ সিম্পোজিয়ামটা করছি আপনারা এটাকে সম্মান করেন এটা খুব ভালো প্রেজেন্টেশন হচ্ছে আপনারা একটু শুনেন প্লিজ
Thank you. Osteoporosis might be far away from you, but it's actually an issue we'll face already. And when you see the number and percentage of the age of the population above 65, you will see that this will steadily increase. So even in countries like Bangladesh, where the average age is, I think, something like 27, so people will get older. And this will lead to the situation that soon, even here in Asia, you will have a kind of tsunami of patients having osteoporotic vertebral fractures. The numbers here on the right side show you more or less that the numbers of fractures will be six-fold increase within just 50 years. So these fractures will come even to Asia Pacific and will cause a lot of problems. So osteoporotic fractures differ a little bit from normal fractures. And the most common type of fractures are either A1 or A3. Highly unstable fractures are rather rare, as well as neurological deficits. On the other hand, progressive kyphosis is quite common, especially when the T-score is below -3. And they show different morphologies and different courses, natural courses in comparison to healthy bone fractures. They can still go on and kyphose over time. So fracture morphologies differ from healthy bone fractures. They can change to sometimes highly unstable situations, and it doesn't depend whether the patient has a fracture due to a trauma or just an insufficiency fracture. You cannot distinguish this by just looking at X-rays or CT scans. They look the same, but they behave a little bit different. Most important clinical parameters on the other side for the patients are pain and the mobilization. And with regard to treatment, we have to confess that the comorbidities those patients typically have may alter our treatment decisions. The majority of patients definitely will get conservative treatment still, but there are several risk failures for failed conservative treatment. This you have to keep in account, especially if the T-score is below -3, if they are rather frail, and certain fracture types like the A4 fractures, like initial height loss, this intravertebral clefts, which you can sometimes see if they have already a decompensated sagittal balance, and some specific MRI types. So if you see something like this, you should consider maybe surgical treatment. Over the last almost 12 years, I led different groups in Germany as well as international, and we were looking for a new classification for osteoporotic fractures, thoracolumbar fractures. Since the fracture classification would exist were not really made for them, like AO, etc., they were not really made for osteoporotic fractures. So in a combined effort with the AO spine plus the Orthopedic and Trauma Society in Germany, we developed a so-called OF classification. It's a relatively easy classification. It has only 5 subtypes, and I will explain it to you now in a little bit more detail. It starts with a simple bony edema and ends up in severe deformity. It reflects the typical osteoporotic fracture morphologies, and it's based on CT scan, MRI, and X-rays. Use this classification if patients have an insufficiency fracture, or if they have a trauma plus a known osteoporosis. All the other fractures are still going to be classified according to the normal AO spine thoracolumbar fracture classification. As I told you, the fracture classification contains 5 subgroups, O of 1 to O of 5. O of 1 means no deformation. It's typically something you can see on MRI, where there's a bony edema. O of 2 means a deformation of one end plate, and you can see that we do not talk about fractures, but we talk more about deformations, because it looks like that more. OF3 is a deformation of one end plate with a distinct posterior wall involvement. That would be something like an incomplete burst types, like A3. OF4 are deformation with, where both end plates are involved with or without posterior wall involvement. And finally, the OF5 are injuries with either anterior but mostly posterior tension band failure. And this is how it looks like. On the upper left side, you see the OF1. OF1 is the bony edema you typically only see on MRI. So it's sometimes a kind of surprise when you classify or when you make an MRI for a fracture and you see that there's another fracture maybe adjacent. OF2 is the deformation of one end plate. That could be a minor posterior wall involvement, but no gross one. OF3 is where you have one end plate affected by the clear posterior wall involvement. The OF4 can look differently, but all of them have both end plates involved, with or without posterior wall involvement, but always both end plates. And the OF5 are the ones who can mostly develop over time when there's an ongoing insufficiency, instability, which may lead to a posterior or PLC insufficiency or even rupture. The classification algorithm is relatively easy because you start looking whether they have a PLC or ALL injury. If not, then you would look whether they have both end plates are involved. If not, whether there's one end plate involved. And if there's one end plate only involved, you check whether there's a distinct posterior wall involvement, yes or no. And therefore, you can judge or can classify them to OF5, 4, 3, 2, or even to OF1 if there's just a vertebral body edema. The distribution is typically that OF1 and OF5 are rather rare, and the vast majority of fractures account for OF2, 3, and 4. The treatment of these fractures can be conservative, but in many cases, I will show you, maybe surgery might be helpful. If you consider surgery, you can choose between augmentation, posterior percutaneous stabilization, or rather rare, open posterior, even sometimes combined stabilization techniques. The kyphoplasty and vertebroplasty are typically the most known ways of augmentation. Typically can be performed in OF1, 2, 3, and sometimes even in OF4. The short percutaneous hybrid constructs, which are see on the lower left side, are mostly done for OF3 or OF4. So that means you have a percutaneous fixator, bisegmental, plus any kind of anterior support in terms of vertebroplasty or kyphoplasty. In some cases, however, you need longer constructs, either open or mostly percutaneous, where you may cement the screws. We at least advise to cement the uppermost and the lowermost pair of screws, not necessarily the ones in the middle, but some bone cement here for better screw anchorage is definitely advisable. And in very few cases, you need very long constructs or even osteotomies or even a VCR to obtain good results. The question is now when to operate and when not. So we developed a score which will help you in your daily life to make a decision. The score has the parameters, the morphology, severity of osteoporosis, whether there's a deformity progression, especially if you have X-rays on different time points, to look at the pain of the patients, whether they have neurological symptoms, whether they can be mobilized or not, and finally, what about their overall health status. And then you can apply points. The morphology gets double, so an OF2 gets 4 points, etc., but the others can be given points if they are available. So if you don't have any issues, if you don't have any X-rays on different time points, then you cannot give, for instance, a point for deformity progression, but you can always give points for pain, neurological symptoms, mobilization, and the health status. So how does it look like? Here's a case example. That's a 70-year-old lady with an osteoporosis with a T-score of -2.6. A fracture of 1, just one end plate is affected, so it's an OF2, and she was complaining of VAS 6. So if you apply the score, you will get 4 points for the morphology, another point for the pain. However, since she was mobile, you can take off 1 point and she was rather sick, so you can take off another point. So finally you end up with a result of 3 points, and therefore that would mean conservative treatment, but which definitely fit in this case. Another case, 74-year-old, severe osteoporosis, minus 2.3 the score, L2 fracture with a distinct posterior wall involvement, so it's an OF3. Patient was mobile and was rather in low pain, just VAS 4. Again, if you apply the score, we see that the patient gets 6 points for the morphology, 1 point because the T-score is so low. However, we take off a point because patient wasn't in that much pain, he was mobile, and so overall we ended up with 5 points and started with conservative treatment. But I told you before that the risk factor for failure of conservative treatment is a low T-score. And that means 3 weeks later, patient came back with having this situation where the fracture morphology changed from OF3 to OF4, because now the fracture kyphosed more, the lower end plate got involved, and now the patient was in more pain, had complained about VAS 7. So again, if we now apply the score, we will end up with 10 points, which would mean surgical treatment. And in that case, since the fracture was relatively fresh, we could perform kyphoplasty here, which showed a good long-lasting result. Next example is a patient, 60-year-old, again, severe osteoporosis, VAS 7. One end plate was affected, the lower end plate was not affected, although it looks like a little bit. As an OF3, bedridden patient with severe pain. When we apply the score again, we will get 6 points for the morphology, another point for the bone, for the T-score, low T-score, and another point because patient was not mobile. Finally, 8 points surgical therapy. And in that case, we typically perform percutaneous bisegmental fixation and plus kyphoplasty of the index vertebral body. This is called short segment hybrid. Stabilization is the kind of workhorse we use. These hybrid constructs have shown or have proven to be relatively effective. Several studies could show that even over a long time, even up to 4 years, these constructs are viable. They show no loosening typically, and the number of adjacent vertebral body fractures is relatively low. So hybrid constructs are, as we can say today, effective. Next example is a 70-year-old male with sudden low back pain 5 weeks ago, and now he was complaining about a kind of claudication, neurogenic claudication. He showed fractures at L3 and L4, while the L4 fracture was an OF4, the L3 fracture was just a minor end plate deformation, so an OF2. So that's his CT scan, which nicely shows the stenosis. And here in that case, again, we applied the score. Again, we came up with a result of 7 points due to the pain as well as to the fracture morphology. And we fixed this patient percutaneously plus the minimal invasive decompression at the level where the spinal stenosis was. A last example, a severe one, 81-year-old female, severe osteoporosis, had a fall 3 months ago, complained about VAS, heavy VAS, and you can see on the right image how kyphotic the situation is. And if I show you now the CT scan, you see how unstable it is because in the supine position it opens up. So here it's very difficult to find a good decision. It's clear that this patient has 12 points, so that would need surgery, but what to do? And here I think the minimal invasive techniques or technology we have is really helpful. Patients got a long posterior percutaneous stabilization and a minimal invasive corpectomy plus anterior stabilization with an expandable cage. So this is something we can even do in an 80-year-old patient. This patient I followed up for 1.5 years before she died due to other reasons. The application of the score has been proven to work, at least in our environment. We've performed a multi-center study in Germany, roughly 500 patients. In my department, we included 60 patients. The majority of them got kyphoplasty, some posterior stabilization, and some kyphoplasty plus posterior stabilization.
Dr. Klaus, please be fast.
Interestingly, the ODI and VAS regained or developed quite nicely, so we saw significant reduction relatively shortly. And finally, what's most important, people gained their mobilization, the same mobility like they had pre-injury before. So in conclusion, the OF classification, the score, and the treatment recommendation are currently expert-based, but they reflect actual treatment status of knowledge. Conservative therapy may be the choice if the patient is mobile and the pain is low. Kyphoplasty and hybrid stabilizations are the surgical workhorses. However, comorbidities, adjacent fractures, implant failures are still challenging, and don't forget to give adequate medication for the osteoporosis, otherwise the patient will come back with new fractures. Thank you very much, and here are the take-home literature if you're interested in it. Thank you.
Thank you, Dr. Kleis, for his nice presentation. We'll allow questions after this session. So the next lecture will be...
The next speaker is Professor Dr. Shahidul Islam. His topic is surgery for OVCF, when hot and when not. Professor Dr. Shahidul Islam, please come to the dais.
Yes, sir. Thank you very much. My previous speaker very nicely and elaborately has given the classification as well as treatment modalities for the treatment of osteoporotic vertebral compression fractures. So this is easy for me, and I think if you hear his lecture attentively, I need not to give any lecture more. So it is, dear audience, this is the session. You should take your lunch as you will take the lecture. Try to listen. Okay, my topic is surgery for osteoporotic compression fracture, when, what, and when not. Already my previous speaker explained why we have to classify this for the treatment, for decision making of the treatment. And there is the classifications, he said several classifications, and finally he has given this classification. He is one of the writer of these publications published in 2018, classification of osteoporotic and thoracolumbar spine fracture, recommendation of the spine sections of the German Society for Orthopedics and Trauma. He is the writer of this publication, and he has given this classification system and when to operate and when not go for conservative management. I am not going to details, and he has also given this classification based scoring system for the treatment protocol. So, natural course of this osteoporotic vertebral compression fracture, 70% of this osteoporotic vertebral compression fracture can be treated conservatively, and they eventually, there is a pain relief, mobilization, and return to previous status. Only 30% undergo extensive collapse with resultant instability, cleft formation, pain, deformity, as well as neurological deficit. And this portion may need surgical intervention. So management conservative, 70-90% can create conservatively, and surgical 10 to 30%. And don't forget the medical management of osteoporotic vertebral compression fracture, because it is the integral part of the treatment. Try to do pharmacotherapy before. When you need conservative treatment, give pharmacotherapy for at least 6 months, then you go for operative treatment. That will give better result. So indication for surgery, already I have described. There is no improvement despite adequate conservative management, neurological deficit, radiological evidence of instability, as well as spinal deformity. So what are the surgical options? Already my previous speaker said minimal invasive is the main option. Among the minimal invasive procedure, vertebroplasty, kyphoplasty and similar procedure, percutaneous pedicle screw fixation, and also open procedure like open pedicle screw fixation, and you must keep ready for hooks and cables, and you may need osteotomies also. Regarding vertebroplasty, there are some indications of vertebroplasty, mainly for pain relief in case of when there is a pain, instability affecting activity of daily living, in normal neurology patient, when there is a clear cleft seen and there is no infection, no coagulopathy, and usually no middle column compromise, you can go for vertebroplasty. And I am not going to in details of the vertebroplasty, but be aware of this self-deposit of your dye, because if you fail to go self-deposit, so their dye may enter into the canal and also into the anterior aspect of the vertebral body, or may go into the vessel leading to immobilization and pulmonary embolism. Be careful about vertebroplasty. Don't give more pressure, use low viscosity cement, and send a specimen for biopsy always. Kyphoplasty is relatively safe than vertebroplasty, and this is also inflation of balloon to restore the bone height, then injecting the bone cement. Here we use the into the body, and remember, don't give more cement, only give that amount of cement need to fill the cleft. Don't try to overzealous correction, it may fail. There are another procedure like stentoplasty. These are not available in our countries. The following procedure: you introduce the stent and give cement, and there is technology. Introduce the PEEK material within the vertebral body and give cement into them, like a cart jack, a spine jack. Introduce the jack and give cement on this, and there is also osteoflex and other many procedures of this type of minimal invasive procedure. But there is many study. This is the study of vertebroplasty versus sham procedure for painful acute osteoporotic vertebral compression fracture. This is a randomized sham control trial of 180 patients. Mean age was 76, and 76% was female. And vertebroplasty done in 91 patients, and all the procedure like vertebroplasty done, like sham procedure in 89 patients. And you see here, after 1 month, after 2 months, no important difference between the two groups. And finally, vertebroplasty did not result in statistically significant greater pain relief than the sham procedure. This is the task force report formed by the Association of American Society for Bone Mineral Research, and they published in their articles in Journal of Bone Mineral Research in 2009. And this task force said, they concluded like that: for patient with acute painful vertebroplasty, percutaneous vertebroplasty, acute painful vertebral fracture, percutaneous vertebroplasty proved no demonstrable clinical significant benefit over placebo. Result did not differ according to duration of pain. There is also insufficient evidence to support kyphoplasty over non-surgical management and percutaneous vertebroplasty and vertebral body stenting or KEVA procedure. So, what are the strategy for fixations if you go for fixation of the vertebra? Always consider the fragility of bone, stability of the spine, likely failure mechanism of the applied spine. We also consider the high incidence of comorbidity of these patients, likely failure of the instruments, and degeneration or fracture of the adjacent vertebra and increased deformity after fixation. So you have to improve your fixation by and increase the pull-out strength by screw design and augmentation of the screws and screw material like this. And this is the surgical procedure, you must follow that, try to follow this, increase the diameter screw. But remember that diameter screw should not consist of more than 70% of the pedicle diameter, because osteoporotic vertebra has a tendency to fracture if you cross more than 70% of the pedicle. So increase the length of the screw. If you go 80%, there will be a strength of more than 30%, and if you go to the anterior corset, you will add more 16% of the strength. And you go for a small pilot hole and under tapping of the screw track. You use long construct if necessary, already my previous speaker said, and supplement the anterior fixation if necessary. And use of laminar hook or wires, because sometimes screw may not be used. Use of transverse connection gives 40% torsional strength in these cases. So there is now novel surgical techniques like screw trajectory. You see white dotted line shows the conventional screw trajectories, but blue shows the cortical trajectories, and if you use the cortical trajectories, it will give more strength. And if you medialize the screw, about 30-degree medialization of the screw will give you the extra strength of 28.6%. And you can use this technique, though very difficult, like double cortical screw, cross screw, and use the bicortical screw. Already I said you added another 16% strength to your construct. So pedicle screw fixation tips. Novel screw design. Already my previous discussion shows that there is a fenestrated screw and there is a double threaded screw. You see cortical thread and cancellous thread, and there is some screws, hydroxyapatite coated screws, and also this is the latest development of expandable screw. You can also use these type of screws. Conventional cement augmentations, it is practiced in our subcontinent, especially in India, that they put the cement, then they put the screw through this, and they found in a public journal that they say thoracic, pull out its strength is 70%, in case of lumbar is about 120%, and you can probably do the vertebroplasty, then pedicle screw formations. These are the some procedure of vertebroplasty with long construct and fenestrated screw fixation. And this is when a patient has neurological deficit with cleft formation or instability. Remember that neurological deficit is not always due to neural compression. It may be due to instability of the vertebral column. So you posterior decompression and stabilization plus vertebroplasty and hybrid good compression and screw in the fracture vertebra. You can use screw in the fracture vertebra, and long construct is desirable here. And screw augmentation already said by screw augmentation and design I said previously. This is courtesy by Raj Tv. He published this paper, and you can use short segment fixation in case of lumbar spine, and you can go for vertebroplasty, and you can screw fix with an screw at the index vertebra. So neurodeficit without obvious cleft formation and significant neural compression, you must decompress it and give long segment fixations, and you may need to with DBO and PSO. There is osteotomy here like that, and in case of multiple fracture, technique of adult deformity correction, you must follow that, but there is a high risk of complications and implant failure. So perioperative pharmacotherapy is very much important. I said previously that you must give pharmacotherapy to these patients. These are the, you see, after giving romosozumab, abaloparatide, teriparatide, denosumab, zoledronic acid and other oral bisphosphonate, these are the, after 1 year there is BMD increase about, you see in the middle column, there is an increase of BMD increase in 1 year. So you give this fixation, and bisphosphonate reduce the spine fracture. You see about 67% spine fracture reduction by giving zoledronic acid, and already I said denosumab, you also it reduced the spine fracture 68% new vertebral fractures, but in case of fracture 6% increase in bone density in the spine after 1 year. This is another teriparatide, 20 micrograms subcutaneous injection per day in 18-month study, 65% spine fracture reduction is possible. But this study published in 2022, there is a comparative study, effect of teriparatide versus percutaneous vertebroplasty on pain relief, quality of life and cost effectiveness in postmenopausal female with acute osteoporotic vertebral compression fracture, a prospective cohort study. They said that teriparatide and percutaneous vertebroplasty similarly improved the patient health condition. Greater pain reduction was observed with vertebroplasty after 1 week, greater pain reduction after 1 week. But in long term, non-surgical treatment with teriparatide provide a more economic therapy than vertebroplasty in terms of treating acute osteoporotic vertebral compression fracture. So abaloparatide is a drug you can use. This is the romosozumab of the latest drug, both anabolic and anti-osteoporotic, anti-resorptive effect. So these are some examples. I treated 32 patients conservatively without operative procedure, and they found that after 1 year of treatment, you see in the middle one there is a cleft formation, but after 1 year of zoledronic acid only and mobilization of the patient as early as possible, there is a reasonable healing of the fracture. This is another case. There is a fracture of the D12 and L1. D12 is old fracture, L1 is new fracture. Only zoledronic acid after 1 year. This nice healing, patient had no pain and patient can do his normal activities without any difficulties. This is another patient came to me with this old fracture D2, D8 but new fracture in the D11, and I advised him teriparatide, but he failed to get it within 1 month. But after 1 month he came to me with this fracture. Then I did operation for this femur and given his teriparatide 1 day post-operatively, and patient has healing after 1 year. So surgical intervention and absolute last resort because of advanced patient age, presence of comorbid disease like diabetes and other disease, there is a movement disorder of this patient and cognitive decline of this patient and difficult to secure fixation to weakened osteoporotic bone, you must consider before fixation of this type bone. So take a message, decide meticulously whether to operate or give conservative treatment, improve your fixation with various strategies already described. Surgical management shows a silence due to potential complication, and medical management is an integral part of the treatment of osteoporotic vertebral compression fracture. So thank you very much for patient hearing. Love your bone, protect your future, and this is the last 2023 World Osteoporosis Day slogan, set up bone health, build better bone. Thank you very much for your patient hearing.
Thank you, Professor Shahidul Islam, for your nice presentation. So the session is open for discussion. If anyone has any question, you can ask it. Dr. Ahmed? Yeah, give microphone to Dr. Ahmed.
I have a question to Dr. Matt Klaus. Are you advocate to treat the fracture vertebra with osteoporosis along with medication? Which medication you preferred? Either teriparatide or denosumab or any other things? And how much long we can treat medication after the surgery? Thank you very much.
So all of our patients are going to be asked whether they have osteoporotic treatment before the fracture or not. If not, we start with the treatment right away. I don't understand the question. Yes.
So what was the question? Suppose there is a vertebral fracture with osteoporosis. Are you treat the patient with operative treatment? Along with operative treatment, are you advocate to treat osteoporosis simultaneously? And how much day or months will continue the osteoporotic therapy?
How long you continue the anti-osteoporotic treatment along with the surgery? That is the question.
No, his question is, should you start the osteoporotic treatment before treating the osteoporotic fracture, or the patient is coming to you in the emergency? Will you wait for the osteoporotic treatment to act, or you
okay, sorry.
directly? That is
No,
the question.
we don't wait. The anti-osteoporotic, the medical treatment takes months. Even if you use teriparatide, then it takes months before it works. So if you just start with bisphosphonates, and bisphosphonates do not do anything with the bone. I mean, they just help that not more bone is going to be reabsorbed. So we treat them with, if they need surgical treatment, they get surgical treatment. But we start the same day with the anti-prosthetic treatment, and we keep this for at least 2 years.
Okay, I can supplement that. What you said, already I said, if operation is necessary, go for operation. Don't wait for giving treatment into osteoporotic drug and wait some days. Then
no, what is the criteria?
No, like
what
that.
is the criteria?
Go operative management as well as start anti-osteoporotic drug. If you go teriparatide, not more than 2 years. If you go bisphosphonate, parental bisphosphonate, at least 3 years. Is it? According to dose schedule, you must give anti-osteoporotic drug. Whether anabolic, you prefer anabolic? Yes. Teriparatide, arabaloparatide, or the romosozumab, both anabolic and anti-osteoporotic drugs. You prefer these 3 drugs, but you can give any more drugs available in your country.
Dr. Klaus, you have got an excellent classification. My only concern is that your classification is based on the T-score. Now the problem with the T-score is that in elderly patient, many times there are a lot of osteophytes. It is not a true T-score, or sometimes the patient has already undergone surgery, L2, L3 fixation has been done. You cannot take the T-score from the spine. Then you take the T-score from the hip or the T-score from the forearm. And many times what we have seen in the T-score from the spine is normal. The T-score from the forearm is minus 4.5 or minus 3 point. So what are your criteria for taking this T-score? But T-score may be very dubious thing for the classification.
Yeah, you have 2 options. You can either use a quantitative CT scan.
Many times it's not available in in the many centers, quantitative CT.
Well, but this, you can either make a DEXA scan, or you can make a quantitative CT scan. So if you don't have anything available, or if you doubt the DEXA value, because they have all these osteophytes and everything, if you doubt, then you have to doubt it. But we have not evaluated the T-score from the hip. So I cannot tell you whether the low T-score in the hip would have the same impact like the low T-score from the spine. So if there's no reliable T-score available, and you can still use the score, but you don't give any further points. It's only if you have a reliable T-score made by DEXA or quantitative CT scan, and it shows that the T-score is below, so either Hounsfield units below 100, or you have the T-score below -3, then it's a clear risk factor for ongoing kyphosing or failure of conservative therapy. But if you don't have it, you can't use it. So I would not recommend to use necessarily the hip, at least not for the score.
Okay. My question to Dr. Klaus, in your classification system, OF 1, 2, 3, 4 are pure osteoporotic. But in 5, OF 5, you have said that there is, in some cases, there is posterior element fracture or posterior element failure. So posterior element is rather less osteoporotic. Osteoporotic less affects the posterior element. So does it mean that it's a pure osteoporotic fracture or an osteoporotic fracture along with some traumatic element? In case of OF5.
Yes, so the O5s always, what's per definition, they have either PLC injury, mostly this is an insufficiency over time. We see it in the pelvis, for instance, is the same. They'll have a pelvic fracture in the elderlies and they start to dislocate over time. So the same with the O5. It's an insufficiency over time. It's very rare that they have it right away from the first moment on after an injury. That's rare. But mostly it develops over time. So sometimes we see fractures coming in as an OF3, then maybe 4 weeks later became an OF4, and like the old lady I showed, the 81-year-old,
like 3 months later, she developed an OR5. So it's an ongoing insufficiency leading to a highly unstable situation. It's rare that it's just happened right away after a trauma. You know, if it's hyperextension, sometimes you see an open up in the anterior part, so a fracture of either of the anterior cortex, or relatively rare of the anterior ligament, where this, but this is mostly due to rheumatic.
Yeah, it's very rare. Rarely it happens that anterior ligament failure along with the posterior ligamentous complex failure. So sometimes there is anterior element failure, very rarely anterior column failure along with posterior ligamentous complex failure. These are the rare entity. I think this should be a separate entity, which is very rare occasion it happens, but it happens.
Well, at least I think they all are highly unstable, you know, so
very unstable.
we typically need, I think they all need surgery.
Yeah,
according to his classification, he classified type 5, there is a posterior column disruption.
Yeah.
Especially including destruction or posterior column disruptions.
Or elongation, destruction or elongation, but you're seeing an insufficiency.
So this is instability, you have to fix it.
Fix it, yeah. If there is instability in posterior ligament, then you have to fix it.
So I have a question to you. Can you hear me? There is a problem about mic. So if you need for stabilization of the single vertebra before your fixation by cement augmentation, there are several procedures like vertebroplasty, kyphoplasty. Which one you prefer? Vertebroplasty or kyphoplasty?
Well, I prefer the one with the least complication rate, and this is kyphoplasty.
Kyphoplasty, right.
Because the cement leakage is the lowest, you know, so you can really perform, and you can put the cement where you want it to have it, so you can place a balloon at exactly at the point where you need the cavity and where you need to reconstruct the vertebral height.
Yes.
And then you have the option to fill in the cement in this nice and safe way. Other than with vertebroplasty, where the cement leakage is significantly increased. No.
So now, Professor Shahalam, do you want to ask some question? Yeah.
Just a quick one. If you decide for the conservative management, what is your follow-up protocol? And when you decide now is the right time to have the surgery, for how long you observe the patients?
When we perform surgery or
No, I mean when you decide for the conservative management.
Yeah, okay.
And you follow the patient up.
Yeah.
What's your protocol? How often do you see the patient?
So your protocol for conservative management. Protocol for conservative management.
For conservative management.
How you manage conservative?
Yeah. So the protocol is typically when patients come in and have severe pain, we always treat them conservatively first. Then after mobilization, they get a standing X-ray. If we see that the standing X-ray looks more or less like maybe 3, 4, 5 degrees more of kyphosis, but looks fine and they're doing well, they get discharged, and we have 2 weeks later, we perform the next standing X-ray. And then after 6 weeks. So we have 2 weeks, 6 weeks, and if they are pain-free already, then we do not necessarily look after 3 months. If they're still in pain, we get them back after 3 months, you know. And the lower the T-score, the more often we would probably make a control. But typically it's 2 weeks, 6 weeks, 3 months.
One of my cases is severe osteoporotic collapse of the D12. But at the same time, D11, 10, and the D9 is the partially collapsed. And the lower vertebra, the L1, L2 is also involved. So in this particular situation, and the patient developed neurological deficit also, what is your plan of treatment?
And the T12 is heavily destroyed, so it's severe kyphosis, or?
D12 is more or less 20 to 25% is.
Okay. Okay, so if the kyphotic situation is not too bad, so if you have like 15 to 20 degree kyphosis, you can still fix it from the back. And what I would do is would be a full standing X-ray, full spine standing X-ray. If the patient is sagitally disbalanced, you may need to correct the patient. Then you need a relatively strong and long construct. If it's just about the local instability, then maybe a shorter posterior construct is enough. But I typically you need at least 2 above, 2 below, sometimes even 3 above, 3 below, in order to fix such a situation.
My concern is the vertebra above and below is also partially collapsed. So the cement integrated screw I have to give. But even though I'm worried whether that fixation will be failed.
Yes, there's a 20% risk that you will have adjacent fractures. That's true. But if you leave the patient like it is, it's no solution on the other side. So, but the more surgery you perform, the longer you perform the stabilizations, the higher the chance that you will have adjacent fractures. So, and here it goes to the more type of deformity surgery concept. So don't stop in the apex of the kyphosis. Don't stop close to a very mobile segment. If the lower lumbar spine you have a degen spondylolisthesis or something like this, you should not stop there, etc., etc. So it gets complicated. The best thing is if you keep it as short as possible. And if it's just a local instability, you may even consider to have just a bisegmental stabilization and put some cement or index screws in this vertebral body. So keep it short, but in the moment you correct the patients, you need a very strong construct. And then you may pay the bill afterwards by having adjacent fractures where you have to extend the stabilization or have to make a kyphoplasty, vertebroplasty at the adjacent level. So the more surgery, the more complications.
So with this, we have to continue.
Thank you very much, both the speakers, very nicely presented and a lot of experience. I have one question to Professor Shahidul Islam. Since you are very experienced spine surgeon here and working in this field long time, especially dealing with osteoporosis, what is your own experience regarding use of expandable screws and also tips and tricks to use the bone cement in expandable screws?
Thank you very much. I have no experience of using expandable screws. In my lecture I said this is a new device coming in not always available in our country. I have no experience about expandable screws.
I do have, but there's no advantage. There's simply no advantage in expandable screws. They cost a fortune, and you can use fenestrated screws and put in cement. So I think that's much more reliable. We did it. They came up like 10 years ago. They were the first companies selling them, but I didn't find any really advantage.
Yeah, almost the same facilities of fenestrated screws.
Yeah.
No extra advantage, rather it is very costly.
No, it is very expensive.
So can
it's
I
more
ask?
expensive than fenestrated screw.
Sorry?
It is more expensive than the fenestrated screw.
Yeah, very expensive. And technologically also it's different.
It's not better
so
than
the extra instrumental supports it requires, but ultimately the fenestrated screws can provide the same, the advantages.
So, Professor Shalom, I have a question to him. As the expandable screw is very costly in our country, but there are other procedures like we put some amount of cement within the vertebral body, like 5 cc or about 1 cc, then we put our conventional screw. Do you support it?
Well, that was the technique we used for years. I mean, because the fenestrated screws came up to the market. Nowadays, in our country, the fenestrated screws have the same price like the solid screws, so it doesn't make any difference and it's much easier. But you can still do this. So, why not making a hole and then putting in some cement and then putting in the screw? That's fine. It works. From a biomechanical point of view, it works the same. I would suggest not to apply more than 1.5 cc cement per screw in order to avoid leakage of the cement. Yes. But the technique is fine. It's a viable technique. Yeah.
No, but
we are running short of time.
The problem is that the chance of leakage of the cement is more, because when you are giving the cement, then you are coming back and again you are pushing the screws, then every chance to leakage, because you don't know how much the pressure or space is there. Yeah. So every chance to leakage of the space.
Yes, you can use less amount of cement.
Yeah, thank you.
So let us conclude the session with this, and I invite Professor Dr. Saidul Islam to receive his memento, and Dr. Klaus also.
Thank you.
Distinguished delegates, welcoming you to the fifth session of Bangladesh Spine Society Conference. Here, this is for cervical trauma session, and I am Dr. Ashraful Motin Sagar. I am Assistant Professor, Spine Surgery, welcoming you to the session. Here, the session will be chaired by our renowned spine surgeon, Professor Dr. Kamran Farooq from India, and our renowned professor and beloved personality, Professor Dr. Wahidur Rahman sir. They will both chair the session. I hope in the middle of the postprandial dizziness, you will enjoy the session. Please, sir.
So we're going to have a session on the cervical trauma, and we have got a very dear Dr. Ranjit Unnikrishnan from India, and Ranjit will be talking to us about timing of cervical decompression, again a very controversial topic, gold standard versus delayed surgery.
Good afternoon. Good afternoon. I hope after Sumter's lunch we'll have some time to discuss about cervical trauma. Thank you, Bangladesh Spine Society, Professor Shah Alam sir, Dr. Janayat, Professor Anwar. I always enjoy coming back to Bangladesh. So, when you come to this kind of picture, I'm sure all of us who treat spine injuries, this is not uncommon. The question which we have is that, does all the three have the same timing of treatment? Not kind of treatment, timing of treatment. Because these are the thoughts which go in our mind. If we operate early, are we operating on patients in spinal shock? Are we allowing the cord to recover prior to the second hit of surgery? And next, are we advising surgery in unstable spines of unstable patients? These are questions which we have in mind when we see these injuries. With this, let us discuss timing of surgery in cervical spine with the light of current evidence. So this debate has been there since decades. It will go for years probably. We know this, whatever done has happened at the site of injury. What we try and do is prevent the secondary injury. And we know that this is a cascade which you're trying to avoid or minimize. Now, what are the goals of any intervention when we do in cervical spine trauma? Number one, to prevent the secondary cascade. Number two, prevent irreversible spinal injury, which can happen because of the secondary cascade. Now, the point of contention is timing. It's timing. Does timing affect the recovery? Does timing affect the hospital stay? Does timing have got financial implications? Does timing affect complications? Now, is early surgery better or more advisable in decreasing these complications? So this was the landmark trial 2012, where if you see the common name Michael Fellings and group, they came up with this randomized multi-centered prospective trial which came out with starking evidence which said that people or patients who had early surgery had at least 2-grade improvement in Asia score as compared to the one who had late surgery. So 2-grade sounds nothing, but imagine somebody with a C7 T8 or C6 7 having a 7 recover. He recovers his hand function. So 2-grade is significant at that level of cord injury, even though it sounds nothing. This trial has been quoted, unquoted, debated years together, but this evidence said that patients who had surgery prior to 24 hours had better outcomes with increased safety. Now, people who think otherwise said that incomplete cord injuries make significant recovery irrespective of canal compromise. If you look at this paper from Stokes Hospital, which said that there is no correlation between recumbency or handling whatever, and if you handle safely, the outcome is better. Now there is this paper also quoted that there is no evidence that surgery enhances recovery. Now these are two big groups. Now this is the underlining. Timing in this polytrauma is always controversial. We know that we have to operate on the unstable spine of a stable patient, not a patient in polytrauma. So that has been again and again emphasized. Ample amount of literature for and against early intervention of in spine trauma. Now, if you look at the Japanese papers, look at this Japanese paper published in 2019. The stasis study came in 2012. In 19, they said that there was no advantage of early surgery. Neither in ICU stay, neither in motor recovery, neither in complication rate. So why advise early surgery? Now, are we comparing the same fruits or are we comparing something else? So if you go into the more granular data, this paper published in 2021, this was the last article which I could find which did this, again from Michael Fellings and company, which said that time is spine. I repeat, time is spine. What was that thing they found out? That like the 2012 article, surgery prior to 24 hours had enhanced recovery. Most important, there is a continuous decrease after first 24 to 30 hours. So after, if you don't operate in first 3 days, it makes no difference. You operate 7th day, 21st day, this makes no difference. Again, they analyze a subgroup within 6 hours, 12 hours, 24 hours. The subgroup said that patients operated in 6 hours had still better recovery. So, what was the idea? That if you can operate within first 24 hours. But this article also had a subnote that what is most important is preventing ischemia or progressive ischemia by maintaining ABC, that is airway, breathing, circulation. So spinal cord hypotension was the underlying factor which was always treated. Now, again, debate over debate, multiple centers, multiple meta-analysis, which all came to the conclusion that if you can operate early, it is best. Not better, it is best. N number of evidences saying that, well, you operate early, you get better. Now, if you look at it, look at this again, meta-analysis from 2019, which said that again, early surgery better. Then came this study from our AO spine in 2017, which again came out with the same outcome that existing evidence support improved recovery among cervical spinal cord injury patients undergoing early surgery. Regarding financial implications, yes, definitely early surgery, less cost, and there's definitely a minor gain in quality of life years. Now, this came out with this conclusion that whenever possible, surgery, if an option, should be offered at the earliest to these patients. The want of time, so I'll go to the take home. So whenever feasible, early surgery within 24 hours. So whenever feasible is most important, you in your setup, your background, if can operate within 24 hours, operate. I do it in first 24 hours because my setup is geared up for that, because we know that there's better chance of recovery. But remember, we operate on the unstable spines of a stable patients. We got lesser complications, less hospital stay, early rehab, less financial burden. Remember this, most important, know thyself and thy resources. In your setup, your resources, your country, what you can do there, if possible, operate well. So for me, all these patients, I'm a posterior guy for acute trauma because I feel I can operate all the 3 columns. I can do a tracheostomy if required. With this, I would like to invite you all for this classic meeting planned next month in Dhaka with Professor Shah Alam and Professor Shahidul Akon, all the faculties from here. We have a degenerative lumbar and cervical seminar in which you will see the kind of questions which you ask in your daily life. Multiple level disc, which level do I operate? Cervical and lumbar, what do I operate? In cervical spine, how do you know what is the pain generator? We are going to go thread by ear. Welcome you all, and I invite you all to please register for this. Thank you very much. Any questions?
Thank you very much, Dr. Rajiv Kishan.
Please come up for your from our chairperson, please.
So, thank you all. Good afternoon. It's a great honor and privilege for me to talk here. First of all, I would like to thank
Before starting, Dr. Junaid, I have to declare your name, please. I will invite Dr. Sharif Ahmed Junaid to talk on central cord syndrome, how it is different. Please.
So, thank you, Mr. Chairperson. So, good afternoon. So, my previous speaker has already described the spinal cord injury, role of decompression, early versus late. So, I would like to talk just with a case scenario. So, let's go back 140 years back in a hospital called Royal Infirmary, Manchester Hospital. The William Thorburn was the surgical registrar. He observed a peculiar case with a patient of 44 years who has presented with quadriparesis following fall from height. So, after subsequent injuries, he noticed that the patient regained neurological function of lower limb first, followed by upper limb, and then he was able to walk after 6 weeks, and subsequently after 5 months, he was able to return to his normal activities. At that time, the syndrome was supposed not to address by the William Thorburn, as it was not described. So, after 70 years later, the Snyder from University of Michigan described this syndrome, pointed out as a Snyder syndrome or acute central spinal cord injury. What it is? It is actually nothing but the injury to the cervical spinal cord, which is presented with the patient with more motor impairment in the upper limb than the lower limb, with a urinary dysfunction, particularly retention type. So, this is the graphical representation you can show here. The upper limb is mostly involved and lower limb is less involved. So, according to Snyder, he thought that it is contraindicated to operate this patient. Why? Because there may be chances of spontaneous improvement as well as the complete recovery. Even the surgery has actually been known to harm this patient rather than improve them. So, dear audience, this is my talk, central cord syndrome, and how is it different from other syndrome. As I have already mentioned, it is the most common type of the incomplete cervical spine injury, and typically it can be resulted from either hyperextension or by flexion. The hyperextension is usually the classical feature of the aged patient, in whose compression from the both anterior as well as the posterior. Compression from the posterior causes the buckling, and from the anterior side disc and osteophyte causes the compression. That causes the syndrome of central cord syndrome. But even in case of fracture dislocation or acute disc herniation like flexion injury or like that, in a young patient may cause this type of injury. So, this is the pathophysiology, as I have already mentioned. So, either compression from anterior side to the anterior spinal artery, from posterior to posterior spinal artery, causes the compression and causes the, the intensity of signal change, maybe due to the cord hematoma or hematomylia or like that. Subsequently, patient has developed with neurological deficit. So, if we see this graphical presentation, so there is a compression from anterior as well as the from posterior. So, this compression ultimately causes the central portion become compressed, and it can migrate it either proximally or distally. So, whenever this type of injuries occurs, of course, you have to judge the, you need to diagnose very carefully. You have to see the clinical scenario, as well as you have to look for some investigation as well as like CT scan, MRI, etc. If the patient is stable, suppose there is, in that case, ATLS is not appropriate. But if the patient presented with the scenario like the acute emergency type or like that, you have to go through the ATLS protocol. And next is very important, that is the prevent secondary injury and neuroprotection. How it is? Your aim is to maintain the mean pressure should be maintained at least 85 to 90 within the 5 to 7 days after post-injury. That is the most important things. Now the next question is, how should we treat this patient? Should we operate this patient, or we should treat this patient conservatively? Let's see the evidence. In the earlier time, suppose in 1954 to 2003, most of the literature, as we search, it was advocated that most of these cases can be managed conservatively unless there is a specific indication. But later on, recently, now the scenario has been changed from conservative to the operative modalities of treatment now has gained almost the maximum cases they gain the popularity. So this is the landmark paper by AO Spine Group. They have clearly shown that if we decompress early and stabilize the patient, that they have any instability or have a significant neurological loss, and we need to address the underlying pathology at the same time. That will ensure a good outcome, shorten the hospital stay, shorten the rehabilitation period. Ultimately, patient can return to the work early. So now the next question is time of decompression. As my previous speaker has already mentioned, there is again controversy, early versus late. Still debate is going on. So most of the literature still suggested that decompression, if is done earlier, has a good outcome. So the evidence is that if it is done from first hospital admission to within 2 weeks, it is come with a good outcome. So now the next thing is approach. So in case of the kyphotic deformity or neural spine column, you have to address this by anterior. If the patient has, the neutral or lordotic, in that case you need to address from posterior. And sometimes you may need to address from combined approach in case of pre-existing cervical spondylotic myelopathy, instability or like that. So if we see some cases, suppose this is a case, we did it from posterior side with a good outcome. So you can see here the patient can gain the neurology. This is another case, we have do this from, from dual approach. So the main thing is that how is it different? Number one is it has potential chances of spontaneous recovery, number one. Number is there is still lack of certainty regarding the instability, as well as we still don't know the exact mechanism of injury. So another thing is that in other spinal cord of the injuries, there may be the involvement of upper limb, lower limb, whatever may be, but in central cord syndrome, mainly it is the great weakness in the upper limb. And there is almost all the cases, sacral sparing is present and bladder dysfunction, mainly the urinary retention. So in conclusion, I would like to say, if the injury is stable and already symptom is resolving, you can treat it by conservative. But if the spine is not unstable and it seems that there is a persistent play to face, in that case, you have to address it surgically. So thank you all for patient hearing.
Thank you, Junaid, for a nice, informative and excellent presentation. Please take your mementos from our chairperson, please. And be seated in the dais. Dr. Ranjit, please come up and sit in the dais, please. And next presentation will be from Dr. Kiran Kumar Mukherjee from India. He will be talking on cervical facet dislocation and controversies of management. Dr. Kiran Kumar Mukherjee. Dr. Kuran Kumar Mukherjee.
So, respected chairpersons and respected audience, so I will talk on management controversies for cervical facet dislocation. We will talk on cervical spine, which have a typical features and can be classified together, though the injury pattern is complex. So we are talking on the Allen Ferguson flexion and destruction injuries, where the tensile failure and the lengthening of the posterior column with possible compression of the anterior column, which leads to anterior translation of superior vertebra, which eventually leads to the facet subluxation dislocation and may lead to spondyloptosis. And along with the associated kyphotic injury, there is disc disruption, 40% with unifascial and 80% with the bilateral facet dislocation. In plain X-ray, we assume that there is a listhesis less than 50%, then it's unifascial, and if more than 50%, then it's bilateral facet dislocation. MRI is a must. It's indicated even in neurologically intact patient because we have to know the status of the disc. And CT is also essential to know the status of the facet and the status of all the bony structure. Now the goals of the management are reduction, maintenance of the reduction along with correction of deformity and decompression. So first controversy with reduction, whether to reduce or not to reduce preoperatively. So if we can reduce, there will be advantage that we can do only anterior surgery. But there are case report which shows that there is catastrophic neurologic deterioration after reduction with disc herniation. So some advocate that the herniated disc should be removed before reduction. But in the majority, they say that the neurological deterioration during closed reduction is very rare, and it actually depends upon the large disc side, which is migrated caudally or cranially into the canal. And actually, the canal size increases after the reduction. Again, the reduction. So, what should we do? The gradual reduction or rapid reduction? Gradual reduction is the traditional one. It is done on a conscious patient with Carl tongues, and 5 to 10 pounds can be increased every 30 minutes. Neuroexamination can be done bedside, and an X-ray can be done bedside, and maximum weight we use up to 25 to 30 pounds. And the endpoint is until the reduction done, or we can wait up to maximum 72 hours. The advantage is the patient is awake, the neurology monitoring is easy. Disadvantage is it can take days and success rate is relatively low. And regarding rapid reduction, you need an ICU setup with CM and standby X-ray. Surgeon and should stay by the side of the patient. We can start with 10 pound and increase very rapidly. After 50 pounds, if there is no reduction, then the counter reduction can be done. And the endpoint is when the reduction is achieved, or if there is a neurodegeneration, or if there is a distraction for more than 1 centimeter, or if we feel that the reduction is unlikely. And the time allotted is maximum 3 hours, and usually 75% of the cases reduced with less than 50 pounds of weight. The advantage of rapid reduction is it's effective, 88% success rate, but disadvantage is risk of over distraction and neurodeficit. And due to heavy traction, there is a problem with pin site, and you always need a proper setup. The closed reduction is more difficult in unilateral locked facet as described in many of the literature, and some literature says that the bilateral facet, they could have achieved almost 100%. And few authors therefore suggest that the unilateral locked facet, you can go straight away for the open reduction because in unilateral facet dislocation is very difficult to get reduced. And now comes the manipulation under general anesthesia. The advantage is immediate reduction and surgical stabilization can be done on the same sitting. There is a high rate of success, 91% success rate. It's safe. But disadvantage is we should be very cautious and must be done by the most expert surgeon, because under the GA, the already unstable cervical spine, and with the muscle relaxed, there is more unstable. So thereby increasing the potential for undergo and neurodeficit. Next comes the approach. We have anterior approach, we have posterior approach, we have combined approach. Anterior approach is by standard anterior approach. The reduction can be done by Casper pin destruction method. In the posterior approach, the posterior reduction can be done by towel clip or by levering with a curved instrument or finally, if you can't achieve with that, you can remove the superior part of the caudal facet and it can be achieved easily. In anterior approach, we fixed with plate and spacer. This is to be a bone graft and fusion, better tolerated. This removal is complete and is effective. By posterior approach, we fixed with lateral mass. We can approach directly address the pathology. Is biomechanically sound. The reduction is direct. But if there is a associated disc disruption, the anterior approach is a must. Regarding the timing of surgery, my previous speaker told everything, and the latest is this TASIS study. They recommend that it should be done, if possible, within 24 hours to improve the neuro recovery. And now, one thing is common to us, but not common to Western country. That is the delayed presentation. It's not uncommon in our situation. It's associated with high morbidity. That is difficult in close reduction, and success rate is very low. Is 1/3 of fresh fractures. Most of the cases presented after 72 hours failed reduction with even 50 pounds of weight, thus necessitating posterior surgery along with anterior surgery when required. So this is an example. This is a 2 weeks old fracture with parts facet also. We could not achieve reduction. So we have to do a combined approach, posterior first, followed by the anterior approach. So there are so many approaches described in the literature, like anterior posterior anterior approach, posterior approach, anterior posterior approach. But what we follow, that if the close reduction is achieved, then with or without disc disruption, we do only anterior surgery. If unreduced, without disc disruption, we do a posterior lateral mass fixation and fusion only. And in unreduced, with disc disruption, we follow the combined approach, the posterior first, reduce first, and followed by an anterior approach, the disc retrieval and fusion. Thank you for your patience.
Please take a moment from our chairperson.
Please take a note of appreciation from.
Our next presenter is Dr. Alauddin. He will talk on cervical spine injury, fixation by ACDF procedure, or early experience.
So I will request Dr. Krishna Das from Bangladesh to present his paper on outcome of management of, it's a brachial plexus injury management. Dr. Krishna Das, please.
Good afternoon. My topic is the outcome of management of adult traumatic brachial plexus injury. I am Professor Dr. Krishna Das, working in Bangabandhu Sheikh Mujib Medical University as a hand and knee reconstructive surgeon. Anatomy, know well and learn to draw for proper diagnosis and treatment. Throughout upper plexus injury, usually the rupture type, and lower plexus the avulsion type due to the anatomical. And the severity of there are three forms. High resolution MRI of brachial plexus is the investigation of choice for diagnosis, and MRI show either it is the rupture or avulsion. The treatment of brachial plexus injury is to cure occasionally, to relieve open, but to comfort always. Priority of reconstruction is the shoulder stabilization as well as the shoulder abduction, repair at the upper trunk level. If it is, but if not possible the repair, then grafting of the upper plexus. And then if not possible, then transport the spinal accessory up to supraschapulars. The approach, either the transverse incision or L-shaped incision in the clavicle region. And if is the upper plexus injury usually gives the better result in more than 80% of the cases. But if present lately, then need the reconstructive surgery. It is the, even in the older patient, the upper plexus palsy cases also give the excellent results. This is 55 years old, extended upper plexus injury, presented and outcome after surgery. After 1 year, it achieved the shoulder abduction as well as the elbow flexion. Even in the comorbid patient, and female patient also, we get the better outcome in the upper trunk palsy. The 56 years old Armin Akhtar is a COPD, diabetes mellitus and hypertensive patient, treated by nerve transfer and but in case of global palsy, the outcome is different. But the strategy of global palsy is the any available route transfer to median nerve. This is the Ripon Sarkar, 27 years old male patient, presented 3 months old. So there is nothing in the right upper limb and palsy cases. We transferred the spinal accessory to supraescapular nerve and cervical 5 to median nerve grafting and then intercostal transfers to musculocutaneous nerve. Harvesting of the intercostal, up to 5 intercostal nerve we harvest, and grafting of the median nerve with the cervical 5 root by using the sural nerve or medial cutaneous nerve of the arm and forearm. This is the outcome after 18 months. The good shoulder and elbow flexion, achieved, and again wait for hand function. But it takes at least 12 months for intercostal nerve to elbow flexion, because in the 7 months of follow-up, there is nothing of elbow flexion. Seven months there is no elbow flexion, but only but after 18 months the patient has achieved the elbow flexion as well as shoulder abduction. Another patient, Appu Sarkar, also pen palsy cases, transferred the intercostal nerve to musculocutaneous and grafting of the C5 to median nerve and achieved the elbow as well as the shoulder and hand function after 2 years.
Naman, mukhen, Naman.
Up to 5 or 6 intercostal nerve we taken for reconstruction. Another patient of Abul Khair, only flickering of finger movement, flexion was present, but we reconstruct it by grafting of the cervical 5 and 6 root with the median nerve, radial nerve, and transfer the intercostal nerve to musculocutaneous nerve and as well as the axillary nerve. And functional improvement after 18 months. Good shoulder abduction, elbow flexion, and hand function also.
মাছ করো সোজা করো
Hassan Masud also pan palsy case, operated after 3 months, and achieved both good elbow flexion and function, as well as the shoulder abduction is limited. Here we adapted the spinal accessory to supraescapular because we didn't do it primary repair. Initially this was nothing there, pan palsy case, no shoulder movement, elbow flexion, as well as the hand movement.
करें एक तो है ना कौन है ना एक तो ना
But if no route is available, then we transfer the median nerve to contralateral C7. In another patient of Mamun, 21 years old, pan palsy cases, no shoulder, elbow and hand function. We also reconstruct using the intercostal nerve as well as grafting. But if no route is available in the affected side, then we transfer the contralateral C7 to median nerve and also use the intercostal nerve for reconstruction. The excellent functional recovery. 2 years. অপারেশনের আগে হাত দিয়ে কিছু করতে পারতেন?
কিছু করতে পারতাম না, একদম পরে থাকতো।
Complete avulsion of the cervical 5 to T1 route, so no route is available. To transfer the contralateral C7 to median nerve and using the intercostal nerve. This is the functional recovery after 15 months. Hopefully we are waiting for the better function of the hand as well as the improvement of the elbow. Last 5 years I operated 160 brachial plexus, but upper trunk palsy was 120. Total brachial plexus management is still challenging, but proper diagnosis as well as early treatment gives the better outcome, and also ensure the near normal upper limb function as well as the normal life. Thanks for patient sharing.
So now I will request Dr. Alauddin from Bangladesh to present his paper on subaxial cervical spinal injury, fixation by ACDA procedure, our early experience. Dr. MD Alauddin.
Thank you, sir. Respected teachers, learned audience, I am Dr. Alauddin, assistant professor working at NITOR, presenting my case papers. Excuse me. Presenting subaxial cervical injury, fixation by ACDF procedure. This is the place where I am working, and this is the team led by Dr. Rejaul Karim. He is very enthusiastic and perseverance to teach us spine surgery. All of you know cervical spine injuries. I am not here to add but to mention. Overall prevalence of cervical spine injury among all trauma patients is 3.7% globally. 65% of cervical injury is subaxial. In a study conducted in 2019, Mymensingh Medical College, they noted that 1,035 patients with cervical spine injury was found in Bangladesh, published in MMG. Cervical spine injury is a common cause of disability, and it affects mainly young, active male person. Common causes are motor vehicle accident, carrying heavy weight and fall from height, sports, etc. Clinical feature, neck pain, restriction of movement, and varying degree of neurological deficit. That can be complete cord syndrome, incomplete cord syndrome, which are all known to you. You know the mechanism of injury. Usually there is compression or destruction. Compression is associated with flexion, that is flexion, compression, flexion, extension, and destruction with extension injuries. We classify the cervical injuries into occipitocervical spine injuries and subaxial injuries to easily identify and describe the condition. There are many classifications for subaxial cervical spine injuries. All of you are aware of that. The classification are needed to describe the pattern of injury and to decide on further management. We use the SLIC score to determine whether to go for surgery or to go for conservative treatment. Usually SLIC score, when 3 or less, we go for conservative treatment, and 5 or more is surgery, and 4 is indeterminate, mostly depend on the condition of the patient and choice of the surgeon. You are all aware of that. Initial management is according to a TLS guideline with neck immobilization, assess neurological status, check for associated injuries, and after stabilization of patient, then imaging, various form of imaging, X-ray, MRI, and CT scan. Goal of our treatment is pain-free, stable cervical spine, maintenance of recovery of neurological function, restoration of physiological and spinal alignment, bony healing of surgically fused spine. Conservative therapy can be done in less severe cases with traction, early mobilization, and physiotherapy. Surgical approaches can be anterior approach, posterior approach, and combined. I am to note about anterior cervical discectomy and fusion. All of the learned audience are totally aware of SCDF. I do not need to describe the steps, but I want to mention that we have to be sure about the anatomy of the cervical spine and neck to safely do SCDF surgery. We will need CM and fluoroscopy. There is shortage of time. Postoperative care with rigid orthosis for 4 to 6 weeks. X-ray should be done to verify stability. Clinically and radiologically, patient should be assessed. We have an ongoing study on subaxial cervical spine injury with SCDF procedure. Study is ongoing, but we have found that patient improved with SCDF procedure, which is noted with VAS score, ODI score, and then final follow-up. We have case illustration. Patient was done SCDF procedure and improved postoperatively. We have case 2, who is also done SCDF procedure. Patient cervical 4-5 injury. We have done SCDF procedure. Patient could move his 4 limbs on the first POD. Limitation of the study was inadequate number of the patient, short duration, and invaded surgery. And SCDF procedure is a good procedure for subaxial spinal cord injury, cervical spinal cord injury, and thank you very much for your patience hearing.
Thank you, Dr. Alauddin. Please come up here for taking your mementos. And the next speaker is Dr. Mohammad Jiaul Hassan from Bangladesh. He will talk on his experience in Indian Spinal Injury Center, where he will be talking on vertebral artery injury in cervical spine fracture dislocation. Dr. Jiaul Hassan, please.
এক সেকেন্ড চেঞ্জ বাটনটা না আমার হাতে চেঞ্জ করবো Respected teachers, dear audience and national and international faculties, welcome you all to my scientific paper presentation. So I want to start with a scenario. A patient 63 years of age, male patient, came with a cervical spine fracture dislocation. He had a weakness of all 4 limbs. He was alert and he was oriented. It was the MRI. He came with a cervical 5-6 fracture dislocation along with neural structure damage. But after a few hours, something interesting happened. Patient developed confusion, severe occipital headache, as well as diplopia. So we have evaluated the patient, and we have done, as part of the evaluation, we have done the CT scan of brain. And his CT scan showed that there is a thalamo-capsuloganglionic area, there is an infect, and as well as generalized brain atrophy with ischemic changes in the bilateral peri and paravertebral regions. So my patient was having an ischemic stroke along with a cervical spine fracture dislocation. So can this ischemia can be a part of the event related with the cervical spine injury? So we have evaluated the MRI again. We have checked the axial MRI. And here we can see on the left side, there is a loss of normal flow void. On the right side, there is a normal flow void of the vertebral artery as for the blood flow, but on the left side, there is no blood flow and there is loss of the normal flow void. So he was having a left-sided vertebral artery injury along with his cervical spine fracture dislocation. So the study shows that with this kind of event with vertebral artery injury, the posterior circulation stroke was 24% associated with the vertebral artery injury. So one should look for the vascular injury also in cervical MRI, not only the neurological injuries. So my study was incidence of vertebral artery injury in cervical spine fracture dislocation. This study I have done during my spine surgery fellowship program in Indian Spinal Injury Center, New Delhi. So what study says? Study says the incidence of the association of vertebral artery injury with cervical spine fracture dislocation varied from 25% to 46% in modern literature. Unilateral vertebral artery injuries are usually asymptomatic because there is another side, there is another vertebral artery and gets the contralateral circulation. Ischemia caused by bilateral vertebral artery injury can prove fatal for life. So if we look at the anatomy of vertebral artery, it is a paired artery. It starts from the subclavian artery and it is divided into 4 parts. And study shows that the interforaminal, that means the second part of the vertebral artery, is more prone to injury due to rigid fixation of the transverse foramen. So this is the classification of vertebral artery injuries. It can be classified from grade 1 to grade 5. It was my materials and method. I have done a retrospective study in Indian Spinal Injury Centers, and all patients with cervical spine fracture dislocation admitted at IHIC in last 10 years was included in the study. Total sample size was 98, age ranging from 14 to 74, and 80% were male. Cervical MRI was used to diagnose the vertebral artery injury. Usually the T2 weighted image is used to see the flow void. So if we look at the MRI again, in the axial MRI, the red arrow marked side is the injured side which is lacking the normal flow void, and on the right side there is a yellow marked area, that is the normal artery. Here it has a normal flow void. So on the left side there is an injury, and on the right side this is the normal vertebral artery. So out of 98 patients, 18 patients were diagnosed to have a vertebral artery injury, which was 18.3%, which varies in the modern literature. This study showing a 24% incidence of vertebral artery injury, this one showing a 14.75% vertebral artery injury associated with the cervical spine fracture dislocation, and this one showing a 16% injury, and another study showing a 19.7% vertebral artery injury association with the cervical spine fracture dislocation. So most common involved level was cervical 4-5 and cervical 6-7. And most common mechanism of injury associated with the vertebral artery injury was the flexural destruction type of mechanism, which was done by the Allen Ferguson class. And 27% of vertebral artery injury patients were having associated transverse foramen fracture of the cervical vertebra. So, and bifascial dislocation were more common to have this kind of phenomenon. 13 patients were having right-sided injury and 2 patients having a bilateral dissection. 17 patients were asymptomatic, only 1 patient had headache, diplopia and confusion. So more than neurological involvement, Asia A having a most number of vertebral artery injury, it was 11 in number, there was 61%. So vertebral artery was more common in the destructive flexion mechanism of injury. It was more common in the bifascial dislocation, and complete neurological injury were more associated with the vertebral artery injury. So more severe the injury, more chance of VAI. So my take-home message is, surgeon should look for associated injury as also along with the bony and neural injury. Bilateral or dominant side vertebral artery injury can lead to severe consequences like a stroke, vertebral basilar insufficiency, etc. And MRI can be a good screening tool to suspect a vertebral artery injury. So at the end, I would like to thank to my mentors, home and abroad, my mentors from whom I learned spine surgery, ABCD, Professor Shah Alam sir, and I am currently also working with him. I would like to show my gratitude to sir, and also I would like to show my gratitude to my mentor in New Delhi, under whom I have completed my fellowship, Dr. Guru Raj. So thank you all. Thank you for patience hearing.
Thank you, Dr. Jiaul Hassan. Due to lack time of schedule time, we please apologize to no more question and answer. If anybody has any question, have to question it in the dinner time, please. So this is the closing of the cervical trauma session. Thank you every presenter. Good presentation. With these few words, goodbye and good afternoon.
Basically, sir, it was a retrospective. So I already evaluated the data.
May I request Dr. O.Z.M. Dastagir come to the dais as a rapporteur of this session and ask the chairperson of this session. Thank you.
Welcome, good afternoon. Now the scientific session 6, lessons learned from mistake. I welcome Professor Jaidur Rahman sir to chair the session, and Rob I first invite Dr. Ayush Sharma to present his mistakes that we can learn from.
So thank you so much for the invite. So this is another one. This is not from this session. This PPT is from another session, the video talk. Yeah. So anyway, thank you for the invite. You know, it's an honor and a pleasure to be here. I basically practice in Mumbai. I had a spine unit in Mumbai, and right now I am taking over Ranjit, who has to go. Unfortunately, a good friend and colleague of mine. So this was originally the talk for Ranjit, but I had a similar case. I said, why not? I will take it. So that is where I stand before you So my name is not in the schedule, but anyway, I'll by the time they correct the talks, I will be in a position to, take it. So that, we all make mistakes, and, no matter who you are in life, any spine surgeon does make it mistake. They say, if you're not making mistakes, either you are not operating or you are lying. There can be only two sides of mistakes. So if you are not among these two, you of course will make few mistakes, and I am ready to share some of it with you. And also I like to share what I sort of learned from them, or what course I took after doing this mistake. So this is 2014. This is a case, and this is early stage of my career, maybe 10 years back. And this is a 60-year male. He presents with quadriparesis. Of course, there is a case of cervical myelopathy. There's a power was 3/5. Hoffman was positive, and patient has even imbalance in walking. We did what we thought is the best. We did a posterior laminectomy and lateral mass fixation. You can look at the monitor. This is what I had those days. And this is the X-ray. It looks pretty okay. At least I felt I did a good job. He presents to us 1 month, which was uneventful, but we realize he is losing his power. This power, which was 3/5, is now 2/5. We get an MRI done, and the MRI looks very, very peculiar. You can see some cord changes already happening. And this is a 2-year follow-up, and see what has happened to the cord. The cord has gone into myelomalacia. What did I do wrong? I thought I did everything I knew, at least what I knew on that day, and sort of it brought me to I need to know something more about these pathologies. And that is where we started our journey into research in cervical myelopathy. And this is where the journey of knowing something more about myelopathy started. And over the period of next 8 minutes which I have, I'll try to bring what we did, what different we did after this case. So this, we all know the definition of myelopathy. We all spine surgeon. I won't go into detail. But there's one very peculiar thing which happens. If you look at the literature on mean arterial pressure, which is now coming back, and it says you need to maintain a certain mean arterial pressure, roughly around 70 to 80. But that literature is almost absent. No one knows how much to do it, what you should do, how much to maintain. And if you look at some of the guidelines for this, this guideline suggests, and we know that if you have a fall in your neuromonitoring, the first thing you do is to increase the mean arterial pressure. But how does it affect these patients? How does it changes your diagnosis? So we did a randomized controlled trial where we divided the patient into 2 groups. One group, we sort of determined the preoperative mean arterial pressure, and the other group, we sort of increased the mean arterial pressure by 20, and we wanted to see if it makes a difference. There was a big surprise to us. If you see, I don't know if it can show you, even the normal mean arterial pressure for our patient was 85 to 90 degree, 90 millimeter of mercury. So, but just so by keeping those mean arterial pressure between 70 to 80, are you putting them to hypoxia? And then we sort of realized that those patients where we kept the mean arterial pressure higher, they did significantly well, 63.3% neurological improvement in myelopathy. This paper went on to suggest that mean arterial pressure during myelopathy should not be arbitrary. You should pre-operatively measure the blood pressure and then determine a map. And in patient of significant myelopathy, it is better to keep them at a higher rate. And this was one of the award-winning papers in North American Spine Society meeting in 2021. Then the question is, can you do something more about this? Is there anything which sort of helps them? Is the surgery the only solution? Is there anything, any drug which can help this patient? And that brought us to this drug, which is cerebrolysin. This is a purified protein and is a neuroprotective activity and it crosses the blood-brain barrier. Before we did our research, which is published in Spine Journal, the only other paper which talked about it was during the conservative treatment. So based on our research, we recommended a 21-day regime, which we ourselves realize is too much, even if you really need to give this drug. So we came up with our recent paper, which is published again in Spine Journal as recent as 2023, where we have recommended a 10-day drug regime in case of myelopathy, in spite of surgery, and we believe it adds to the benefit of your surgery. Continuing with our journey, we sort of gone ahead and done quite a bit of work on cervical myelopathy, and these are some of the papers we have published in cervical myelopathy. Even we have been able to set some of the current guidelines in treatment of cervical myelopathy. And doing all that, we have also looked at the technology, how technology can help us do a better job, especially when you have cases like this, where if you see the compression is going beyond C2, no matter who you are, it becomes very, very cumbersome to use your ronger, and even if you have burr, to go and undercut the C2, it's always risky. And if you see, most of the time, you might not be able to do what you really wanted to do. That has brought us to use of these modern techniques. So what you see here is a ultrasonic scalpel. This is a specific attachment, which is a claw. You can go underneath the C2 and really cut it as much as you can without actually worrying about the safety or the compromise of your cord. And this is, you can see how much you can go. You can really go underneath it and really take it out. And all your attachment on top of the bone is still preserved. So these, we believe, really helps you to decompress. And this patient was a famous guy, and he is a chartered accountant with a significant myelopathy, and he could not write, so much so that we have to give him a certificate that he cannot sign his signature. Remember, he's a chartered accountant, and this is what we did. And of course, ultrasonic scalpel was used to undercut the C2 completely. And this is a 6 months video. He's making a rangoli, which is on the Diwali. This was, I think, last year Diwali. And now he is on a world tour, and he keeps sending me his beautiful pictures from being almost handicapped to moving all around the world. That is what you get when you sort of do the right thing, the patient. As we started ultrasonic scalpels, we also looked at our own data. If scalpels are really better than the burr, and this is our paper which compares the scalpels to the burr, and we did realize that it does, the use of ultrasonic scalpels really reduces your complication rates. And this is what you can see. There is a significant difference in complication rate. And these are the other difference we found. You are faster with ultrasonic scalpel. The total complication rate, especially the dual tears, will really, really less if you do use the ultrasonic scalpel. And then there's always a future ahead. You have to step forward. You have to go next. And this is now what we are doing. We are sort of navigating our ultrasonic scalpel. So it allows you to do a very, very precise cut. You know the exact incidence or the position of your compression. You can navigate, and what I don't know if you can see better, the navigation can even be integrated with the MRI. So you know exactly where the compression is come, and you can really take a very, very precise cut. So these are some of the cases from those. From those you can see a complete, very well decompressed cord. And I don't know how much you can appreciate, but look, the cut is exactly how much you need. So much so that you really don't need to go in the lateral gutter if you want to take these cuts. So, this is now from 2023, a similar case I started with. This patient has a similar profile, everything similar. And this is what we did, posterior laminectomy, decompression and fixation, exactly what we did with the same case. This is a 1-year follow-up. And this patient has improved from grade 3 to power 4 plus. Only he has a mild instability. And you see, only glaring difference I can see in maybe I kept a BP of around 70 millimeter of Hg here. Here it was 89 based on our own protocol. So maybe there's no way to be certain about this, but maybe a mean arterial pressure gives a difference to your final outcome. So I was asked to share my mistake. I think don't be scared of making mistakes. Remember, a child does fall a couple of times. before he starts making mistakes. Biggest failure is not to learn from your own mistakes. So don't be scared of mistakes. You do make mistakes, but try not to repeat them. Try to learn from them. Try to improve with them, and try to give the best what you can do for your patients. With 22 seconds to spare, thank you so much.
Thank you, sir, for your nice presentation. Now the time is for Dr. Abrar Ahmed from India. He will present his case now. Dr. Ayush Sharma, you are requesting for sitting there, and I will request you to come here for taking your memento, please.
It's not working. Change our channel. It's not changing. Sorry. Go to the first slide. No, first slide. So I'm going to present very unusual cases. There's the cases of spondylodiscitis with epidural abscess, and very, very unusual presentation. So this is the first case, case one. This was a 37 years old male patient. Patient was a diabetic patient. He presented with a chest pain, with a breathing difficulty, fever, with back pain, and difficulty in walking for last 1 month. And on presentation, he had a swelling in the spinal region on the D9, D10 region. Power was 5/5. Sensations were intact. Bladder bowel functions were intact. And in the blood investigation, there were raised DSR, CRP, and TLC. So from the radiology, it looks like there is a infection present, and there is a paraspinal abscess present, paravertebral abscess present. These are the radiological investigations which were done in this patient. And you can see the spondylodiscitis involving multiple levels. There is abscess in the paraspinal region on the left side. Patient underwent D9 minimally invasive costotransvasectomy, debridement with abscess drainage with biopsy. And immediately in the post-operative period, the patient was having severe hypotension. We did all the investigation to rule out all the pathologies. There was a minimal bleeding during the surgery. Ultimately, patient was put on ventilator for 4 days, and after that, he came out of the ventilator. Then again, he developed recurrent paraspinal swelling at L2, L4, and wound exploration and pus culture sensitivity was sent. Now, this is similar to the second patient. The patient is a 64-year-old male, diabetic patient, back pain with a fever for 2 months. He had grade 1 spondylodiscitis, spondylolisthesis with discitis. And these are the radiological investigation. You can see classical signs of spondylodiscitis at L5, S1 level. This was the patient. Sorry. Now the patient underwent surgery at debridement outside, and the bacteria was Burkholderia. This is a biopsy with the Burkholderia pseudomyelinae. Again, the minimally invasive decompression was done in the second phase, and during the surgery, patient had cardiac arrest. We were not able to complete the surgery. Patient was, flipped back. The wound was sutured, and again, the patient continued to have hypotension. Patient was on ventilator for 4 days, and both the common things in both these patients were, both the patients were diabetic, but at the same time, the infection. This is the minimally invasive. This is the intra-op basically procedure. Half the procedure was done, and then the patient was flipped back.
So coming to the thing that both of these patients, they had the similar presentation. Both were diabetic and both were diagnosed with the gram-negative saprophytic soil-dwelling bacilli that is called Burkholderia pseudomallei. It is an intracellular pathogen like Mycobacterium TB and mimics TB. It is endemic to Thailand, Australia and Africa. It is rare in Indian subcontinent. It is hardly reported in eastern India. It is very common in gardeners, farmers, housewives, and very high risk commonly seen in the immunocompromised patient like diabetic AIDS or CKD. And presentation can be acute, subacute or chronic. There is a presenting feature, the fever, skin rash, pneumonia, mimicking tuberculosis of lung with multiple abscesses, septic shock, multi-organ involvement. Neurological involvement is reported in 7% of the cases, which include both the central nervous system and spine. And in the bone, commonly it is the osteitis with the soft tissue abscess. Spinal involvement as pus collection as epidural space is epidural abscess. It mimics spondylodiscitis causing organism as tuberculosis or pyogenic spondylodiscitis. Coming to the history of this organism, it was used as a bioweapon during the Civil War. Both World Wars, as well as the USSR troops used it in the Afghanistan war. It is melioidosis and it is called melioidosis and is common in the endemic regions. And human-to-human transmission is rare. Aerosolized form of the B. malleoli is highly infectious. So coming to discussion, so normally it presents with the fever, back pain without neurological deficit. It is very important why I am presenting this patient is these cases are that whenever you have this sort of infection and suppose you diagnose the melioidosis in the pre-operative period, never operate on this patient unless and until there is an emergency. In every patient, plus we have got the similar sort of presentation in the fracture of the tibia in one of my colleague. Again, the patient underwent surgery. Immediately after surgery, the patient had hypotension and for 4 days patient was on the ventilator. After that, it came out. So there's some way this bacteria causes some sort of release of toxin during the surgery and during general anesthesia. There's some interaction with the anesthetic gases and it leads to persistent hypotension in the post-operative period. So if you have similar sort of infection in the pre-operative period, you diagnose that thing, always treat them conservatively unless and until there is some dire emergency. So to the conclude, early detection, diagnosis, prompt treatment and delay causes fatal consequences. Rapid antigen detection, which is not available in India, it is available in the Western countries, in the Australia, where it is quite endemic. It's quite common in the high-risk category like diabetic, CKD, AIDS, immunocompromised patient. And there's high chances of intraoperative hypotension and high risk of septicemic shock in these patients. Thank you.
Thank you, sir, for your very atypical infection in spine. Now the time is for doctor from UK, Dr. Peter Rivers. I am requesting him for presenting his case.
How do I move the slides? Is it with the here and backwards? All right, okay. Good afternoon, everybody. Thank you, the organizers, for inviting me for this meeting. It's a great honor to be here. My name is Peter Osek, and I'm one of the spinal surgeons in Birmingham Royal Orthopedic Hospital, and we are also the center for primary bone tumors, one of the biggest centers in UK, and this topic is related to the primary bone tumors. So it's actually a case report. Patient, 37 years old female, who presented in local hospital with a radiculopathy in left L1 and L2 distribution, and they have organized the MRI scan, and on the MRI scan the patient was found to have this lesion. At that time, the neurological symptoms were not progressive, so we have decided to start with a biopsy of the lesion, So the biopsy was performed, and the histopathology confirmed Ewing sarcoma. Given that the patient has had still good neurology, we could start the patient on 3 cycles of chemotherapy, and fortunately, the patient responded well to this treatment, and the tumor shrunk. Below and excised the lesion along with nerve roots of L1 and L2, and also with the proximal psoas muscle. The instrumentation was titanium at the time, and the patient underwent radiotherapy in the local hospital afterwards. We follow up the patient, all the patients with primary bulk tumors, we follow up for 10 years. So the first couple of years, there is a follow-up every 3 months with X-ray and MRI scan. So this was the specimen from the surgery. You can see the lateral border of the vertebral body, L1, L2, and part of the T12, and along with TP and psoas muscle. So during the follow-up, 2 years after the surgery, the patient was still disease-free. After 2.5 years, she had a low energy impact and felt something has snapped in her spine. And on the CT, you can see that there is also on the X-ray, actually, you can see there was a broken rod at the bottom of the instrumentation, just above the screw L4. So on the CT, there was not sufficient integration of the bone, so the fusion was not sufficient. So we have decided. Sorry, just can't go. Yeah, sorry. Can I go back? Yeah. So we have discussed the case at the MDT, and it has been decided for a revision surgery. So this time we removed all the metalwork and replaced the metalwork with carbon fiber implants. As you can see here, compared to the previous imaging, we used the pedicles on the side of the vertebra L1, L2, and L3, and also the bottom part because, sorry, shall I? I'll go. Yeah. So you can see there was not only broken the rod, there was also broken the screw of L5. So we have decided for revision, and at the bottom we couldn't use the pedicle screw, so we used the hooks and connected this with carbon fiber implant. We had also the discussion with the patient if we would continue with extension of the fusion to the pelvis, given that she would have had limited mobility in that part of the spine, and she didn't want to proceed with this type of procedure. So revision surgery was successful. We continued with the follow-up, and here is the timeline. So in 2017, we performed the initial arm block excision with posterior instrumentation. Then she had a carbofix revision in January 2019, and this was a follow-up in January 2021. And as you can see on the imaging, on a CT scan, there's a broken rod. Again, it was above the L4 pedicle at the bottom of the construct. She presented with severe back pain, so we completed the investigation with a bone scan, and it showed increased uptake at L3 pedicle, which was deemed to be stress related. So and on the MRI scan, which was important from the oncology view, there was no disease in terms of the original Ewing's sarcoma. So we have discussed the case again at the MDT, and it has been decided, as you can see here on the X-ray, she lost her balance in the lumbar area. So this time we have decided for anterior support. So we did approach the spine from the lateral approach and completed the instrumentation from T12 down to L4, and also supported the anterior column with intervertebral cages at the level T12, L1, L2, and L2, L3. So she's now, so this is the X-ray from the post-op. We restored the lumbar lordosis as well with this type of procedure, and so patient is now 2 years following this instrumentation. She is doing well, so she's almost pain-free, and also the MRI scan follow-up didn't show any recurrence of her original disease. So it was a case with 2 revisions, so multiple revisions, and when we discussed in retrospect what we would be doing differently, so probably we would address more the anterior column reconstruction in this case, and it's mainly because of the resection of the psoas muscle, which also maintains the lordosis in the spine, and I think that this was the part which has failed and needed better support in comparison with only posterior instrumentation. Thank you for your attention.
Thank you all the presenters for a nice presentation. Because of lack of time, we are not allowing any question, we are not inviting any question, because we are lagging behind the time. So now I will request all the presenters to come here for their moment to take. Dr. Ayush Sharma, please. Then Dr. Abrar Ahmed, our best friend from India, Kolkata. Then, oh, okay, thank you. Dr. Peter House from UK. Thank you for your. Now the next session is moderator Dr. Aksadal Anon, and chairman will be Professor Monjur.
This session, our moderator is Aksadal Masur Anon, and chairperson is Professor Dr. Jangir Alam, Secretary, Bangladesh Orthopedic Society. And Hong Wat from Thailand, okay.
Okay, thank you very much, and welcome to you all again, and very good evening here. And another next exciting session is still left. So video presentation. Our presenters are, first presenter is Professor Dr. Muhammad Anand Islam sir, then Dr. Ayush Sharma, and then Dr. Anindo Bosu from India. Okay, I would like to request Professor Dr. Manjullah Kakondo sir to chair the session.
Hello everyone, I'm Dr. Wong Wat from Thailand. Today we start with 5 topics. The first is a video presentation from the Dr. Anowarun Islam from Bangladesh about the microdiscectomy. Okay. Please start.
Okay, take us. Respected Chairperson and Moderator, I am Professor Anwar Islam presenting this case. Actually, it is the video presentation of a case, microlumbar discectomy decompression. কি হয় না তো এই কি হচ্ছে তো তুমি তো এটা দেখালে আমাকে হ্যাঁ yes there are some points regarding this topic that are used in ambulatory surgery, definition of the day case surgery, merits and demerits of them, day case spine surgery and selection criteria and case discussion, take home message. These are in nutshell. Outpatient surgery, actually this is outpatient surgery because term used in ambulatory surgery. Definition of day case surgery, it is the patient was discharged within 23 hours and this is the overnight stay surgery, and within 12 hours it is the day case surgery. There are some merits, significant reduction in medical cost and increased availability of the indoor beds, better comfort and greater control over the patient, and some protection from hospital-acquired infection and rapid return to his work. There are many literature regarding this, but some demerits also. Poor patient and procedure selection, if inadequate information given to the patient, morbidity from the anesthesia and surgery, burden of care first to the family members and community workers. Good organization and management is needed for that. Considering all the merits and demerits, we have planned to perform the day case surgery. There are some literature which shows how to diagnose the lumbar disc herniation, radiological evaluation, this is the parameters of this. Management, conservative, operative, but we are dealing with the surgery, that is operative management. Indication you know all, there is some demerits of traditional open lumbar discectomy. And modalities of MIS surgeries are percutaneous microlumbar discectomy and percutaneous endoscopic transfemoral lumbar discectomy. Regarding percutaneous microlumbar discectomy, less amount of blood loss, less operative time, and duration of the hospital is very, very short. So, considering the merits and demerits, we had performed the microlumbar discectomy as a day case surgery. Selection criteria, you know, according to the signs, symptoms, and some radiological evidence. Now, I would like to show some case examples. Case 1 is presented with the lumbar disc herniation at level. This is the case. The findings are that no bowel blood involvement. The EISL was 3/5, 2 months of history. And he can walk hardly for 5 to 7 minutes. And this is the X-ray FEN lateral view. This is MRI, you just see. This is a paracentral disc herniation. This is the good candidate for that. And axial section shows also right paracentral disc herniation, you just see. Diagnosis was the L45 PLID at the right paracentral. This is some preoperative pictures, case 1. You just see how to identify the space by the image intensifier. And this is a paraoperative microscopic view. And this is case 2. This is also the diagnosis is in the 2-level L45 and L5S1 paracentral disc herniation. One is on the right side and other is on the left side. You just see. Lumbago sciatica due to prolapsed lumbar intervertebral disc at L45 and 5S1. And this is the identification of the space by the image intensifier. And paraoperative microscopic view, just see. Surgeon's team working with the microscope and monitor. Now, paraoperative video. Actually, this is the video presentation. So, you just see the videos of these cases. You just see. Probably sound dite hobe ekটু sound হচ্ছে না কেন? The removal of the ligament of flavum by the Carison, 2 mm Carison. Dura and root retracted medially, you just see. You just see the extruded disc materials. This is the extruded disc materials. Yes. Incision over the herniated and disc materials removed with pituitary ronger. The instrument is 2 mm pituitary ronger. Meticulous hemostasis was ensured by the bipolar diathermy. This is case 1. This is the beauty of the microlumbar discectomy, just 11 hours after surgery. You just see the second case. This is the double level case. You just see the video. Case for microlumbar speculum angulated 30° caudally to address the L5S1 disc level. Now the Casper is angulated 30 degree caudally to address the L4 and 5. You just see how the extruded disc materials come out after retracting the root, easily come out. This is the double label. 10 hours after surgery, the patient can walk. The outcome, this study carried out in 30 cases from 2020 to 2023. Preoperative JOS score was 5.3 plus minus, but postoperatively it is much higher. And VAS score also decreases in postoperatively for back pain and leg pain as well. And out of 30 cases, 40% was excellent result, 43% good and 30% fair. 3 had poor outcomes because there is 2 patients has developed seroma, 1 patient discitis and 1 patient developed foot drop.
He is not present.
Take home message is lumbar microdiscectomy is a safe and effective method to treat unilateral both single and double level paracentral lumbar disc herniated patients as a day case surgery and better prognosis with minimum and considerable complications. Thank you everybody for patient sharing.
Okay, thank you very much for your presentation, for your good presentation, and the video is very clear for microdiscectomy. And the next presentation is in the topic the oblique lumbar interbody fusions in the OLIF with Dr. Ayush Shamans.
From India.
From India.
From myelopathy, let's move to MIS. Myelopathy and MIS are 2 of my favorite topics, and this constitutes almost 70 to 80% of my work. So I will be talking on oblique lumbar interbody fusion. And if you know the direct lateral approaches, why OLIF came into picture is if you remove the psoas, you see this is not just a muscle. It harbors many, these big nerves which you see, they go right through the psoas. And that's why the oblique interbody approaches came where, you know, instead of going through the psoas laterally, you go obliquely, which is a natural corridor between the psoas and the abdominal aorta. And this is how this surgery is done, just to orient you before I show you the video. You go between this corridor, between the psoas and the aorta, and this is a natural corridor. Anatomy has given you this corridor to be exploited, and if you know the technique, you can do it. This is how you do it. You go like this between the abdominal muscle, you reach the psoas, you come anterior, and you sort of put the cage. So you can do any fusion from L2 to S1 can be done. It is one of the best things you can do for degenerative scoliosis. And even L2, 3, 4 corpectomy can easily be done through a OLIF approach. So let's see the video. So this is a single position OLIF. This is where we have done, the whole surgery has been done in one position. You can see there's a patient has a L3, 4 listhesis. You can see some amount of, I think it went back. Yeah, I think it went back, the video finished. So. Can you rerun this slide, please? Sorry. It should be. Can I control from here? That slide is not running. This is a video. Just play this video. Yeah, it's there. It was running, but now I think we have to repeat the whole thing. There is no way to sort of fast forward. So you have to go through with again with the first 30 seconds. So basically this is a 39-year female, presents with neurological claudication. You can see there's a quite amount of listhesis. There is a past lysis in this patient. And there is also some sort of scoliosis, and the PILL mismatch is there. So this is how you position the patient. You put them in lateral decubitus. Your incision is anterior of almost 2 to 3 centimeter anterior to the anterior border of the spine. This is how you mark your incision. This is the cranial end, this is the caudal end. I am standing on the abdominal side of the patient, and this incision is roughly 2 to 3 centimeter. It depends, if you are doing multi-level, you might have to increase the incision. So one of the beauty of this technique, if you see, only thing I will cut during the whole surgery is the skin and the disc, and rest I will splitting the whole thing. So you cut the skin, you get a fascia just underneath the skin, and you cut this fascia. And these are the only things you will cut. And rest, as you go in, you sort of just retract through the muscles. So this is the fascia of an external oblique. Normally this is very, very thick. You cannot miss this fascia, and you really need to cut this fascia. As you go ahead, you get the muscle, which is the external oblique, and you just split it in the direction of the muscle. You don't need to cut it. As you split it, you retract it. Once you retract it, you will see a next layer. And even if you don't remember the name of the layers, just by going through the muscle, you'll see how different they are. And you see this is one layer, and the other layer is just perpendicular to it, which is the internal oblique. And again, you do the same thing. You split the internal oblique. Every time as I'm splitting it, I'm trying to create a plane, just like the way you do in ACDF. You split the muscles and you create a plane. And as you go ahead, you get the next layer, which is the fascia transversalis, the transversus abdominis. Again, it is the third layer, and again it comes in a completely different direction. Again, you split the layer and you just go through it. So all along you are just splitting the muscles, not cutting anything. The last layer, which is a very thin flimsy layer, is the fascia transversalis. You can use your finger to dissect it, and what I am doing is try to create a plane all around it and trying to feel the psoas, because by this time I am here, so I will be able to feel the psoas. You feel the psoas, you push all the peritoneum content anteriorly, and then you go land exactly at the disc space. You can take a Xi'an suit to do this. This is how you will be. You cannot miss the psoas because it is such a big and bulky muscles. At this moment, you can use these long retractors. If you see, they are very specifically designed. These are my own retractors. They go exactly over your finger. So designed like a semicircular. So what happens is, they sort of prevents anything from coming in. Remember, you are in abdomen, all your content will tend to come in your view. So sort of it allows you to keep them all away while I'm still feeling the psoas. I'm sure I'm in psoas because my fingertip is like my third eye. And then every time I'm making sure, because you have a lot of other things out there. You are deep in the abdomen. You don't want to miss the trajectory. And then comes the second retractor system. And under your complete vision, this is the time you sort of go in and see where you are landed up. If you have done the trajectory right, you will see the psoas muscle, and this is what we'll see now. So what you can see here is the thick belly of the psoas. Now remember, sometimes you not only see the muscle, but you can see also a nerve going just anterior to the psoas. So it is very, I don't know if you can see in this video, there's a white cord-like structure just out here, and this is the genitofemoral nerve. That's why you have to be very, very careful while doing this approach. You don't want to mess up with this nerve. If you mess up with the nerve, patient will really have a bad time after the surgery. So if you see here, the genitofemoral nerve is just hugging. This is how the genitofemoral nerve comes like. It is just in most, sometime, especially at L4, 5 level, it is just in the anterior body of the psoas. So you sort of make sure that this goes out of your way for your approach to happen. Remember, psoas is just a muscle like any other muscle. If you do it right, you should be able to retract it. And that is what we will do. We'll sort of mobilize the psoas, retract it completely away from where I want to work, and put the retractor, handheld retractor anterior, making sure that that genitofemoral nerve is sort of has gone out of the way completely. So this is what will happen in next 5 seconds. We are just making sure that nothing is there. And as I have put the retractor back in, the psoas and genitofemoral nerve has completely gone back, being protected all around with my retractor system. And this is the time I'll put my first dilator in. Although this is a dilator based system, so this is the first dilator which is going with a 360 vision all around it, and it goes into the L3, 4, whichever level you do. and then you have a serial dilators. Again, at the same time, you have both the handheld retractors protecting you all around. And this is the time you remove those handheld retractors. And this is the position how the dilator looks like on C-arm, as you can see here. And this is, most of the time it is placed in the anterior 1/3 of the body. And now this is L3, L4. You have some sort of a osteophyte which was just out there. You remove the osteophyte, you see your disc, you start working on your disc. And remember, this is an oblique approach. You are coming obliquely to the spine, but you want to put your case perpendicular to the spine, in the direction of the spine. So if you see carefully, and we'll show you, every time what you do is, you sort of maneuver your hand towards the back of the patient. See, the tubes is directed obliquely, but the instrumentation is perpendicular to the spine. You put your the dilators, you do your disc work like anything you do, anything. And these are the trial cages. They are 45 to 50 mm. They can go up to 16 millimeter in size. And they're really, really powerful. So this is how the instrument goes. This is the angle of your tubes, but the instrument is perpendicular to the body, not obliquely. And that's why it's called oblique lumbar interbody fusion. And this is maybe a 12 size cage. And this is how the cage is. The big part of the cage, it takes in a lot of bone graft. And it can really give you a very, very good lordosis. And remember, your TLIF cage is 22 mm. This is normally 50-55 mm. So it really goes and sits from the one end of the body to the other end of the body. And see how much you have been able to achieve. So this cage is sitting from this end to this end. And as you remove it, this is what you see. This is the cage. And as you sort of remove your retractor, if you remember, we have not cut anything. You have only split things. So everything, all your abdominal muscle, all the fascia, it simply falls back because you have not been doing anything with that. And then in our case, what we do is we, of course, use MIS fix. Sorry. So it just went through the last part. So of course, you can do MIS fixation. What I was trying to show you is you don't really need to put the patient back in prone position. You can do the MIS fixation in the single position with the lateral position as well. So it really saves you time. Any technique is indicated. It does have its contraindication as well. It won't be fair not to tell you about contraindication. Of course, your experience does matter a lot. Don't venture into very difficult case if you're not very experienced with anterior approaches. Previous abdominal surgery, remember, it's a big no because there could be a lot of fibrosis which is happening.
Dr. Aush, time is over.
Yeah, lastly. Yeah. And avoid high-grade listhesis and unfavorable corridor. And just remember this Mickey Mouse sauce, again, you should not take it. And there is something called, this is any anterior surgeon nightmare, there's something called iliolumbar vein, which can go and sometimes come right across your disc space. This again you have to avoid. So if you know your anatomy right, if you have a good 3D orientation with the abdominal anatomy, this is one of the best way to do a lumbar interbody fusion. Thank you so much.
Thank you, Dr. Raj Sharma. Please be seated in the dais. Next case presentation, Dr. Ananda Bosu from India, about the top decompression of lumbar canal stenosis. Please, Ananda Bosu.
Am I audible? Yeah. My heartfelt thanks to the Bangladesh Spine Society for the warm welcome and the hospitality so far. I'm really thrilled to visit Bangladesh for the first time. Do I have my slides here? Yeah. Huh? Which ones?
Close session.
Right. Yeah. So that's my topic, over the top decompression. let's get on with the procedure. Right? What I do is like make a 1 to 2 centimeter longitudinal incision, and that incision is about 1.5 centimeter away from the midline. I do draw the midline first, mark my incision site, and then use the C-arm to start the incision exactly where I want it to be. And docking is a very important thing. I do the docking under the lateral view, and on the lateral view, I go to the, I hit the bone, and then use my tactile feeling to rub over the lamina to feel the facet, to feel the lamina, to feel the base of the spinous process, and then to dock it at the place where I really want it to be. So, and then follow it by sequential dilatation, and after that, I place the tubular retractor, and after placing the tubular retractor, I take a AP at the lateral view to be absolutely sure where that the retractor is at the correct place where I want it to be. Because docking is 90% of the surgery, because without proper docking, you'll always struggle throughout the entire procedure. So this is where you want your tube to be, so that you can see a little bit of lamina, a little bit of ligamentum flavum, so that you can start drilling from the lower edge of the lamina. And this is what your thing should look like under the microscope, and before you start drilling. And so once you start drilling, then you take out the little bit of bone that is required to reach the upper level of the ligamentum flavum with kerrison. Then you start taking out the ligamentum flavum. Reorient your tube, that is very important. You see the patient is tilted here, the patient is tilted here to the opposite side, and the tube is reoriented so that you can look towards the opposite side. You need to do this maneuver so that you can look towards the opposite side, opposite lateral recess. This is very important. And again, then you create the sub-spinous process window under the lamina of the opposite side and take out the flavum from the opposite side. So this is what it is, and you have to maintain stability to maintain at least 9 millimeter of parts. And let us go to the case. This is one of the demonstrable case. So this is the video. So I'm marking my skin incision. You can see. And then before docking, I'm filling all the bony landmarks with the first dilator. And then when I'm happy with my docking position, I use a K wire and mark it over the bone. So I use the K wire because that helps me to exactly locate my docking point and hold my all my retractors at that place. So this is, I am putting my tube over the serial dilators, and then I'm fixing the tube to the table. After that, I confirm the position of the tube using X-rays on the AP and the lateral view, and this is the microscopic view. Then I take the microscope. The little bit of muscle that is there over the bone is taken out with diathermy. Then I start drilling using a high-speed burr. A high-speed burr is very important for tubular surgery. You cannot do these surgeries without high-speed burr. So once you have made the laminotomy, then you use a kerrison to reach the upper level of the ligamentum flavum. Remove as much amount of bone as is necessary. It depends on each individual case. So, some cases you get away taking smaller amount of bone. In some cases, you have to do a little bit of undercutting of the facets so that you get the amount of space that you need laterally to take out the disc and the flavum from the lateral recess. So I'm doing a little bit of undercutting of the facet on the ipsilateral side, as you can see, because there was a disc fragment which I was trying to chase on the right side. So after you have taken care of the ipsilateral lateral recess and the traversing nerve root, so here is the disc space. So the idea is to decompress the traversing nerve root on the ipsilateral as well as on the contralateral side, and also to take away the flavum from the lateral recesses of both sides. That is the goal of the surgery. So as you can see, I've decompressed the ipsilateral traversing nerve root, taken out the disc on the ipsilateral side, and then what I'm going to do is turn the patient to the opposite side, tilt the table, and now that I've done is I've tilted the patient to the opposite side, and I've tilted my tube to direct at the opposite lateral recess. Now I'm taking out the base of the spinous process, and I've gone to the opposite side. You can see that I've gone to the opposite side and taking out the ligamentum flavum on the opposite side, and the opposite traversing nerve root is visible there. So you can see the opposite traversing nerve root. So you have to use your suction to gently retract the dura so that the opposite traversing nerve root is visible. So I've taken out the flavum entirely from the opposite lateral recess, and the opposite traversing nerve root can be seen there. It is free and mobile. So that is basically the decompression that I want to achieve from this. So if we go to so this same over-the-top decompression can be achieved through endoscopy. So this is one of my cases. You can see that there is quite a bit of stenosis and instability. I did an endoscopic TLIF here in this case, UBE. So, but I'll not show the TLIF, but I'll show the over-the-top decompression steps that is to be done in this case. So this is the placement of the portal. There in unilateral biportal endoscopy, there are two portals. One is the working portal, one is the visual portal. So I'm creating the two portals so that the working port and the visual port, they triangulate at the level of the disc space or at the level of the spinolaminar junction. So this is the same arthroscope that we use for arthroscopic surgery. The dilator and the sheath are the same, except for the fact that in arthroscopy we normally use a 30-degree scope. In this, many people do it with 30 degree, but I do it with 0-degree scope because that is useful. Now you can see that I've landed on the Son space, the space which is medial to the multifidus muscle and on the bone. And I'm using the RF, the radio frequency that is used for shoulder surgery is the same RF. And you can see that this is a spinolaminar junction. Now we can see that this is the endoscopic view. So I've located, so I can see, we can see the bone, spinolaminar junction, and they started drilling. So the surgery is similar. Actually, the bone work and then everything is similar. Only the way you do things is a bit different. So now you can see that I'm drilling the lamina as well as the base of the spinous process with the drill. So I'm using the kerrison, the same kerrison punch that we use for open surgeries or microscopic surgeries. I'm using the kerrison to take away the lamina to reach the upper level of the attachment of the ligamentum flavum. Now I'm drilling over the base of the spinous process. So the base of the spinous process and the contralateral lamina has to be, the bone which is necessary to reach the opposite lateral recess has to be taken out. So this is the ipsilateral fascicectomy that I needed to do in this case because it was a TLIF, normally not required for a ULBD or a bilateral decompression surgery. So I've gone to the opposite side. You can see that I've gone through the base of the spinous process and drilling the opposite, taking out the flavum from the opposite undersurface of the opposite lamina. Yeah. So that I'm freeing the flavum. Then again taking out the bone, whatever the bone is necessary to reach both the lateral recesses has to be done. Using the osteotome to take out the ipsilateral IAP. Now you start taking out the flavum. I think I'll overshoot by 30 seconds. That is allowed. So I've started taking out the flavum, you can see.
So on in the time.
Yeah. So let us go. So this is ultimately what you see. This is the opposite lateral recess. You can see that there is the opposite side traversing nerve root. The flavum has been taken out from the opposite lateral recess. And again, similarly, in this is a different case. You can see that I've done the over-the-top decompression and complete the opposite side traversing nerve root is completely freed. And it is very well visible. So the over-the-top decompression can be achieved both by microscopic as well as endoscopic surgery. And thank you for your patient hearing. And I really enjoyed my stay in Cox's Bazar.
So thank you, Dr. Anindo. Please take your respective seat in the dais. And thank you very much all the speakers for a very nice and excellent presentation. We are in shortage of time because another exciting session of the invited guests are still left. And your tea will be served inside the room. Please don't leave the room, please. And before closing the session and moment of presentation, I would like to request Professor Dr. Manjullah Kakanda sir for a little comment.
Thank you. Thank you. The fine, nice three video presentations shown by the three presenters who have enjoyed a lot. The minimally invasive surgery, the idea is to small cut, reduce the perioperative bleeding and also to reduce the postoperative pain. So MEAS is a very interesting procedure in the field of surgery. Thank you the presenters for the nice presentation. With these few words, I am handing the mic to our co-chairman.
So, Dr. Ong Thawat.
I have some comments that, thank you for your three presentations. It's a very good presentation and had some concern about the calcified discs. Sometimes we has hard to deal about this condition that has many surgeons has used it's very difficult for discectomy. That is concerned. Maybe pre-op CT scan, maybe very is important. This is my comment, concerns. Yes.
Okay, thank you very much. This is the time for moment of presentation. Yes, sir.
This is the time for moment of presentation. I will call the Professor Anwar Islam. Please take your memento from our foreign guest. Thank you, thank you, thank you. Professor Anindo. Are you from Calcutta? Thank you. Is your first time in Bangladesh? Thank you. Thank you. Any? Oh, thank you. So with time,
running short of time, so no tea break as well. If someone wants to take tea, he can go alone and again come back here. Okay, the session will be going on.
Sharif Ahmed Junaid. Okay, now I would like to request Dr. Sharif Ahmed Junaid for the next session's report here.
So thank you, Dr. Anand. So due to shortage of time, as already mentioned by our Secretary General, we are going to start our session. May I request Professor Dr. M.D. Shah Alam and Dr. Petri Rusek come to the dais as a chairperson of this session. So in this session, we have 5 papers. So the first paper was supposed to be presented by Dr. Alex Beccaro. he will present on controversies in management of spinal trauma. So, as right now he has been traveling from New York to Los Angeles, that's why we have to run his recorded talk. So, may I request the media to run his talk?
Hi, my name is Alex Vaquero.
Good afternoon, ladies and gentlemen.
Hi, my name is Alex
At the
Vaquero.
time, given that we are going
I
to
wish I
start
could be there. I have the
our
opportunity to speak with you at this esteemed gathering. I wish I could be
Professor
there in person today to talk
Dr.
about
Vivek
and
Sekia
hopefully
is
in the
with me,
future
also
that will be the
co-chairman.
reality.
And we
I
are
was asked today
going
to
to
talk.
start our this session.
The first, first on the list is Alexandro Vaccaro from United States, and the topic is controversies in management of spinal trauma. So we are looking forward to the presentation.
Please start.
Hi, my name is Alex Vaquero. And it is with great pleasure that I have the opportunity to speak with you at this esteemed gathering. I wish I could be there in person in Bangladesh, and hopefully in the future that will be the reality. I was asked today to talk about spinal trauma, current controversies, and clinical challenges. The only conflict I have is that I've been an ardent supporter of the AO, which helped us basically perform most of this research and give us a better understanding of the controversies we face on a daily basis managing people with spinal trauma. If you look at the entire gamut of spinal injury, from the second you see someone in the field to place them in an ambulance, bring them to the hospital, classify their injury, do you give steroids or not steroids? Who is a candidate for surgery, who is not a candidate for surgery? What is stable, what is not unstable? Once you decide to operate, what surgical approach? What type of outcome measure you use? These are all the controversies we face today. The first thing is taking a radiograph. It's extremely expensive for spinal injuries. And do we get a CAT scan on everybody? Do we get plain x-rays on everybody? Do we get an MRI on everybody? And many different facilities don't have the resources. So I think looking at all the different studies like the Nexus and the Canadian C-spine rules, we've come to an understanding that there are clear radiographic risk factors such as age over 65, fall from a certain height, was it a motorcycle accident, was it a motor vehicle collision, was there head injury, is the patient have any type of sensorium loss, and stuff like that. Those are the things that you look at to determine this person needs an imaging studies. And if you're fortunate enough to have a CAT scanner, that's the modality of choice. Now, some facilities have the wealth and can get an MRI scan. And when do you need an MRI scan? I would argue that in the vast majority of the time you do not need one. But in centers that have the ability to use an MRI scanner, it can pick up injuries missed with a regular CAT scan. In this particular study in 2008, there was 21.1% of injuries were missed with a CAT scan only. And if you look on the graph on the side, some of these had to do with the posterior ligamentous complex, the anterolongitudinal ligament, the posterior ligamentous capsule. So they can be significant. So if you have the opportunity in an obtunded patient to get an MRI, I would recommend it. But that is not the standard of care. Neurologic assessment. We see so many patients that come in and appear to be neurologically complete, but a day or two later, they're not. So for any type of studies that we do in spinal injury and spinal cord injury, we like to document every day the neurologic assessment. And usually by day 3, the patient is what they are. And you can use that as a baseline when you do any type of drug study, any type of surgical intervention study, any type of surgical study. Day 3 is when you really, really have an understanding of someone's true neurologic assessment. And then, as I always say, if there's any change for the worse, you have to figure out why. Imaging, release traction, do you have to operate, and so forth. So be wary. Do you give steroids or not give steroids? Well, out there in the world is against steroids. At our institution, many of the older surgeons still give it. I still give it. I followed the Michael Fahling's AO spinal cord injury study published in 2017 that showed there may be a benefit. So as long as there's no harm, an elderly patient with a high cervical spine injury, someone with infection, things that I'd be afraid to give high-dose steroids, I don't give it. But in everyone else, I still give it. One of the most important things we can do in the setting of spinal injury is make sure we have adequate spinal cord perfusion. Get that blood pressure up. That's that, and stop micromotion. And that could be through surgery or traction, but get the blood pressure up no matter how you want to get the blood pressure up. Do you want to put a central line in? Do you want to do a duotomy? Whatever you need to do, get that pressure up and stop the manipulation of the spinal cord. Now I'm going to talk about some clinical challenges. Now if you look closely at this imaging study, this person comes in apneic, hypotensive, unconscious, and just looking at the occipital cervical level, you say to yourself, there's an injury. But everything else is a clue, cranial nerve injury and so forth. Now, it's important to realize that if you miss this injury, these patients can get worse over time. So if you miss an occipital cervical dissociation, and even with a CAT scan, which is very sensitive, if the patient reduces themselves in terms of the occipital C1 articulation, you may miss this. So you see neurologic deterioration at the 35% patients. So keep an eye. These patients are surviving more frequently, especially with rapid mobilization and rapid immobilization. So keep that in mind. And what is the gold standard? I always ask, what is the gold standard? And it's, forget about all the different measurements like the Bayesian to axis interval, Powers ratio, the X lines of Lee. No, just look at the symmetry of the CAT scan. If you see asymmetry between one side and the other of 1.5 millimeters, or if you see a diastasis of 2.5 millimeters, you have an injury. Now, I've seen some CAT scans that were perfectly reduced and only the MRI showed it. So keep that in the back of your mind. When it comes to hangman's fractures, these are relatively stable injuries that are canal widening injuries. These patients can be mobilized in a collar, the vast majority. Type 2, a collar. But there's certain types you have to be careful with. If a patient comes in and they have a Brown-Séquard injury, I automatically think it may be an atypical hangman's fracture where there's a spike of bone that stays with the isthmus that goes back into the spinal cord as the anterior body translates forward. So take a look at this picture. You can see right here where there's a spike of bone. So when the body moves forward, the spike of bone impales the spinal cord. This is a problem, and this patient has to be reduced. It has to be reduced to make sure there's no pressure on the spinal cord. And that was illustrated by a classic paper by Starr and Eisman in the past. So neurologic deficit in the setting of a hangman's, which should be a space-widening injury, look for an atypical. Now, there's certain injuries you do not put traction on. And if you see this injury where you see angulation without translation, you'll have significant disruption of the ligamentum flavum, the posterior longitudinal ligament, and the disc. And if you put traction in this fracture, you can pit the spinal cord. So do not put traction on a type 2A hangman's fracture. Now, another dilemma that we have is stiffening bone disease. These patients decompensate quickly. If someone has neck pain and stiffening bone disease, they have a fracture. Even if you can't see a fracture, they have a fracture. Even if the CT is negative, they have a fracture. So immobilize. They are like a stick. And there's a lever arm above and a lever arm below. It's usually low energy. They have a simple fall and they present with neck pain. And the last thing you want is for that patient to develop a chin and chest deformity 2 weeks later because you did not immobilize the patient. The other thing that really confuses patients is there's a vascular injury to the vertebral artery. So someone comes in, has an unusual neurologic presentation, they may have a Horner syndrome, they may have dysphagia, blurry vision, anything that can affect the vertebral basal system, they have a vertebral artery injury. And you see it with foramen transversarium fractures, you see them with flexion distraction injuries. So you got to have a low index of suspicion for any of these signs or symptoms. Dizziness, vertigo, syncope, Horner syndrome, visual disturbances. They have a vertebral artery injury. And there's many ways of identifying it. You could just look at a type 2 MRI scan, a T2 weighted image MRI scan to see that you don't have to get a vascular study. You can pick this up on normal MR imaging. And we have followed these patients over time, and they tend not to recannulate. So remember, if you have an injury to one vertebral artery, be very careful doing a procedure that may violate another vertebral artery. Keep that in the back of your mind. They do not reconstitute. And the treatment of choice out there is after you do your surgery, placing them on aspirin, and most importantly, bring them back and image them again with a vascular study to make sure there's no dissection. So always bring them back for follow-up angiography. Type 2 odontoid fractures is another controversy. These injuries tend not to heal, and the morbidity of immobilization is usually greater than surgery. So we are very aggressive in surgically fixating type 2 odontoid fractures. There was a study done by the AO, and this was 159 patients, a prospective cohort study. Centers that wanted to treat them non-operatively treated them non-operatively. Centers that wanted to do surgery treated them surgically. And what was surprising was the results. Pain was less if you did surgery, but most importantly, mortality was less by 50% if you did surgery. So we strongly recommend, if someone can tolerate anesthesia, to fix these patients. C2 fractures in general. If you look at Scandinavian countries that have a great registry system, up to the age of 85, these patients do well with surgery. After the age of 85, then it's on a case-to-case basis. Now, the timing of surgery. I think this has been proven through many studies that early is better than late when it comes to spinal cord injury. And this was a study that was published in PLOS ONE. Michael Phalanx was the lead author. A group of patients underwent surgery, early versus late. And what we noticed was that if you operated early, it had a greater effect than age, the administration of steroids, and you had a much better chance of improving in terms of your ASIA grade if you were operated on within 24 hours. So we strongly recommend operating within 24 hours. We recommend the same with central cord syndrome, that you want to get the blood pressure up and you want to operate whenever feasible if possible. So get the blood pressure up, take the pressure off as soon as possible. Do not ignore central cord syndromes like we used to do in the past. Now, the classification systems, we've talked ad nauseum in the past of the best upper cervical, subaxial, thoracolumbar, and lumbosacral systems. They have to be simple, reproducible. They have to allow us to archive the information so we can then follow these patients over time, and hopefully they can prognosticate. I just want to talk about the thoracolumbar injuries because I think this was important. This was one of the first studies that we understood the importance of morphology, the supporting ligamentous complex, and neurology. That originally led to the TLIX system and then the TLIX injury severity score. So basically you look at the morphology. You get a point if there's a compression injury, another point if there's a burst fracture, if there's a disruption of the posterior longitudinal ligament, a ligamentous complex, you get 3 points, and if there's a neurology, if there's an incomplete lesion, you get 3 points, and you add it up, and that scoring system tells us how to treat these patients. The new system we use now is the AO spine thoracolumbar trauma classification system, and that goes from having 4 basic morphologies to 9. You have 5 A fractures, which are compressive, 3 distraction injuries, which are the B injuries, and then translational rotational injuries, which is C. And then we have modifiers. Modifiers M1, there may be an injury to the ligamentous complex, but we can't really tell. And M2 is any other type of comorbidity that allows us to change our treatment plan. And this is one of the first systems that really have a granular neurology, like the patient can be intact, where there can be a transient loss of injury in the field, where they could have radicular or complete or cauda equina. So it's a very good system to archive so we can study treatment modalities over time. Now, clinical ecopause is an interesting concept. Everyone thinks they have the right answer, but everyone is wrong. So what you do is you bring a bunch of cases into a bunch of people that have different opinions. When everyone agrees on the treatment, you knock them off the table. But for those that don't agree, you look retrospectively back and see how they were treated to see, was surgery better or was non-surgery better? And that was a study that was done with Kumar Oner in Holland, where they looked at a bunch of patients, and those that they could not agree on, they looked back and they said, if this person had surgery, did they do better? If this person was treated non-operatively, do they do better? And what they found, after they excluded all the treatments that everyone agreed on, they found out that there was really no great difference between non-operative and operative. There are certain reasons why people did worse, certain reasons why they do better, but the outcome of treatment was comparable, which is interesting. So the bottom line is we don't have any good granular data in the setting of an unstable burst that surgery is in the best interest of patients up until this time, up until that time of that study. So we didn't have the answer until recently. Recently, we did a study with the AO, multiple systems, where we looked at A3 and A fracture, single level end plate fracture, two level end plate fracture, between the ages of 18 and 65. They could have a posterior ligamentous complex injury, and there may be an additional distraction element. We wanted to know which group, non-operative or operative, got better quicker. So an ODI improvement of 12.8%, and then we looked at other characteristics like what imaging features can be correlated with a better outcome. If you did a minimally invasive, did it do better than an open? Long fixation for short fixation. We looked at everything in this large patient cohort. So we had 14 sites. Follow-up was great. We had 213 enrolled patients. And we had 182 baseline CAT scans. And then we sat back and we looked at the data carefully. The questionnaire, as you can see here, talked about what type of fracture, what type of modifications, how much comminution, how much translation, how much cord compression, did you use a brace, what type of brace. We looked at everything. And when we noticed that if we did surgery, the patients improved quicker, the outcome was the same at long-term follow-up, but they improved quicker in terms of their ODI if they had surgery compared to non-surgery. And they also return back to work quicker. So this is one of the first studies that say, well, there may be a benefit to surgery. You feel better quicker and you go back to work quicker. So in summary, both non-operative and operative did well, but surgery got you better quicker. The outcomes were the same in a year. And then the other interesting things, we found that minimally invasive did not do better than open. Open did better than minimally invasive. We looked at length of constructs and so forth. So this paper will soon be published. It's extremely interesting, the findings. We also understand now, just like deformity, that you want to get good sagittal alignment because that does correlate with outcome in the future. And we also found that bracing may or may not be effective. Most studies show that bracing doesn't make a difference. We tend to use bracings for comfort, to sort of modify people's behavior and how they behave after an injury, but there's no hard data that a brace makes any difference. So in my limited time, I went over all the controversies that I see today. What I'd like to know is, what drug cocktail improves spinal cord recovery? How can we regenerate the spinal cord? But I think we've sort of realized that take the pressure off the spinal cord as quickly as you can in the setting of a neurologic deficit, get the blood pressure up and mobilize the patients. So more to come in the future, but again, I want to say thank you for allowing me to speak at this meeting. Thank you.
Nice presentation. Unfortunately, he is on the way to New York to San Francisco. So now he's in the aircraft. So unfortunately, he cannot attend our question and answer session. So we are going to switch over the next speaker. The next speaker is the Michael Fellings. He'll talk on pathophysiology and management of degenerative cervical myelopathy, state of the art and future directions. So please, Michael Fellings, start please. Hi,
hello.
Michael, can you hear us?
Failing. Yes, I can.
He's online. Sound please.
Hi, Professor Fellings. Can you open your microphone? Hi.
Good morning.
Okay. Good morning. Good morning. So we are now going to run your recorded talk. Is it okay, or you want to talk live presentation?
Why don't you run the video, and I will stay online for Q&A.
Okay, that's fine. That's fine. Thank you.
Very good. Very good.
So please run the recorded talk.
Hello. I'm Michael Failings from the University of Toronto, and it's an honor and a privilege to participate in this spine conference. And I think one of the beautiful things that's emerged with virtual technologies is our ability to span long distances and to create connections and friendship. Today, I'll be speaking on the pathophysiology and management of degenerative cervical myelopathy. And in view of the time constraints, I thought I would focus specifically on the challenge of the management of mild degenerative cervical myelopathy. I have no disclosures that will directly impact the content of this talk, but I'm pleased to indicate to you that we have spun off a biotechnology company called IntelliGex, which is moving forward regenerative technologies for central nervous system disorders into the clinic. And at the outset, I wish to acknowledge my friend and dear colleague, Dr. Sharif Jonayed, for the kind invitation to speak at this meeting. So we coined the term degenerative cervical myelopathy in 2015 in an effort to try to bring together a number of various entities that include benign, non-neoplastic, non-traumatic pathologies that in essence result in a slow motion type of non-traumatic spinal cord injury. And the two most predominant pathologies are cervical spondylotic myelopathy and ossification of the posterior longitudinal ligament. The pathophysiology of DCM can be broken down into three areas. So one are the static factors, and there's compression of the cervical cord, which results in ischemia. There are dynamic factors because the spine moves, so there's dynamic compression and axial tension that occur, and this can be exacerbated by deformity or instability. And finally, there are biomolecular factors causing a type of spinal cord injury. These include inflammation, ischemia, and excitotoxicity. We owe a great debt to the Japanese for deriving the Japanese Orthopedic Association scale, which was subsequently modified by Benzel to call this the modified JOA, and then we subsequently validated this. We classify the clinical presentation of cervical myelopathy into mild, moderate, and severe, as shown in this slide. And the MGOA has many advantages and strengths. I will say, though, that one of the weaknesses is that it does not include pain as an outcome, and it's not particularly sensitive for mild DCM. But nonetheless, this is the predominant scale that we're currently using to classify the clinical presentation. In 2017, we issued the first clinical practice guidelines for the management of degenerative cervical myelopathy, published in this issue of the Global Spine Journal. And here is one of the key data slides. And here we have summarized meta-analyses showing the effectiveness of surgical intervention at short-term follow-up within the first year. And here is a forest plot showing the mean and 95% confidence interval, showing very large improvements in neurologic function with surgery. And these results are maintained up to 3 years and beyond 3 years of follow-up. So surgery, in generally, is a highly effective treatment for DCM. And based on this, we were able to come up with very clear recommendations for moderate and severe DCM, where surgical intervention is a recommended treatment. But there's a lot more gray in the management of patients with mild DCM. And here, it's reasonable to offer surgery or potentially careful observation or structured course of rehabilitation, depending on the patient's wishes and presentation and the surgeon's clinical judgment. So mild DCM clearly represents a key knowledge gap and an opportunity for innovation. And we need a personalized approach to manage mild DCM to improve clinical prediction. We need a better understanding of the natural history, improved outcome measures. Microstructural MRI is emerging as an attractive imaging biomarker, and potentially in the future, we may have genetic and serological biomarkers to guide our management decisions. So let me present a case of a 67-year-old woman who presents with an early myelopathy. She presents with neck pain, radicular arm pain, some hand weakness, and she has evidence of corticospinal tract deficits on examination and a broad-based unstable gait. Here are her imaging studies disclosing multi-level cervical spondylosis. So now let's play with this a bit and consider three clinical scenarios. Let's imagine that this person comes in with minimal neck pain, some cervical stenosis, and absolutely no neurological symptoms or signs. So how do we manage this? And, this is sort of, the anxious patient who has some neck pain, gets an MRI, they come into your clinic, very disturbed by the MRI report. Then what about the patient who comes in with neck pain and clear evidence of cervical radiculopathy and cervical stenosis? How are you going to counsel that patient? And then the third scenario is the one I've described, where the patient is complaining of a myelopathy, and this is actually something which is troubling her. Now, how can MR imaging facilitate clinical decision-making? And so we can actually use conventional MRI, and this can help to guide us. And there are a few patterns of MRI signal changes which are concerning. Specifically, a diffuse T2 signal change or segmental T2 signal changes are of concern, as is the coexistence of a high T2 signal change and a reduced T1 signal change, because this indicates actual loss of neural tissue. But we can go far beyond conventional MRI, and we can look at multi-parametric quantitative microstructural MRI. We can look at T2-weighted, T2 star-weighted imaging to assess atrophy and compression. We can look at magnetization transfer ratios to look at demyelination. We can look at DTI imaging to assess axonal injury. And the one that I really want you to pay attention to is this one, T2 star-weighted white matter to gray matter ratio, because this is indicative of demyelination, gliosis, and this is actually predictive of patients with mild DCM who will show subsequent deterioration. And this is the paper that came out in American Journal of Neuroradiology, published by a former PhD student, Alan Martin, who's now on faculty at UC Davis. And so essentially, this metric can be done really on any clinical 1.5 Tesla MRI. You could do this actually in your clinic tomorrow. And I would really recommend this to you. This is a focus issue we put out about a decade ago, really just to summarize where we were with the surgical treatment of DCM. And importantly, this article here by John Reed and colleagues emphasized that a substantial number of patients will deteriorate over time with DCM, but not all patients will deteriorate. Now, this paper by Matz and colleagues, I think, is an important paper. Patients with cervical stenosis who do not have evidence of myelopathy, but have clinical radiculopathy, will go on to deteriorate and should have surgery as the preferred management option. So I think that's an important pearl for you to hang on to. So again, to revisit the AO Spine CSRS guidelines, as we see here, the uncertainty in the area of equipoise, if you will, relates to the management of mild DCM. So in an effort to try to address this knowledge gap, we undertook a big data approach where we were able to take advantage of a number of large prospective data sets to try to assess three aims: to look at the quality of life, the changes in patients with mild DCM, to evaluate the outcomes of surgical decompression, and to identify which subgroups of patients would be most likely to benefit from surgical decompression. So these are the two data sources that we used. We had over 750 patients. This is the publication that emerged from this, and the main focus here was the subset of patients with mild DCM. So one of the points that we see here is that although the doctors rated the patients as having mild impairment based on the MDOA scale, the patients who wish to have surgery rate their the impact on their physical and mental quality of life as quite substantial. And here we see significant impairment in the SF-36 physical and mental component scores compared to the population norms. Surgery improves function, disability, and quality of life in these patients. But the outcomes are somewhat heterogeneous. More than half of the patients did have a major improvement in the neck disability index, and roughly half of the patients had a significant improvement in their health-related quality of life. So who are the patients that seem to benefit the most? And this is a paper here where we used a type of a machine learning approach to cluster the effects using a principal component analysis technique. And essentially what we found is that negative predictors of function are age. By age, really, I think we mean medical frailty in older individuals and significant medical comorbidities. So in an older individual who's medically frail, it may not be the best decision to provide surgery. And then interestingly, patients seem to do better with mild myelopathy when they had an anterior approach, likely because of the impact of pain in the assessment of outcomes. So when you're approaching patients with mild DCM, I think in addition to looking at the MGOA, evaluate their physical quality of life, for example, using the SF-36, and also examine the impact of pain. And a good tool to use here is a neck disability index. And based on this, you can differentiate patients who are responders from non-responders. So how did we manage this patient who came in with early cervical myelopathy? And again, by review the imaging studies. And essentially, my preferred approach here is to do a multi-level anterior cervical decompression reconstruction, which was undertaken. The patient had an excellent outcome and remains well at long-term follow-up. And important to note, mild DCM may not have a benign prognosis. So here's a series of patients that we followed with mild DCM. And over 50% of these patients ended up requiring surgery at 2 to 3 year follow-up. The influence of genetics, I think, will be profound going forward. Most individuals in society have an ApoE3 allelic phenotype. This is a key receptor on the cell surface of neurons and other cells that influences cell signaling. 10% of individuals have an ApoE4 subtype. This increases your propensity to develop Alzheimer's disease. It makes you more susceptible to long-term post-concussion symptoms, and it also worsens the outcome in a degenerative cervical myelopathy. And here's a cohort of patients that we analyzed in addition to preclinical mouse model studies, and here we found that the ApoE4 carriers had a worse prognosis. So very interesting, looking at the influence of genetics. So in conclusion, surgery is safe and effective for mild DCM. Mild DCM is heterogeneous. Patients who are presenting with significant perceived impairment are the ones that you should be operating on, and one should generally consider an anterior approach. The SF-36 can be a useful instrument to discern those patients that have significant impairment in health-related quality of life. So the patient who comes in with neck pain, cervical stenosis, and no myelopathy, careful observation is indicated. Neck pain and evidence of radiculopathy in the setting of cervical stenosis, I would recommend surgical intervention. Neck pain and early myelopathy, I would recommend surgery if the symptoms have an impact on quality of life. And future clinical decision analysis will benefit from new approaches, including machine learning and artificial intelligence, microstructural MRI, and genetics. Just by way of interest for additional reading, I would refer you to this recent textbook that we've published on spinal cord injury, and we have a textbook that will be coming out early in 2024 on degenerative cervical myelopathy. And on that note, thank you so much for the privilege of addressing you today at your meeting.
Thank you very much for the talk. So the next one is Dr. Stephen Lewis, Associate Professor, University of Toronto, Canada, and the topic is Principle of Management of Adult Spinal Deformity, Role of Osteotomy Instrumentation and Fusion Level.
Hi, Luis.
Hello, good morning.
Hi, guys.
Good morning.
Good morning.
How are you?
Appreciate the honor of presenting. I'm going through have a lot to discuss today and over it in some detail here. We're going to go over the principles of management of adult spinal deformity, looking at osteotomies and some of the decision making we do behind some of the instrumentation levels that we use. Had the honor of a very distinguished guest at our place and enjoyed having him work with us and nice to see all the good work that's being done back in Bangladesh. So we'll go over the normal syndrome line, we'll do some radiographic measurements just to get the basic principles, and then we'll go over some of the ways we do corrections and some of the options that we do for addressing some of these deformities. And really to understand how to fix deformities, you have to understand what actually is normal. And I'll just briefly go on that. And it's quite easy in the coronal plane. We should have no scoliosis, should be straight. And in the sagittal plane, it's a little bit more complicated. There's some lordosis, thoracic kyphosis, and lumbar lordosis. And how we have that is trying to, I'll go over some briefly and some of the principles that we use for that. So when we have a scoliosis, we want to make it straight in the coronal plane. But what about in the sagittal plane? So there's a lot of terms that we use, the pelvic incidence, the tilt, and we'll go over some of those in some detail. But you have basically a lordosis that you do. You have to have basically try to get your head centered over your legs. So these are some of the terms that we're going to use, and I'll show you some of the normals that we have for these. So it's all based on the pelvic incidence, which is the angle that the spine and the pelvis make to each other. And this is a personal thing. Everybody has their own pelvic incidence, and it's usually constant through life. And it bases on that is how you stand. So basically, if you have pelvic incidence, it's related to the pelvic tilt and the sacral slope. So the pelvic tilt and the sacral slope can change to compensate, but your pelvic incidence will always stay constant. And based on your pelvic incidence, you'll stand in a different way. So people with a high pelvic incidence will have a little more lordosis and will be able to stand straighter. And someone with a little less pelvic incidence will stand in a different way as well, with a little less lordosis, just to be able to keep their head centered over the pelvis. And there's been a lot of studies to show what the normals are. And basically, we look at a pelvic incidence on average is about 52 degrees. The pelvic tilt for that would be 12 and sacral slope 40. So that's kind of the distribution. And then on average, lordosis is about 45 degrees in general, depending on how you measure it. And thoracic kyphosis is similar, about 45 degrees as well. So let's look at, those are kind of global parameters, and we look at global and segmental parameters. So the Russley classification kind of gives you the differences that we have on the different people, and there's usually 4 types. He's added a 5th type with a 3B, but generally you can see that in the different types, there's a different distribution of how much lordosis you have and how much kyphosis you have. So for the lower types, you have a greater distribution of kyphosis to lordosis, and on the type 4s, you're going to have a much greater lordosis to kyphosis ratio, and most people will fit in the type 2 range. So that's kind of what we see for most people. And you can see a scoliosis here. You can see the red line shows how much lordosis, that the inflection point between the lordosis and kyphosis is quite high. And then when we do our surgery, we're trying to normalize that to a more normal level. And you can see the same here with the very low, with the offset. And you can see by trying to reestablish a type 2 pattern, we give her a more natural curve. Now, to get normals, he did this study measuring 154 university students, and you can see the difference based on their PI. And if you look at the data for a given PI, you can see the distribution that's normal for. So if you had a very high PI, you would have a little less, a little greater PT, pelvic tilt, as opposed to a lower PI where you have less. And the sacral slope generally is about 3/4 or so of the pelvic incidence in a normal situation. And interestingly, the lordosis also increases with your PI, but the thoracic kyphosis is pretty constant. And usually we have about 45 degrees of thoracic kyphosis, no matter what the pelvic incidence is. So that helps us a little bit in establishing what we're trying to do. But when you look at global parameters, we look at the SVA, which is very common, but really doesn't speak for everything. It's really a plumb line from C7 down, and some people will use the T1 sagittal tilt angle and also the T1 PA, which is the line from T1 to the head, compared to where the mid of the 5-1 disc is, and that tries to give you a relative balance of the spine itself. And then we like to keep our pelvic tilt under 25, and there's some relationship to PI minus lordosis, but I think our trend is more to switch to more segmental parameters where we try to recreate normal at the normal levels. Now, this study from 1989 really went over all the angles that we needed for all the levels, and you can see that a minus is lordosis and plus is kyphosis, and you can see this is a set group, maybe a little bit difference, but you can see the neutral thoracolumbar junction and the increasing lordosis that occurs as you go more distal in the lumbar spine, and a pretty normal and symmetrical distribution of kyphosis through the thoracic spine. So you can see here someone fused from the front and they get an anterior compression, and you can see that really brings the spine completely off because the way it was fused did not restore the alignment, and you have about a 30-degree difference from what should be and what is. This is a more recent paper looking at the segmental lordosis, and they looked at it based on different pelvic incidents. And what interesting was is that the L4 to S1 was always about 35 degrees no matter what they did. And then the higher your pelvic incidence, the higher the lordosis in the upper arc or the upper lumbar region. And so when you put them both together, this is kind of really what the true numbers are probably today. Is they're quite similar. But we aim for about 35 degrees from L4 to S1 and some gradually increasing to neutral as you go higher. So this kind of rough numbers that we use, and they're quite similar between the groups, except for perhaps too much lordosis in the earlier Bridwell paper. And then there's an age adjusted. So should we make a 12-year-olds and a 75-year-olds the same? And the ISSG work shows that as you get older, you should accept greater pelvic tilt, greater PI minus LL mismatch, and greater SVA as a kind of a normal distribution of aging. And to really understand how to correct things, you really have to understand how we compensate when we have a deformity. And so you can see for people with very high pelvic incidence, we'll have a much greater range to compensate, where people with low PI do not share that same benefit. And then the three kind of deformities we have would be a thoracic kyphosis, a thoracolumbar kyphosis, and a lumbar kyphosis. And each one's a little bit different. And you can see this is our classic Sherman's kyphosis. And you can see clinically the difference in her lumbar lordosis, how she compensates. And when you fix the deformity, you can see how her compensation through the lordosis doesn't have to be so aggressive anymore, and a much more balanced way of standing. And here's someone you can see just a focal deformity, congenital deformity right at the thoracolumbar junction. And you can see the hyperlordosis that occurs in his thoracic and lumbar spine to stand straight. And just fixing it, you can see how that normalizes quite nicely. And someone with a very low lumbar kyphosis, you can see after a burst fracture, you can see it really unable to compensate for the deformity. And you can see despite significant thoracic lordosis, they have to recruit the pelvis and their legs in order to stand straight. And you can see fixing that deformity brings things back to normal. So we look at patients as compensated or non-compensated. This is a young patient with a deformity, with a spondy and a previous scoliosis. And you can see she stands straight with an SVA that's pretty normal, but she's compensating through pelvic retroversion. You can see her sacral slope's almost zero. And when she started degenerating the levels in between, we addressed her deformity at the same time, normalizing her, bringing her sacral slope and pelvic tilt to more normal levels so that she can stand a little better. You can see someone, an older patient with a kind of a global kyphosis, and you can see a very high imbalance just because he's not able to compensate for his deformity, as opposed to someone a little bit younger who's able to work hard and compensate as best she can to stand straight, even though she does have a fair bit of deformity. And there's another one I learned a lot from, a congenital. You can see how he stands perfectly straight, and very complicated and complex deformity and congenital fusion from his spine. You can see his sacral slope's like close to zero. And then, the concern was that if we'd fix his deformity, he'd be leaning back too much. But this is case shows really nicely how the deformity is compensated through the pelvis. And as soon as you fix the deformity, the patient still stands straight, but with a lot less pelvic retroversion, which makes him much more efficient for walking. And you can see definitely not overcorrected, even though we addressed his deformity through the site. So let's go briefly on how we actually correct the deformities. And we look at deformities, whether they're flexible, whether they're stiff, and whether they're very rigid, and it changes kind of our approach to how we're going to do that. Something flexible, you don't have to do very much. You can just put your rod in. But when it's moderately stiff, you have to decide whether you're going to do some sort of release, either from the front or from the back or with traction or different ways. And when you have kyphosis, you can really do one of three things. You can make the front longer, you can make the back shorter, or you can do a combination of both. And this is the classification for osteotomies that was described by Schwab, divided into 6 types of osteotomies, where 1 and 2 are just posterior column. 1 is just taking off the inferior facet. Type 2 is really our workhorse, and some people call it a Smith-Peterson osteotomy. It'll also considered a Ponte, and some just consider it now a posterior column osteotomy. So it's a release of the really of the facet joint proximal to the pedicle at the level of the disc space, and really opens up and gives you a significant release. When the anterior column is a little stiff, then we look at doing a partial body, which is 3 and 4. So you can either have it a regular pedicle subtraction osteotomy, which is a 3, and a transdiscal version, which would be considered a 4. And then when you have a take out the whole body, that's a type 5, and take out more than one body, we consider that as 6. So these are the different osteotomies, kind of what we're looking for the posterior, the SPO or the type 2. We're looking at something with a mobile anterior column. If the anterior column is mobile, when you close the back, the front will open. When your anterior column is fused, then you're trying to look at something with more of a 3 column that's going to be able to create correction even in the presence of a stiff or fused spine. So this is a classic one for Sherman's, which we use with mobile discs. This is kind of a Smith-Peterson osteotomy that we describe, and you can do we basically separate the superior facet right off the pedicles, do it at multiple levels. I like to use a hook, a central hook. So we put a hook in the spine on top and bottom, put a central rod in, and then squeeze that with the compressor until the correction that we get in the osteotomies are nicely closed. It spares your screws. I usually take this rod off because it gets quite prominent otherwise. And then once it's all healed up, put my bone graft down the middle. And you can see the correction that you get. Very global deformity with a global correction, nice and symmetrical. We can use it for scoliosis. My workhorse for scoliosis as well. It provides the release. And once you have the release, you're able to get the flexibility in the spine to do the correction. So we use it as a release. In this case, we actually create kyphosis with the osteotomy by allowing it to open and distract through that. And that's what Ponte described for his scoliosis. And you can see it works for multiple levels for the deformity. And you can see trying to really work hard to restore the more natural, create the inflection point at the desired level, pick your top and bottom, and then use the rod contour to kind of bully the spine into the correction that you want. When the anterior column is fused, are you looking at doing a closing wedge osteotomy or pedicle subtraction osteotomy? The reason we subtract the pedicle is to create so you don't trap a nerve root in the foramen. And by taking the pedicle out, you're able to create one foramen for the 2 nerve roots. Classic for ankylosing spondylitis with a fused spine in all planes. And you can see we use a CAT scan, or actually you can see the deformity. Knowing what normal is, you can see his thoracic kyphosis up is not too bad. Historical lumbar junction is kyphotic, however, and he doesn't have enough lumbar lordosis. So we target those 2 regions for his osteotomy. So he has double osteotomy, 1 at L1 and 1 at L4. And you can see he restores a nice balanced spine after that. And there's someone with a very fixed deformity at the thoracolumbar junction, with the rest relatively normal. And so we targeted that with the double thoracic osteotomy through there with a nice correction of the deformity. This I put as a 4.5 as a version that we described, a hemi VCR. And I've been doing that for a lot of these very aggressive deformities and taking out the full vertebra. We do kind of a half vertebra resection through these bad coronal plane deformities. And this is an older patient. You can see with a shunt and everything in place with a very high proximal curve. It responded very nicely to this type of correction. And there's a younger girl with a very aggressive proximal thoracic scoliosis that responded well, combining the multiple Smith-Pete's with a hemivertebrectomy at the apex of her deformity. The transdiscal version of the PSO, a type 4, I usually do for infections or trauma. And you can see here's a C7T1 discitis. And you can see how we took off did a PSO at T1, taking off the bottom and end plate of C7, creating this new vertebra of C7 and T1 combined, which healed and really in a nice position with nice correction of the deformity and good decompression of his problem. In the VCR, we're looking at for more multiplanar deformities. It's kind of like if your teeth are crowded, you take one out and then there's more room, and it's kind of the similar principle. So we use it for large fixed deformities, severe multiplanar deformities, and also in congenital deformities. There's a patient with a younger girl with neurofibromatosis with a very aggressive curve, and you can see her 3D image on the CT. And this is kind of what the release looks like. We put all our instruments in place. We surround the mediastinum, going with a bilateral costotransversectomy approach, complete a wide decompression, and then release the discs above and below. And once that's done, then we're able to distract gently on the concave side and remove the vertebra after the release, and then reconstruct it with the rod. So there's a combination of Smith-Pete's with the apical VCR. I use the rib to reconstruct the posterior column, and this is the correction that we achieved for her. And using the rib graft as the thing we published for our tumor resections really restores the posterior column and provides the local bone graft and continuity for fusion in these areas. And we do it for all our posterior column. We reviewed about 81 of our 3-column osteotomies using the posterior column reconstruction technique, and we didn't have we had 3 rod fractures at the site of the osteotomy, which is quite small for these kind of cases. And you can see there's other cases with severe deformities with a VCR is really powerful and be able to achieve the desired release to get the correction that you need. And then for the kind of the type 6, I usually do for more congenital deformities or for infections. So you can see here's a congenital. We took out the hemivertebra plus the one below. In this case, it's kind of a view of the surgery following the release, rod reconstruction, and you can see a nice correction we were able to achieve in a very kind of aggressive deformity with a very focal deformity with a nice clinical result. And then infection with, there's an old TB, and you can see multiple vertebrae fused together, and a type 6 osteotomy performed for him at the apex, providing a nice correction for him, restoring the anterior column with a cage and rods and quite nicely for this kind of deformity. So in general, for all these cases, we look at know your alignments, know what your normal is, know the distribution, use your segmental, and these are the kind of the workhorse kind of principles that we use. I've really switched to more segmental alignment as my deal approach, trying to restore what normal is at that normal level. If you try to create lordosis at levels that really don't need it, it really augments and creates deformities and junctional failures down the road. So understanding the concepts of sagittal alignment, normal compensatory mechanisms is really the key to align these. In the last 5 minutes, I'm going to just tell you about determining levels in adult deformity surgery. So we'll go over that kind of briefly. So how do we determine where to go on the bottom end and where we decide to go on the top end? And, you know, the advantage of being able to stop short of the pelvis and the sacrum is really you preserve one motion segment or two. It's much easier for the fusion. You have outlet motion at the bottom so that there's not so much force through the construct to fail. And also probably protective at the proximal junctional as well. It's a lot less surgery. You don't need as many interbodies. You don't have to go down to the pelvis. So it's less OR time, less blood loss, less transfusions, and less intraoperative complications. If you can preserve a bottom level, it really is good for the patient and good for the surgeon too, assuming In order to do that, though, you have to be able to achieve a very normal alignment in both the coronal and sagittal plane when you're finished. So here's a kind of a 60-year-old with a scoliosis. She had a well-preserved L5S1 level, degenerative 4-5, so we're able to stop at 5 for her. And you can see we restored a nice coronal and sagittal alignment for her, and we've gotten, so far she's 10 years post-op, and I still haven't revised her. She has some degeneration at the bottom, but really doing very well with the extra motion. A different one, a 56-year-old that we did with a similar curve, and you can see a nice result for her at 9 years following with well preservation and no need to go back. So you can see there's another case with a kind of a short scoliosis in an older patient, but a really nice 5-1 disc and a nice 5-1 facet, restoring a normal alignment. You can save the bottom and not have to go all the way down to the bottom. You can see no evidence of any major junctional failures at the follow-up. But you do have some problems. Here's someone, we did a shorter fusion, and you can see a very early failure with a fracture of L5 that had to go down. So you have to be careful, and these aren't always, so looking at patient comorbidities and other things, even though with a nice shorter fusion, we ended up having to extend down to the sacrum and pelvis to address the deformity and the fracture at the bottom. When you do go to the bottom, it's really important to put fixation into the pelvis. It's not enough just to go to the sacrum in a lot of these older patients. So once I go usually about L2 or so, this is a patient that I inherited. You can see she had scoliosis surgery. You can see probably inadequate sacral fixation, and really, while the staples were still in, sustained a fracture right through the sacrum right away. Had to be revised right away with extension to the pelvis. So for long fusions, especially in women with a bit of osteoporosis, make sure that you back these up with either an S2I or an iliac fixation, and often interbody fusions for 5-1. You can see here she's got a deformity, and you can see her thoracic spine is kyphotic all the way through. So there's structural deformity above. So this is one that we're going to fix the thoracic and the lumbar spine, and no evidence of any normal levels at the bottom. So she's going to get a fusion all the way to the bottom with a upper thoracic to pelvis fusion, and she's done quite well. She's about 5 years out right now. So how do you pick the upper instrumented vertebra? Well, I usually go by zone. So below L2, I'm just going to go one level at a time, L3 to S1 or whatever I need. Once I get to L2, though, I don't like to stop. I haven't had good results at T12, L1, and I usually go to either 10 or 11 once I get past the L2. So if I have a zone failure in L2, I'm going to go up to T10, T11, often T10. And then if I fail at the T10 level, generally my next level would be in the T4 range. And then if that fails, I look at the high thoracic, and then after that, I need to go to the cervical. So we look at it as kind of zones. So there's a classic L2 to pelvis that we do, and normal spine above, and I've had reasonable good success with those. You can see someone here with the normal thoracic spine with just a lumbar deformity, and just addressing his lumbar spine is all you need. Here's a pedicle subtraction osteotomy for his post-fracture, central rod closure, and you can see nice alignment, restored his lumbar lordosis, and you can see a normal thoracic spine, so no need to go higher than the lower thoracic region for him. And someone with a fixed deformity throughout the spine as well as in the thoracic spine, we have to address that with going from the upper thoracic all the way down to the bottom. So it's kind of what we're doing. But there are cases where we actually fuse short as well. You can see someone with scoliosis, but really the main problem was a herniated disc at L3-4, which we treated with a fusion, leveling out the disc, which actually leveled out the scoliosis a fair bit as well. And then these short fusions here, you can see a 70-year-old with a degen spondy at 4-5 and 5-1 with bad stenosis. And you can see addressing just the fractional curve at the bottom was enough for her. But when we do that, we try to straighten it out at the same time. So do our best to level out the scoliosis at the bottom end, straightening out those levels. You can see the L4 is much more parallel to the floor in the post-op than it is in the pre-op. So these are kind of the evidence of short fusion. There's a 35-year-old with a lytic spondy at 5-1 and a scoliosis that we addressed her radiculopathies first through the 5-1 fusion, because she would end up with a very long fused back, which she's held off at this point. So you have to use your judgment. Claudication, sagittally balanced, with the main problem at the lumbosacral fractional curve, and we did a fractional fusion at the bottom for that. And similar for someone who's just really not well for a big surgery. We just did what we needed to for the stenosis symptoms at the bottom. So you have to use your judgment. There is a treatment algorithm that was published by Silva and Dr. Lenke that looked over different factors, looking at claudication, back pain, anterior osteophytes, olesthesis, Cobb angle, kyphosis, and global balance. And they gave these 6 levels of when to do just a decompression, when to do just a fusion. And it is an older paper, and perhaps maybe not perfectly, but it would be something that gives you a lot of the principles that would go behind all the thinking that would go, whether you're doing a big surgery or small surgery for some of these deformities. So there's surgical controversies, when to fuse, short, medium, long, 5 versus 1 at the bottom end, how to manage osteoporosis, when do you go to the front, when do you do these laterals, what kind of source of bone graft you're going to use, how to incorporate new technology, and all these things are going to play themselves out over time. But in general, we want to create a balanced spine. We want to decompress the regions that have stenosis. We want to restore our lower arc of lordosis from 5 to 1 and use osteotomies to correct any fixed deformities. So thanks for your attention, and hope it wasn't too long. All the best. Thanks for the privilege.
For answer and question session, just at the end of the presentation of Raja has other, he's online. And our next speaker is Professor Raja Shekaran. No caption to introduce him because he's very well known in this subcontinent and also all over the world. And Professor Raja Shekaran will talk on a kyphosis classification to guide management and surgery. Raja, can you hear me?
Yeah, I can hear you very well. Can you see my screen, Shala?
Thank you. Yeah. So we are waiting for your lecture. So you can start.
Yeah. Thank you, and I would like to first of all express my gratefulness to the Bangladesh Spine Society, Professor Shah Alam and Junaid in particular for this invitation. Today is the day of Diwali in India, you know, the festival of lights, and I bring to all my Bangladeshi friends greetings from the Association of Spine Surgeons of India. I really also enjoyed listening to the great talks by my 2 friends, Mike Fellings and Stephen Lewis, and it was good for me. Now, for the people in South Asia, we know that in every deformity unit, we see as many kyphosis as scoliosis, and sometimes more kyphosis than scoliosis. But if you look at all these cases, we know that they are vastly different in their etiology, the natural history, and also the principles which guide the treatment. For scoliosis, we have the Lenke's classification, and this has helped the surgeons worldwide to use a common language to share data, compare results, and also provide some guidelines on treatment. But however, for kyphosis, this is not available. And we know that grading according to the severity of the complexity of the surgery, we have these 6 possibilities possible to correct kyphosis. So we really do not know or have a clear guidelines in a classification that will guide us to what is the surgery that we should choose. So we thought that we should evolve a classification on sagittal spinal deformities for facilitating a common language and also provide guidelines and help us in our decision making. Now, the basis of this classification is 3. Now, these kyphosis patients differ in whether they have an anterior or posterior column deficiency, and this differs from etiology to etiology and pathology. We also know that they differ from their disc space flexibility and also the severity of the deformity. So we did an analysis on 187 cases which required spine osteotomy and tried to bring about a rationale in treatment. Now, if you see these 3 cases, they are totally different. All of them have a kyphosis, but in cases like ankylosing spondylitis, we do not have any destruction or loss of either the anterior or posterior column. Whereas in a common disease like tuberculous kyphosis, we know that the posterior column is usually intact, but there is a huge loss of the anterior column. And there are some postoperative cases or myelomeningocele that the anterior column is okay, but the posterior column is grossly lost. So depending upon that, we need to look at the prognosis. So type 1 is or cases where there is no column deficiency. And they are divided into type 1A is where there is a mobile disk space and some amount of flexibility is possible. And this is a classic example is Sherman's disease. And type 1B is where the anterior column flexibility is lost, where there is fusion. And here the classic example is ankylosing spondylitis. The important issue here, the differentiating factor is while a Ponset osteotomy may be sufficient in these cases while type 1A, usually we need to do a PSO for the cases of 1B because the anterior column flexibility is not there. So you get an example over here and you can see that just by when the anterior disc spaces are intact, all that you will require is a posterior column Ponset osteotomy. Type 2 is where there is a deficiency of any one of the column. And 2A is where there is a deficiency of anterior column. And this can be either by a tumor or an infection. And 2B is where there is a posterior column deficiency. And the classic example is posterior laminectomy, kyphosis. Now, here, the differentiating factor is in many of these cases, you always require an anterior column reconstruction because when you correct the kyphosis, you will always get a deficiency. And unless there is a very good anterior column reconstruction, you will face a problem. Whereas in most of these cases, you only require in type 2B, a posterior column reconstruction, pedicle screw and rod construction, which will substitute for a posterior column. Good example of this is type 2A, where you can see that there is an anterior column deficiency, and 2B is post-curve. I would like to emphasize here, and I have spoken to many of our friends who come here for fellowship, we should understand that the posterior column deficiency here can either be structural, where there is a loss of facet joint and destruction of the posterior column, or there is a specific type of posterior column loss or deficiency, what I call as the functional posterior column loss by subluxation or dislocation of the facet joints. Now, this is very important because the effect on the biomechanics is the same, whether there is a structural destruction of the facet joint or there is a dislocation of the facet joint. And this is very important to understand because if there is a dislocation or subluxation of the facet joint, then it is not type 2A, it actually goes to type 3 because both the anterior and posterior columns are destroyed. Now, this we have first noticed it in the TB spine, where we found that although the TB actually affects the anterior column, it usually, whenever the kyphosis extends more than 40 to 50 degrees, and especially in children, the facet joint sublux. And we have also described the spine at risk signs, which will lead to collapse completely, as you can see over here in this specimen. It is not just in TB spine, but in this congenital kyphosis, you can find that this patient from 33 degrees to 51 degrees, suddenly over a period of year, progressed to 104 degrees. And then you can see in the scan that the 2 or 3 facet joints are completely dislocated, which leads to this tremendous increase in deformity. Another example over here, this patient who has got just a 28 degrees deformity, but these facet joints are dislocating over here, can seriously progress to 63 degrees and within a few years has gone to 96 degrees. So this is a loss of functional loss of the posterior column, which will lead to a tremendous increase and progress in kyphosis. And when we assess any kyphosis patient, we should not only look at the anterior column, but also the posterior column. So type 3 is a deficiency in both columns. And here you can see that there is a loss of the anterior column and also a loss of the posterior column by facet dislocation. And these are divided into type 3A, B, and C, where 3A is less than 60 degrees, B is more than 60 degrees, and C is again what we have described as the buckling collapse. Now, the reason why we divided it into like this is because in 3A, where the deformity is 60 degrees or less, a posterior column shortening is more than sufficient, and these patients can give a good result. Now, this classification is oriented towards treatment of posterior only surgery, and here you can see that such a deformity like this, you can excise this and close the posterior column, and you get a very good result. A good example is this patient who has got a 51 degrees kyphosis, but it has been corrected completely from the posterior side. And here, there is no problem of kinking or herniation of the cord. However, in patients who have a gross and angular kyphosis of more than 60 degrees or sometimes more than 90 degrees, when we adopt the same principle of posterior column shortening, this can give rise to a problem because there is a sudden shortening, acute shortening of the spinal cord. Sometimes the cord, you can also see, herniates through the laminectomy defect, and this can give rise to a major problem. And here, the principle is that in type 3B, you not only need to shorten the posterior column, but also you need to lengthen the anterior column appropriately so that there is the column, the spinal cord is not jeopardized. Now, type 3C is the buckling collapse. Now, we know that in buckling collapse, there is facet joint dislocation of multiple segments, which leads to a total collapse of the whole column. The superior segment and the inferior segment come to rest on each other, and the entire spinal column above and below is converted to two gross major compensatory curves. You can see that the thoracic spine here is completely lost its kyphosis and become one large compensatory lordotic curve. Now, this is a problem because these vertebral segments get horizontalized. Correction becomes very risky, and we need to be sure that this was our first description of the buckling collapse, the biomechanical principles of it, and what needs to be corrected in 2007. Many of these patients you can't understand that deformity very correctly by X-rays because there is so much of collapse and sometimes there is a gross overlap. In the buckling collapse, there are two types where you can see here that the two columns above and below are actually collapsing and coming one on the other. You can see that these patients develop a lot of pain at this place because of multiple facet joint dislocation. Sometimes they come to rub on each other and form a painful bursa over here, which makes it difficult. And this we have termed it as the anaconda spine. Now, they may rest on each other, or you can see that the columns can sublux because when there is a slip, when the facet joints are dislocated, they not only need to come on each other, but they can also slip on each other. And then there is a tremendous problem as what Boyachi used to call it as omega deformity. You can see that these two columns have completely slipped on each other, and then this becomes a very risky factor to correct. I mean, correction of these is very difficult. It has to be very slow, and you have to be careful over here. The third reason why we described the buckling collapse separately is that these patients should do well with a prolonged period of halotraction. And this will sometimes help you to get the column mobility restored a little bit, and it helps you a lot. Now, this patient came to us, 23 years of age, and her only symptom was exertional dyspnea. And she had no pain, she had no neurological deficit, she was a working woman. And then you could see that her normal SpO2 was 88 and breath count was very short. And the reason for this is very obvious in her CT scan. You can find that T1 is much lower than the upper cervical vertebra. And T6 over here is at the same line of the occipitocervical junction. what happens is that this compensatory cervicothoracic junction actually comes and occludes the thoracic inlet, and then they develop severe dyspnea. In these patients, it is important that we restore the normal anatomy as much as possible by putting them on a halopelvic distractor. In this patient, we have put a halopelvic distractor, but now our current is hallowed gravity traction. And over a period of time, you can see over 6 weeks, you can see that this patient who did not have any neck at all has got her neck completely restored. Her functional respiratory status became very much improved, and then we could fuse her in that position. So what is important in this is whenever you have a buckling collapse, you have to always put them on a halo traction for a long time, and this is quite easy. The other modification that in treatment that comes with buckling collapse is some of these patients are normal neurologically. They have been with this deformity for all their life, and so they are not worried about it. But because of the functional failure of the posterior column and also development of multiple bursas over there, they have severe back pain. I mean, they cannot work more than half an hour, and they have very difficult pain over there. Now, these patients they don't want to take a risky surgery which will jeopardize their neurology, and all that they want is that the pain to go. And in these patients, we have found that just doing a much simpler surgery using a fibular struct graft, you have to take the fibula, 2 fibular structs, pre-drill them, and then you can come from the side, and you can see that this is the 2 column, that this is the pseudoarthrosis between them, and just placing the 2 fibular grafts and filling this whole area with a lot of bone graft makes a solid fusion over there, and these patients are completely cured of the pain which was really worrying them. So this is the classification which we reported in the JBJS in 2008, and we again verified and validated the use of it in guiding what type of surgery is required. In a prospective analysis of 75 patients with sagittal fine deformities, there were 4 surgeons who analyzed the preoperative imaging to classify the deformity, and we had a healthy kappa value of 0.87. I mean, that was quite good to this. The deformity was treated by the following procedures. I mean, these 6 are what is already been described by Schwab classification, and to it we added the 7th procedure called the salvage procedure of anterior strut fusion, when we thought it was too dangerous to go in and correct, when the only presenting problem was pain. So these are the 6 classically known surgical techniques, and to that we added the 7th one of anterior fusion for buckling collapse. Now, these cases were prospectively analyzed for the type of osteotomy, and here you can see what is the etiology. I mean, the etiology was spread all over the pathologies, but most of them were post-tubercular and congenital, because these are the 2 pathologies which can give rise to horrendous deformities. We also had a modifier of sagittal balance, whether it was present or not, and whether there was a coronal, if there was a coronal decompensation of more than 20 degrees, it had a modifier of C1, and if the sagittal balance was lost, again it was M-. So we can see that prospectively we did the surgery, and we found that the mean kyphosis was there, and you can see the number of cases which were classified. So most of them were in type 3B, which is one of the most difficult to treat, bicolumnar deficiency with greater than 60 degrees deformity, and buckling collapse was 5. And these occupied almost 50% of the study. Now, what was important is, now when you looked at the severity of your surgical scale, from the smallest or easiest Pontin's osteotomy to disc bone osteotomy or PSOs, single vertebrectomy, multi-level vertebrectomy, and fibular struct graft, you found in that there was a very good correlation of how the classification influenced what kind of surgery that was required. Now, when there was only when there was no column deficiency, you found that in 1A, where the disc spaces were mobile, all that you required was only Pontes. And in ankylosing spondylitis, where there was no column deficiency, I mean, some of them could be treated in the early cases in Pontes of different etiology. Ankylosing spondylitis required only a PSO. But as in 2A and 2B, also there was no vertebrectomy required. But when you came to 3A, 7 cases required single vertebrectomy and 1 case required multivertebrectomy. And when you come to 3B, you can find that 20 of them, none of them could be treated by just Pontes or PSO. They need a full vertebrectomy or multi-level vertebrectomy. And when you're talking of buckling collapse, 2 of them required multi-level vertebrectomy and then 3 required tubular struct salvage. So you can see that according to the classification, you can give a very good prediction of what will be the type of surgery that is required, and there is a good guidelines for how to choose the osteotomy. Now, when we reported it in the JBJS in 2017, the problem was that it was restricted to a single center, and we wanted to do a multi-center study. And this was taken as Asia Pacific Spine Society directed multi-center research. You can see that many participating centers from Japan, China, Vietnam, Malaysia, and Singapore and India actually participated. And this has been reported in the Asian Spine Journal, where we could find a good correlation, a high kappa value in the way surgeons could classify the deformity, and a good correlation of the type of osteotomy and surgery required according to the classification. So thank you very much for this opportunity, and I bring greetings on Diwali for all our friends from Bangladesh Spine Society. Thank you very much.
Thank you very much for your talk. So shall we go back, please, to the second talk of Professor Fellings. Do we have any questions from the audience, please?
Please feel free to ask any question for Professor Michael Fellings. Okay.
Yes, Mr. Hassan.
So, Mr. Hassan from Royal Orthopaedic Hospital, UK.
Thank you, Mr. Felling, for your nice presentation. As always, you are the master. But my question to you, that one, in the mild DCM, you said that even for a mild symptoms, we will prefer surgical intervention. What are the symptoms you give any preference or any valuation of, if this is the symptoms is there, we will prefer to operate or not?
Yeah, thank you. So, in general, for mild DCM, the guidelines would indicate that there is equipoise between the consideration of surgical intervention versus a non-operative approach. But if you kind of look at the patient factors that will tend to drive patients to wanting surgery, if patients feel that they have an impairment in their quality of life, then surgery will result in an improvement in the quality of life. And a key driver is pain. So if patients are presenting to you and they have significant neck or arm pain, they will tend to favor the decision around surgery, and they'll benefit. And interestingly, both neck and arm pain do improve with surgical intervention. And so I think for the patients with mild myelopathy, in the clinic, you can ask the patient if they feel that they have an impairment in their quality of life. And then you can get a sense of this by looking at their scores on the Neck Disability Index and health-related quality of life measures like SF-36. And if they're impaired, then surgery will be effective. On the other hand, if patients come in with clinical evidence of a very mild myelopathy, but they feel well, the patients aren't going to want you to operate. And the evidence there is not so clear whether you in fact should operate versus careful observation. Yeah, so this is an area of kind of controversy and discussion, and I'm aware that neuromonitoring isn't available around the world. There are guidelines that are coming out from AO Spine and the Praxis Institute relating to the use of neuromonitoring, and essentially, the systematic reviews do show that multimodality monitoring on average has around 90% accuracy in terms of the assessment of changes intraoperatively. And for patients who are felt to be at risk for potential compromise of spinal cord, so for example, high-risk deformity surgeries, if there's significant cord compression, you're doing a decompression, there is a recommendation for the use of multimodality electrophysiologic monitoring. So in Toronto, we're fortunate at the hospital that Dr. Lewis and I work at, where we have very excellent availability of neuromonitoring. So I would say that pretty much all of these cases will be done with neuromonitoring. And for patients who have a severe impairment, usually there's a significant degree of cord compression. If it's available, I would certainly use it. On the other hand, you have to look realistically at the logistics that you have, and I wouldn't stop proceeding with surgery if the monitoring were not available.
Okay, thank you.
So thank you, Professor Fellings, for joining with us. It's a great pleasure for us for joining with us. Thank you once again. Now I am requesting to talk Professor Lawrence Lenke. He is the Surgeon-in-Chief of Newark Presbyterian Spine Hospital, as well as the Chief of Adult Spinal Deformity in Columbia University. Professor Lawrence Lenke, please. Good morning.
Good morning. Hello. How's everyone doing? My friends on Zoom.
Yes.
Shotgun and Dr. Lewis was here and Dr. Failing, so it's great to see everyone. Let me share my screen.
Sure.
Ready? Right. Can you see my slides now?
Yes.
Great. All right, well, thank you for allowing me to speak to you this morning. Again, sorry we can't be live. I do miss the live interaction of meetings, but obviously it is much more practical to do some of these lectures through Zoom now, so thank you for that opportunity. I'm going to speak today about a new classification system of adult idiopathic scoliosis that you'll see is modeled after our adolescent idiopathic system that still over almost 25 years now since its origin is the standard of care around the world for classifying children with idiopathic scoliosis. Now we've kind of adapted this to the adult with idiopathic sclerosis. My disclosures. So hopefully most of you that do deformity in children are aware of this classification system that we developed through the Harm Study Group, published this in 2001 in JBJS. It's a triad system consisting of a curve type, a lumbar spine modifier, and a sagittal thoracic modifier that we all added the triad system together to have a complete curve classification. Instead of having 42 different types, which is really kind of what this entails, we separated out into one of 6 curve types and one of 3 lumbar and sagittal modifiers to make it more easily adopted and used. But the reality is that obviously younger AIS patients who do not have surgical treatment evolve into older patients who often have increasing radiographic progression and clinical disability. And as Dr. Failings just mentioned, can have severe deterioration in the quality of their life, that they come see a surgeon for consideration of operative treatment, as we're well aware. So when we considered classifying the adult with idiopathic scoliosis, we still wanted to use x-rays as the main means of communication. It's still where we begin in identifying that they have a ADIS curve, and obviously we still have to examine and measure and evaluate the x-rays in much detail. But we also wanted to keep it simple, reliable, and modular, similar to the AIS system, because we found obviously that's been very well accepted around the world for many, many years now. And ideally, we wanted to keep it familiar and tie into some of the AIS principles, because again, AIS evolves into ADIS. It's not a separate disease entity, it's just an evolution. So as we are well aware, in AIS, we really look at three regions of the spine that we've quantified for the deformity: the proximal thoracic, the main thoracic, and the thoracolumbar and lumbar. We kind of lump together, and we determine whether these regions, which one is the major curve, the largest, and which of the minor curves, the other two, are structural or non-structural. That's how we come up with the curve types. So what we did for the adult system, we have the same evaluation of the proximal thoracic, main thoracic, and thoracolumbar and lumbar, but we added the lumbosacral region, because as we know, that region, although really never structural in a teenager and an adolescent, can certainly become structural and problematic, and maybe sometimes is the main problem in the adult. So we have to look at 4 regions of the spine, not just 3 regions. So what we did basically is then decide on another 3-tiered or triad system of classification for the adult with idiopathic scoliosis. The first component is the curve type, as you'll see, and it's the same 6 curve types, because the same 6 curve types are there. They're just often larger and more structural. We designate the major curve, again, as the largest curve, and the minor curve. We basically decide on structural criteria using supine and not side bending images. And you'll see that's one of the main components and changes in this system. We don't use side bending x-rays. We just use the supine AP as the determination of structurality. Now, the 2 modifiers are different. The second component and the first modifier is a lumbosacral modifier, as you'll see, which is either determined to be non-structural or structural, again, based on the supine AP image. And then we have a global alignment modifier, where the spine is aligned sagittally, coronally, or combined malaligned based on the standing x-rays. And again, we do this because at the end of the day, overall alignment of the adult in the coronal sagittal plane is of utmost importance in the outcome of the surgical intervention. So again, here's the 6 curve types. They're the same 6 curve types that we see in adolescent, but again, we're determining the structural criteria based on the proximal thoracic, main thoracic, and thoracolumbar lumbar image on a supine x-ray, whether the residual cob measurement is greater than or equal to 35 degrees, or the same amount of kyphosis that we have in an adolescent system. So that's the difference, and we'll go through that. The treatment direction is the same. Obviously, if the curve region is structural, major or structural, we recommend fusing that curve. And obviously, all of these can be done through the posterior approach. We do much more, obviously, posterior approach surgery than anterior surgery in adults, but obviously, anterior surgery through more minimally invasive techniques in the lumbar spine is becoming much more popular throughout the world, as we all know as well. So here's basically how we use the supine image. Here's an upright AP and lateral x-ray on the right and left, and then in the middle is the supine AP x-ray. So we see here the residual proximal thoracic curve measures 36 degrees. The main thoracic curve is the major curves, that's 77. That doesn't really matter, but the thoracolumbar and lumbar residual curve is 56. And both of these residual measurements are greater than 35 degrees, so we call both the proximal thoracic and thoracolumbar and lumbar region structural minor curves. And so we're going to recommend that we basically treat all 3 regions because they're all structural by this system. Now, the lumbosacral modifier, again, is either selected as non-structural if the residual lumbosacral curve from L4 to sacrum is less than 20 degrees, and it's structural if it's greater than or equal to 20 degrees. So on the left, you see is a supine image of a main thoracic curve where the lumbosacral curve measures 8 degrees, so that's non-structural. And on the right is a residual curve of 24 degrees, which is structural. And again, on the left, we're going to recommend not fusing the lumbosacral region, and on the right, we're going to recommend fusing it. Obviously, it's not perfect, and one of the things missing, obviously, as we'll talk about later at the end, is the MRI exam. But again, from a radiographic perspective, this is a pretty useful template for when the lumbosacral region starts to get structural enough that we need to consider including it in the instrumentation and fusion of the rest of the spine. And here's, again, these two examples. On the left, we do not fuse the lumbosacral region. We stop at L4. On the right, we fuse the lumbosacral region along with the rest of the construct. Then the second modifier, third component, is the global alignment modifier. And very simply, the spine's aligned if the coronal and sagittal plumb lines are less than 4 centimeters from the midline. Sagittal aligned, you see if it's greater than 4 centimeters. Coronally malaligned greater than 4 centimeters, combined if both are 4 centimeters or more in their C7 plumb line. Again, a bit simple, and we've moved somewhat past the plumb line now, but it's still relevant and can be used for classification. So again, the new classification system of ADIS, again, is triad, consisting of the curve type, a lumbosacral modifier, and a global alignment modifier to give the triad classification system. One example would be 5 structural lumbosacral regions, sagittal malalignment. So that's basically how we kind of put this together. So we published this in Spine Deformity in 2020. We did both inter and intra-observer reliability. We found very good reliability. And again, these are pre-measured x-rays. So if you understand the system, it's pretty straightforward to understand how to classify by this, both in inter and intra-observer. So here's a patient who presents with a large thoracic curve. As you can see, is a 27-year-old male. He had obviously progressive adolescent scoliosis now to a very severe adult curve. So when we lay him supine, you see that obviously his major curve is quite obvious. That's going to be fixed as a thoracic curve, but it's 132 degrees. The proximal thoracic curve above is 40 degrees, and the lumbar curve below is 16 degrees. So obviously the 40 degrees that's a structural proximal thoracic curve, and the lumbar curve is not. So we're going to basically do a double thoracic curve pattern on here, and the lumbosacral region is obviously non-structural as well. So here we do a T2 to L3. We stop at L3. That's the last touch vertebra. We use the same principle that we use in adolescence as quantifying the center sacral line and the last touch vertebra when we're stopping short of the sacrum and pelvis to do as our lowest instrumented vertebra, LIV. And we obviously also performed a VCR on him for his correction. Here shown both radiographically and clinically at 2 years postoperative. So here's a middle-aged adult presenting with these curves. You see a 35-degree thoracic, 52-degree lumbar, 22-degree lumbosacral curve, fairly aligned in the sagittal plane. So we look at her supine image. The thoracic curve is 27 degrees, so that's non-structural. And the lumbosacral fractional curve is 12 degrees, which is also non-structural. So here, basically, we're left with just a major thoracolumbar curve, which is the type 5 curve. So we basically classify her as the type 5 non-structural aligned. And we just treat the thoracolumbar curve with a short T11 to L3 fusion. So, again, a little unusual, but she's, somewhat of a middle-aged adult. So she came in before her lumbosacral curve was very degenerated. So we were able to just do a short posterior fusion on her for her ADIS curve. So another patient, young adult, 60-degree thoracic, 80-degree lumbar, then 18-degree lumbosacral curve. Yeah, it does have a thoracolumbar kyphosis as well. It's going to make both those curves structural, the thoracic and lumbar curve. But the supine image also shows a structural thoracic curve residual of 57 degrees when she lays supine. And importantly, the lumbosacral curve is only 12 degrees. So that's a non-structural lumbar curve. So the classification system is a type 6, which is a major thoracolumbar, minor structural thoracic curve. Non-structural lumbosacral modifier, and she's balanced or aligned in the coronal and sagittal plane. So she gets a T4 to L4 fusion here at 2 years post-op, showing very nice radiographic correction of her double major curve, and very nice clinical correction also of her severe 3-dimensional deformity. And this last patient, 59-year-old, obviously now more of an older adult patient, coming in with these curves, 18-degree proximal thoracic, 53-degree main thoracic, 85-degree lumbar, 44-degree lumbosacral curve. Here you see she's balanced and aligned in the coronal plane, but malaligned in the sagittal plane. with forward imbalance. So her coronal supine image shows a 42-degree thoracic, 71-degree lumbar, but the lumbar is a major curve. It's obviously going to be treated. And importantly, a 37-degree structural lumbosacral curve. So obviously she's going to need a fusion not only of her thoracic and lumbar structural curves, but her lumbosacral structural curve as well. So her classification system is type 6 structural sagittal malalignment. So the goals of the surgery obviously are not only to fix her thoracic, lumbar, and lumbosacral region, but also get her better sagittally aligned during the procedure. And here's her fusion from T2 to sacrum. We do a unilateral PSO at the apex of her lumbar curve to get the optimal three-dimensional correction and get her sagittally realigned. And here she is radiographically showing very good restoration of normal coronal sagittal alignment following this posterior-only surgery. And this patient who presents with a 50-degree thoracic, 76-degree lumbar, and 17-degree lumbosacral curve. Here, basically on supine image, the thoracic curve is 36, so that's structural. Obviously, the major curve is the lumbar curve, and the lumbosacral modifier is also structural at 27 degrees. So his classification again is type 6 structural, but he's coronally malaligned now. He's sagittally aligned, but coronally malaligned. So he's type 6 structural coronal malalignment. And you see him, interestingly, he's actually autofused at his apex, and he's not very healthy. So this is obviously, we also take in consideration patient's health and other comorbidities to decide exactly what we're going to do. But in him, I decided not to do any 3-column osteotomy, even though his apex was fused. But we were able to get him realigned in the coronal plane and keep his sagittal plane alignment without any 3-column osteotomy, just with posterior column osteotomies. And you see it interbody fusions, T-lifts at the bottom of his construct, and a kickstand rod here on the left side, where we basically push his trunk over to the right to optimize his coronal realignment. You see here post-op that he's very well aligned radiographically, both regionally and now in his global films as well here at 2 years post-operative. So in conclusion, thank you for allowing me to present this new radiographic classification system of adult idiopathic scoliosis, kind of modeled after the well-accepted and long-standing, over 20 year now, AIS classification system. And the components are the same 6 curve types that we see in the adolescent, but again, structural criteria being chosen off the supine AP image, not the side benders. Then the lumbosacral modifier is important to quantify whether the lumbosacral region is non-structural or structural. And a global balance modifier show whether the spine is balanced and aligned in the sagittal and coronal planes. If they're not, then obviously we have to accomplish that during our surgery. There's excellent intra-observer reliability in the posterior treatment, but obviously we're working on now adding a lumbar spine MRI module and modifier for further direction of the lumbosacral treatment, because obviously some of these patients present with also stenosis and MRI degeneration of their spine that needs to be taken into consideration along with the radiographic components. So pretty soon there'll be a 4-tiered system with the 4th component and being a 3rd modifier of the MRI sagittal modifier in the lumbar spine. So we'll be hopefully adding that very soon to the system. So I thank you for your attention, and I'm happy to answer any questions you have regarding this.
Nice lecture. Now the floor is open for question. First of all, I would like to ask the participant for questions to Professor Stephen Lewis. If you have any questions to Professor Stephen Lewis.
Hi, Dr. Stephen Lewis. How are you?
Yes.
Good. How are you doing, Larry?
Good to see you.
Do you have a spine on this?
And what do you think about this system? I'm sure you've heard this before.
Yeah, I think, I say your name after every OR note when I do a pediatric case, and I'd like to do the same in adult cases too. So I was just wondering, what about a spondy modifier at the bottom? Like sometimes we may not have a coronal curve, but we have a degen spondy at 4.5 or even a lytic spondy at 5.1. Is that something you're going to be adding on with your MRI?
Yeah, we started initially with about 6 components we wanted to put in, but I was really worried that, again, that if we put in too much from the beginning, that the acceptance wouldn't be so easy. I learned through the AIS system that we made a modular 3. People can always remember 3 things, it seems like, busy people, but you start asking them to remember 5 or 6 things at a time, and it gets hard for acceptance. And So that's a great point. We have thought about that because you're right. A lot of these patients have degenerative mixed spondylitis at 4-5-5-1. The question is, I think most of those are also seen on the MRI. So I wonder if the MRI modifier can cover that, maybe potentially, right?
Probably.
So again, obviously, then you look at flexibility. Some of those are mobile on standing. So I mean, it depends on how much in the weeds you want to get on this, but. I'm always worried for kind of a global classification system. That if you keep it simple, I mean, I think it's easily accepted from the beginning. We can always add things. So, but that's a great point. Yeah, I think we can certainly. I think if we get this accepted more commonly, that we can keep adding things, and people will. I think it'll be easier to handle the modifications, right? If we get it accepted early on. Also, as you know, I want to use the CADS database to kind of quantify this. These structural criteria that we came up with in the coronal and on the supine AP, those are just mainly my cases. And I want to see what other people are doing, obviously. So we have to modify those. The 35-degree residual curve in the coronal plane and the 20-degree residual lumbosacral curve. That's a bit arbitrary. Just like the side bending X-rays of AIS are a bit arbitrary, but it's a general rule. I mean, the bottom line is I even say in AIS, if you've got a 30-degree residual lumbosacral curve on supine, it's going to be hard not to fuse that curve, right? I mean, most of the time, that's a pretty structural curve versus, if it's 10 degrees, most of the time you can avoid that. So there's a bit of a sway, if it's 19 or 21 degrees, those are tweeners, and you got to really look at other things like the MRI is going to be very helpful, as you know.
Yeah.
So that's why, we may have to modify the criteria, right, based on using a larger database. So we're doing that. That's one of the projects we're doing for CADS, right now to look at that. So.
Larry, can I ask a question?
Sure, Raj. How are you? Good to see you.
Fine, Larry. Yeah, good to see you too. When I was involved in the research commission, there was a new classification coming with addition of all the comorbidities, presence of pain, and by the AO Research Commission. How different is this classification from the other classification?
Yeah, so that's a great point. I'm glad you brought that up because we worked hard on it. I was actually part of the group that I think, Steve, you were part of that too, weren't you?
Yeah, exactly. Yeah, both of you.
Yeah,
actually,
exactly.
both of you were a part of it.
That was a great effort, and I think it's actually I like the system because it's very complete. It's not only radiographic, it's clinical, it's morbidity related. It's so it's basically a comprehensive. Basically it's more meant as almost an evaluation, right, than a classification, an evaluation of the adult with spinal deformity. So from that perspective, it's very, very useful because it forces you. What I like about that system, it forces you to look at all components of the patient, right, the demographics, the radiographics, the outcome scores, the pros, the disability, the comorbidities. But from that perspective, it's you almost need an app. Honestly, it's almost overwhelming. And coming back to the point of when you have classification systems that are simple, right? They're much more readily adopted than when they're very complex. And that's so to me, I like Steve's opinion, but to me, that's more of an evaluation classification than it is a kind of a treatment-based classification system. So, but it's very useful. Unfortunately, I personally don't use it, but I think that you bringing it up to my awareness now, I think that's something we should maybe start pushing more, Steve, because it is very. We did a lot of work on it. And it's very, I think, very useful for an evaluation of the patients. But Steve, what are your thoughts?
Yeah. So. I think it's also very useful, but it has not been adopted, and I think part of it is the complexity about it. I mean, it looks at MRIs, it looks at X-rays, it tries to put whether the patient's fit enough to have a major surgery. So it does meet all the criteria that we use, and it is actually what everybody thinks about that goes into your thinking process when you do your surgery. But it's just very difficult to be able to put the patient in, and I think. I tried to validate it with part of our groups and with other groups, and I think that was very difficult. And so I think the adoption is very difficult. But I do think for most adult spine surgeons who are thinking about doing surgery, to go through this kind of checklist that it provides, it is published, and we could send it to you guys to have it available on your website or whatever, just to see. But I do think the checklist, it goes through all the thinking about all the patients, things that you think about before you actually go ahead with a surgery. So I think it's part of the adoption is the complexity of it and the difficulty in trying to quantify and objectify the data. But it was done by expert opinion. I think.
Yeah, maybe we could use both the ISHG and ESHG, common database, current databases to put a little more data behind it, and maybe that might help become more usable. But I think, and honestly, until I think this is more kind of app-based, where you kind of plug in all the data and it kind of shoots it out at you, that I think it's going to be a little hard for a practitioner to kind of take in all this data, right, and put it into the form that it needs to be. Because there's a lot of data, but that's the positive thing. It's very comprehensive.
Question. Maybe specifically the Klaus from Germany, he's waiting to ask us. To whom you want to ask question, Klaus?
To Steve. Stevie, hey, how are you? Klaus Schnake.
Hi, how you doing?
Hi. Great talks from all of you. Thanks. But I have a question to you, a more practical question. You said in the adults you can sometimes stop at L5, So yes, I agree, but the question is when and what criteria you have. Because if you have a nice disc on the MRI, and you look closely and perform a CT scan, you see most of them have already come of osteophytes, some facet joint arthritis. Some of them even react if you do a facet joint infiltration. So I think in my practice, it's not easy to be brave enough to stop at L5. So can you clarify a little bit what your criteria when to stop at L5 and when to go further down, please?
So I agree with you, and I only have maybe a couple of years that I can actually do that. And they have to have normal discs, and as you say, normal facets as well. And the discs and facets have to be normal, and you have to be able to achieve coronal and sagittal balance really nicely when you're done. And so those are the criteria. So if I can get them straight and they start, we do MRI, CTs, X-rays, everything to make sure there's no degeneration of 5-1 at all. Those are the ones that I've been able to really get a home run with. And I would say that I agree with you. It is very difficult to find someone in their 60s, for example, who has no degeneration of their facets after having a long deformity. But I do find the odd one, and I've been very happy with it and getting. I would say that it's very rare that I have an early failure on them, and most of the ones that we pick, I'm having at least 5 or better years out of them. So, but I do agree, you really have to study the MRI and the CT and make sure that you do have the normal facets and the disc at 5-1.
May I answer?
Yes. Hi.
Classification should lead to somehow for treatment guidance. But if you treat everything from the back, then the question is sometimes, so what is the classification helpful in daily practice? I mean, I personally treat a lot of these cases anterior posteriorly, and I think it's a very viable technique, and reduce the need of multi-rod constructs in the back, etc., etc. So if everything gets treated from the back, according to your conclusion, then what is the big advantage of this classification then?
Yeah, so that's a great question. I think I was a little bit off on saying I treat everything from the back, but the key of the classification system is what's structural, what's not, including the lumbar circulation, right? And so what needs to be treated. So yeah, you can certainly treat, especially lumbar spine. I don't think many adults are getting big thoracotomies and anterior surgery in the thoracic spine, but obviously lumbar spine, they are around the world, we know that. So this classification system basically just tells you, gives you ideas of what's structural, what's not, and what should be treated. And you can obviously treat it however you want. As I mentioned briefly in the beginning, you can treat it certainly anterior as well. We're just trying to designate, whether it needs to be treated in the first place. Whether you go anterior, posterior, or combine, that's really dealer's choice at this point in time, right?
Okay, thanks.
Hello. So, anybody has any question to any specific speaker? No. So, thank you very much. So, Raja, do you have any comment, or Lenki, and also Louis, do you have any comments on any speaker or any talk?
Nothing, just enjoyed listening to all my friends and great finalists. Thank you. Thank you for the opportunity.
Thank you very much on behalf of Bangladesh Spine Society. It's a great pleasure. So all the speakers, so it's on time for few people. It was early morning or very early morning, but you have participated, so we are grateful. and also the Bangladesh, other participants are from Bangladesh and also from abroad. Everybody is really expressing their extreme gratitude to you. So if no comment from the speakers or any participants, then I request my chairperson, co-chair Petro, to conclude the session. Thank you very much.
Thanks for having us, guys. I appreciate the honor.
Good luck with the rest of your meeting.
Thank you very much for joining us at the meeting here, and also to all of you in the audience. And we can now close the session. All right? Thank you very much. Thank you for helping.
So, dear participants, our opening ceremony will be start at sharp 7 p.m. So you all are requested to stay here so that we can start in time. Thank you for joining with us. Thank you.
You are watching Raj TV, Jagorone, Bangladesh.